So good morning everyone, and welcome you all to Device Update 2025, and we hope that this is going to be a great learning exercise for all of us. To begin with, we all have been implanting pacemakers, in everyone's career. So I have been implanting for 20 years. Panja sir is there. He started pacemakers journey in KOLKATA, what I suppose, in 1980s, 1990s, early 90s. The basic, idea about starting this program is to just have a brief discussion on programming, because that is very important. Once we put a device, the device is going to work for the patient, and how the device is working, and do we need to change some programming parameters, how the device is behaving. This is very important. Tips and tricks of programming and some troubleshooting by Dr. Mr. Sabri Vashan. Sabri is kind enough to come here in person. He is always there as a part of device update, Kolkata. So I invite him to give a brief idea about programming of devices, and then our then we'll start our inauguration at 10:30 sharp, and then we'll kick off the remaining scientific agenda. Thank you so much.
Good morning, everybody. At the outset, I thank Dr. Dilip Kumar, who has been running this program for many years, and we are also very honored to be part of this program from the inceptions. So thank you very much, sir, and the organizing committee. So, sir, as you had told us about this, basics of pacemaker interrogation. So evaluation of a pacemaker comes before that, or before you turn the programmer on. First, we have to make sure that we have the history, symptoms, implantation details, and probably ECG, X-ray, everything with us. Because we are not going to treat the device, we are going to treat the patient. We should have the complete idea about what the patient's issues are, and on that basis, we go for the programming. So nowadays, the challenges is every year new algorithms are coming up, and this makes the life difficult because new things are coming up. We should know how they function, and we should be also knowing how and what you should be changing in the programming. So for a standardized method of checking the programming, it has to be consistent and it has to be accurate. So the industry is having something called as PBL stop. So this is understanding the initial situation, how the device and the patient is having functioning, then go into the understanding the device of what it is working, and finally the observations and printing. So this is called as PBL stop. So basically this is to make sure that you understand clearly the diagnostics, then you go for the assessments and program and make the printouts. So this creates a device follow-up routine which will be on complete information of the implant, as well as it could be on a repeatable order. Anybody can do this at any point of time. So this is the full form of the PBL stop. So we will go one by one into it, so I will not go into here. So when you have a standard follow-up, you are going to look at the presenting rhythm. So whether the rhythm is having a hysteresis or normal pacing, capture, follow-up, all this. So you will be looking at the markers, which will be ASVS or ASVP, whichever it comes, because this is something what the device says to you, that what it is seeing. So that the device, whatever it sees, it is putting it, so that we have an idea what we can do about it, because whether the device is correctly doing it or not. Also, the programmers gives you various information, like you can also have the various intervals like AA intervals, VV intervals, as well as AV intervals also. So the initial assessment is always the rate, rhythm, whether pacing or sensing, percentage of pacing, and also from the last follow-up, whatever arrhythmias, PMTs, alerts are there. So now we go to the most important thing about the hardware, the battery status. So you can see here clearly the battery status. It is almost very good. 3 to 4 years of longevity is still remaining. And this gives you an idea like what will be the battery at present. So this estimated longevity is calculated on the situation of various impedances, voltage used for pacing at the present point of time, ultimately the current drain. So the ERI or RRT, also these indicators will come through this. And here a most important person who comes into play in the hardware is the reed switch. The reed switch is the one which actually, when you put a magnet, it actually goes and makes the asynchronous pacing, that is VOO, AO or DOO as per the patient pacemaker programming. Whether it is a single chamber VO, AA or VVA, it goes to VO or AO or DOO as per this. So this helps us to understand whether to replace the generator or we can continue with this. So if you look at the simple thing about the magnet rate, there are three things which come into play. Beginning of life, which is coming to 98.5 in the older generators, 100. This is for Abbott. I will show you the rest of the companies as well soon. And the ERA is the elective replacement indicator when it gives something like 3 months time. So elective means you still have 3 months time. ERA means after 3 months also it is going to have a complete pacing thing. Even if it is, that is, you are pacing at 100, it will give you 100 for 3 months at a rate and as well as amplitudes, whatever your program. Absolutely, you can use this pacemaker for another 3 months without any problems. So after 3 months only, it is going to be of issue. And the last thing is end of service, where definitely this pacemaker has to be replaced immediately. The initial days, they used to call it as end of life, and that was really difficult for the patients to digest. So we changed the name to end of service, that is completely gone. So anybody can tell me what is going on now in this ECG. So as such, we are few people, we can have better interactions. What do you see in this? And you do have an option. So this is a magnet ECG. So not end of service, excellent sir. So this is exactly what the problem is. When the pacemaker, you know it is in ERI sometime back, don't try to put a magnet. So if you put a magnet, then it may drain off whatever little battery it is having, and completely it will be going to asystole because loss of capture can be there. And as I was telling earlier, what I was showing was the magnet rates of Abbott, but industry, we want to confuse you quite very well. So every company has a different type of magnet rates for beginning of life, ERA. So more or less it is same for Abbott and Boston, but Medtronic and Biotronic, they are slightly different from us. So kindly note this, because if you take Medtronic, is 85 is beginning of life, but the same thing is ERA for Abbott and Boston. If you don't have an ID card and if you're going to have a magnet rate taken, then it may mislead. And one of the other important things of a magnet is it also makes it asynchronous mode during a surgery or a situation where you find that there will be a lot of noise. You can always strap a magnet and do a surgery. And only difference will be it is going to be not the same thing the way it ICD when you put a magnet on an ICD. The ICD here, the therapies are switched off and it doesn't go into an asynchronous mode. So this is another thing which is coming up recently. Now people want to hear music, they want to have big earphones, and a big earphone means a big magnet. And whenever they are going to take these earphones quite near to the patient's device, it may go into asynchronous mode, which you can see. There is a slight increase in the rate immediately when the speakers or the headphones of the speakers goes in like this. So it is difficult. This is something which is going to be commonplace. Don't try, the patient should not be trying to keep their earphones because they do have magnets, and this should not be very near the device. So another thing is, which is now commonly coming up, is every iPhone or every phone wants to have loud music. And this is what going to be a trouble when you are going to use, a patient is going to use an iPhone 12 or more. So if it is iPhone 12 or more, there is definitely going to be interference because the magnets in these iPhones are slightly bigger and they can interfere with the patient's device. So the devices usually have something like they need a magnet of 20 Gas. So then they will go into magnet mode. So this is something which is very common. So anybody can tell me what is the Gas of 1 Tesla? We have MRI machines which are 3 Teslas, 1.5 Teslas, and 20 Gas is required for a magnet to take the pacemaker into magnet mode. Any idea about 1 Tesla, how much gas it will be? So it is around 10,000 gas. So you can imagine the magnet of an MRI, which is going to be so powerful, whereas only 20 gas is required to make the magnet go into MRI mode. So that's the reason MRI becomes a big issue. And when you come into electronic interference, especially from the cell phones, usually give the advice that it can be used in the opposite ear from the inside of the implant. But nowadays the devices are all having a lot of filters by which the cellular filters you can use or your patient can use on both the sides. That should not be an issue. So now we are in the PBL stop, PB we have seen. Now we go to the lead impedance. Very interesting place. So this is one important thing which will give you exactly what is the problem in the device, especially in the leads. So if you see this patient is having an impedance of near 1000 and slowly it has come down to a point where it has gone to 50. So what could be the issue here? So basically this is something called as insulation failure. So when the insulation starts breaking at points, this is the issue where the impedance goes to 200 or lower than 200. It is something like this. Your lead is leaking energy. And this is like a pipe which has a broken pipe. The same way the insulation is broken, it starts leaking energy. So when this is the number of electrons when the lead is perfect, and when there is an insulation break, it goes down. And this may lead to loss of capture. So nowadays we always talk about AA. AA is something which everybody wants to put in all our things, and it is taking over most of our jobs as well. But we do have AA in the device as well. So in case if there is an impedance which is less than 200, the device immediately transfers itself from a bipolar lead to a unipolar lead. And the same thing, if there is a breakage in the lead, also it transfers from the unipolar to, that is bipolar to unipolar. This is an automatic polarity switch which automatically happens in the device. So we saw the impedance when it was low. Now the impedance is high. This is basically because there is a high impedance because there is a coil fracture. And this is something where you can see it is not moving at all. It's completely gone. So electrons come here, they can't transfer themselves over there. So this is something which is the problem which is going to be there. So when does it happen? Oh, there is one more question. So anybody can spot any problem in this? This is an explanted device. You know there is an explantation sometime back. Why it could have been explanted? Think on that. And what is the problem you see in the picture? You see a break, sir? It looks almost okay. And this is what the problem always you will have. The patient will come to you, he will say that I had a syncope, I had a fall, but when you take the X-ray, the fluoro says it's almost okay. So, though the doctor spotted the thing, it was 5,000 ohms when the patient was interrogated. So 5,000 ohms means it is definitely a lead crack. But it's very difficult for you to see this in this picture. It is something like this. The bridge is there, but it is breaking. And there is a reason because there are so many wires, that is multi-filar wires. Even 1 or 2 wires are there, it is still going to conduct energy. So ultimately when the bridge totally breaks, then only you start seeing the impedance going up. So this is the issue. Again, the autopolarity switch will work here and you will be able to see there was a real break. But we did not spot because in X-rays probably it will not be revealed. So for this you have to move your arms, provocative measures, so that you will be able to reveal this fracture. So this happens especially in a rib clavicle fracture. Over a period of probably a year or 2, you will be able to see this fracture almost totally gone. So these sort of things can happen whenever there is a problem, it automatically switches from bipolar to unipolar. So this is how it is, the construction. You see there is an outer coil and the outer insulation, inner coil and inner insulation. And if you have a unipolar, it uses only the inner coil and the inner insulation. So in this situation, it will be using it bipolar like this, which is between the tip and the ring. And when it is going to be unipolar, it is going to be inside from the inner coil to the can. But there is a lot of problems. That's the reason the unipolar was not used. And one of the problem was this. So if you see in the first picture, the doctor saw EGM, that is the first one is a ECG, second one is an atrial egram, third one is a ventricular egram. That is showing noise, ECG is showing noise. And he did something here and totally the noise was gone. He did just one programming change. What could have been the programming change? So you see there is a lot of noise and one programming change. Noise gone. It is not lead change, it is programming change. So we were looking at unipolar and bipolar. Unipolar always catches a lot of noise. So this was inadvertently programmed in unipolar and they changed to bipolar. The noise itself was totally gone. So that is the beauty of bipolar. But unipolar, you have these problems. This has to be encountered. And also there is also one more problem which can come through, which...
You're trying to show muscle twitching.
Yes, sir, yes, sir. Yes. Yeah. Yeah. So, yeah, exactly, sir. The insulation break, especially at the pocket, or if it is a unipolar, you can also have the same thing. So this is the reason why physicians have completely avoided unipolar, gone to bipolar, but can be useful as a temporarily savior medication when there is an outer insulation or outer coil is gone. So now we come to the second part, the stop. So the first is sensing, and basically to see what is the height of the R wave and the height of the P wave. So why we need this sensing? Because only with this sensing, the device is able to know what's happening in the heart, whether it is sensing a good R wave or a good P wave or it is gone, so that the pacemaker has to start pacing. So the difference between a EGM and a ECG is, EGM is something which has picked up the lead and only a small part of myocardium. Whereas the ECG is a global one which sees the whole P wave, R wave, T wave, everything. So this is going to be the difference between an EGM and an ECG. So you can see here, a EGM is only seeing the atrial activity in an atrial egram. Whereas in ECG, you see the whole, the heart is complete. So this is the difference between this. And this is the way it actually looks at. And it looks at it and measures this height. So if the height is going to be good enough above your sensitivity wall, then you will be able to see this. Anybody can tell me what is this you see here? It's just for fun. Don't think it's difficult. No technicalities in this. So Hina says it's a leaf. Okay, let's say whether it is really a leaf. This is the beauty of nature. Nature has created so many camouflages. So this is one camouflage which is a butterfly. So this is exactly what we undersensed. We thought it was a leaf, but it was not that. So anybody can tell me what's going on here? You can see there are pacing pulses immediately after an R wave. So this is something which is a problem. So it is not seeing this R wave and it is giving a pacing pulse over here. And what could be the problem here if it is undersensing? You may hit the, because this was an R wave which was hiding inside the sensitivity, but sensitivity was programmed wrongly at high amplitudes. So now, is there a problem if you have undersensing? Yes, you can start a tachycardia, R on T phenomena, or pacing pulse on T wave, which can be this. So if you leave a patient with a pacemaker with undersensing on like this, so what you will be called as? You will be called as James Bond 007. Why? Because James Bond has a license to kill. So the same thing with the undersensing, you may end up the patients with death. So this is another example of where it was unnecessarily pacing and getting into it. So now we have another picture. So you can make your comments on this. You see a boy and a girl very close by, romantic scene. Sorry, it's not. It is just two people passing on the side. So earlier we undersensed, now we have oversensed. So this is a problem of failure to pace can happen whenever there is a oversensing. So it could be because of various algorithms also, like hysteresis, rest rate, sleep rate, or a PVC. And oversensing is also another important thing which we should take into account. And if you see here, you clearly see there is a lot of noise, and the device thinks there is a lot of R waves, and it is inhibiting its own pulse, thinking there is already there is a good rate, why it should pace. So this could be a problem when you have oversensing. So oversensing can lead to underpacing, and this could be because of a poor signal or a lead issue, battery issue, or a functional undersensing or a sensing circuit issue. So basically it is something like this. You have kept the sensitivity wall low, and you are seeing the T waves, R waves, and other extra signals. So again, we do have AA and pacemakers. So whenever there is a problem of high or a low amplitude R waves, the device using an algorithm called sensibility manages to reduce the sensitivity wall according to the height of the R wave. So that this is also something which you have to be in the device that does. But when you want to know that it is really a brake and you don't see the brake, and you move the arm, you do like this and you reveal a brake, and you may end up having an asystole completely. So we have to be doing these maneuvers very carefully in this also. And anybody knows what is this maneuver for? It is not a lead issue. The issue is something else. There he used this. So this Namaskar maneuver is basically used to find out myopotentials. So this is one thing which you will be stressing your arms, because there is no lead issue. It is only a stressing issue. So myopotentials can be coming. So now we are gone into the second part, threshold. So thresholds are very important because patient safety is important, because anything and everything in this pacemaker is useless if it is not able to capture. So this basically is a low amplitude or sub-threshold. That amplitude is sub-threshold. It is not able to capture. So we have to look at certain things, not only the amplitude, it could be a sensitive setting also. This could lead to loss of capture. So if you look at this picture, what will be your answer for this? Why this lady is having so much injuries? Fight with her husband? Capture failures. So you got the answer without me telling it. So very difficult that she would have got a fight with her husband or a neighbor or a robber. So this was exactly the none of the above. And I will just go to the case study. It was an 83-year-old woman who had a gastroenteritis recently, was admitted in the hospital. And if you look at the trend of the thresholds, it was normal almost up this place. Suddenly it started going up because electrolyte imbalance, gastroenteritis. Yes, sir. Doctors cleared it up, and slowly it came back, or immediately it came down and became normal. But the problem is when the threshold was increasing like this woman went for a fall. And the injury was basically because of that fall. So these are the things which can happen because we never know when the threshold is going to increase or not. So we do have AA, and this AA was not come here. It came in 1995 itself. So it is an auto capture which makes sure that whenever there is an increase in threshold, it increases the amplitude on its own. So this makes sure that beat-to-beat safety of the patient is always there. So failure of capture can be because of various reasons: lead dislodgement, myocardial or drug issues, battery damage, completely ERI, EOS, inappropriate programming, and capture management failure. If it is a capture management failure, don't worry, auto capture is there. Now we go to the O, that is observation. So this is very important because the device is something which you have put inside, and this is always looking at the heart, and this is going to give you a complete information like Sherlock Holmes. It's a super spy, secret spy, which we have implanted along with the pacemaker. So it is looking at the heart all the time, and if there is anything which is going to be a problem, it immediately informs the doctor. So If you see in this particular picture, you see something different? Any problem? First to A to C. Good. I think. Yes, sir. You are right. So there is a completely gone through the heart and out. So perforation, and this would have lost capture completely. So these are things what our Sherlock Holmes or device is going to give you alerts immediately. In case if you have a remote monitoring, immediately it is going to give an alert. If it is going to be something like where you don't have a remote monitoring, only when you are doing a programming, you will get this alert. But anyway, the device gives all these alerts and you will be able to take care of this programming. So this Mona Lisa is not good. Let us clear it up. So this is exactly what a programming can do with this information of diagnostics. So much of diagnostics, I need not go into that, but everything is there. And now we come to the last part of the B, stop and P. This is printouts, and that is basically whatever you have observed, whatever you have seen there is a problem, and whatever you have changed, everything you document. So tomorrow you yourself will be able to easily identify it, or probably some other physician is going to get that. He will be able to know what was the issues before this patient's programming was. So with this, we complete the PBL stop. And sir, I just take 1 minute. That's it. Okay. So this is what it is. So we started with the presenting rhythm, battery status, lead status, and how the sensing went on, how the threshold was there, observation data, and how we programmed and printed out. Oh, there is one more important thing. What is that? The paperwork. This is the most important thing which you should have for a subsequent long-term follow-up. So you know very well paperwork is very important. So this is what we are going to do so that the next doctor who is going to interrogate will have a clear idea about all these things. So no more ECGs, no more EGMs, and no more magnets. Thank you very much for the opportunity you have given me, sir. So any questions, I'll be happy to answer. Thank you, sir.
I want to ask one question. Can we have hand mics, please?
Hello, check.
Thank you, sir. I want to ask one question. If for any reason I have changed the programming mode of a patient which was previously put on DDD pacemaker to unipolar mode, and now I want to do an MRI, can I switch to VO asynchronous pacing mode and do an MRI in unipolar mode? Because in bipolar mode patient has some problems.
Sir, it will not allow you to do an MRI scan, because when you want to program the MRI settings, it is very important that it has to be a bipolar lead. So, because usually the bipolar lead, why you switched into unipolar? Probably there was insulation break, there was a coil breakage, so it may be leaking energy, and that will cause a lot of problems. So that is the idea behind MRI settings. And just because you asked it, I'll just ask you one more question. Why is this MRI setting so important?
MRI setting is important because if the electromagnetic interference leads to the oversensing and leads to the loss of capture kind of thing.
Very good.
Goes in arrest.
Excellent, excellent. So never ever send a patient to MRI without programming the MRI settings. And if you send the MRI to programmer just VO mode or DO mode in normal programming, you may end up with the patient with a power on reset or backup VVA. That is a common thing which you will see as a complication. So whenever you send for MRI, always MRI settings has to be programmed. Even if it is an MRI pacemaker, don't bother, it has to be programmed.
Okay, thank you.
Yeah, so we have got a dedicated talk on MRI and pacemakers. So what we have seen is there is a patient admitted in surgical unit, non-cardiac surgical unit, and then patient has to go for an MRI, and company rep, they investigate, they program, they integrate the device and they write a comment. This device is not MRI compatible. MRI can't be done. So this is a wrong notion. There is a recommendation also now which has come up. All existing pacemakers, we can definitely do MRI if we program the device. to a pacing mode. So, because the safety has been seen in many studies and the guidelines also endorsed now, so I think we should get away with the idea of, writing there by anyone that MRI can't be done. Obviously, there are situations like we just discussed, or abandoned lead, or some freshly implanted pacemaker. So there are some situations where we can't allow, but majority of the times we can allow, showing some risk that although it is not MRI compatible, this much risk can be there, which is very, very less, but we can go ahead with what is your,
So what you say is practically very right.
Yes, same.
So you,
Devices which are at the end of life. Yeah. There you cannot program it. Absolutely. Yeah, absolutely. These are, but those which are not MRI compatible, any of the devices we can go ahead. That's why we have kept a talk here also. Yeah.
So whatever you are saying is practically right, sir. But what we do about is the evidence-based medicine, where the rep can't give a writing that can be done in
but
MRI.
He can't also write that categorically it can't be done.
Because as
So
far as
the
we
decision
know,
has to be taken by the implanting physician.
Yes,
Considering
exactly.
the risk. That's what it
so
should be written.
the risk versus
Yeah.
benefit is in the physician's hand.
Absolutely. And no, the patient keens are being convinced that no, you can't do, you shouldn't be doing like that. So this we should do away with these kind of words and sentences.
So
by company
generally
doctor,
what
yeah.
we do is we always tell the patient to talk to the doctor, because whatever we say may be misconstrued and the patient may come to you with a different
Thank you.
thinking. So
Thank
we
you.
never entertain the patients.
Thank you, Sabri.
Thanks.
It was indeed wonderful, and you made us, the device, Sherlock Holmes, James Bond, and what else? Thank you so much. So I think before we, look for any journey, we try to have blessings from the Almighty, and then with our seniors, and that's what we are going to do. We will do a lamp lighting and a formal, a short inauguration ceremony. So may I request Dr. Panja sir, Dr. Robin Chakravarti, Dr. Sudeshna Lahiri to come on the stage. Anupam, Dr. Anupam, Dr. R.D. Yadav, please join us. Sanjeev, please come. Where is Sabha? Can we have a Saraswati Bandana to start with, and then we can have lamp lighting?
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमा
Thank you. So I request Dr. Panja sir and Dr. Ravin sir to say a few words and bless us for this upcoming events.
So first, good morning to everyone, all my friends, and I'm very thankful to Dilip Kumar and Arvind Chakra to organize the meeting. And you know what is need of indication of the patient, everything. You see, total implantation done in India, 40% Eastern India. Among the 40%, 90% Bengal. Keep in mind. Highest incidence of pacemaker. Why it is? We work out, you see, etiological aspects are unknown, but we postulated that we have also conducted tissue study on rabbits. We have proved it that some enough role for the urusuric acid which contained in the mustard oil is responsible for that. So the burning problem. Apart from that, cause is unknown. So therefore, during my stay in the FSCAI hospital for 1965 to up to that 2008, our total implantation done 19,500. That was presented by me, Singapore World Congress of Pacing. So there is a great problem in Eastern India, particularly Bengal. So that is very important. So I'm thankful. So starting we used to use the single chamber pacemaker initially. 90% SSCAI during my stay, that is single chambers. But dual chamber only 10% because of the financial constraint. Now just reverse. Everywhere there is the 90% is that is the dual chamber pacemaker. Now only 10% hardly single chamber. But that is the evolution. And now so many things, micron and the leadless pacemaker coming up. Already ICD and CRTD last prior to the transplantation is very important issue. So make us a bridge for transplant. So there is a rapid development of the devices in India as a whole. We are thankful to all the industry organizing and helping to us to upgradation knowledge to the program. I am thankful to Dilip, and he is the convener and organizing secretary, and he is assisted by Robin Chakraborty, is the advisor. Thank you very much indeed for present hearing.
Is because of genetic factor. It's a progressive cardiac conduction disease, which if you do genetic study, because most of them present 50 years, 55 years, below 60 years, so with complete heart block. They come with bifascicular block, trifascicular block, and then complete heart block. So mostly they are progressive cardiac conduction disease, sodium channel defect. What I feel, genetic disease. So the work is on.
Yeah, Western countries, these presented in the World Congress of Cardiology Singapore. Our incidence, I told, that is bifascicular block with the recurrent syncope, highest indication. Dr. Father of the pacing, the department asked me, our country, Western country, incidence 6-signer syndrome. I mean, no, we are reluctant to place the 6-signer syndrome. No question of prophylactic pacing until there is recurrent syncopal attack. So that is, they used to do the prophylactic pacing, their incidence, Western country, that is a complete heart block, and is because of 6-signer syndrome. But our country, bifascicular block, recurrent syncope, this is the indication. Okay.
So we have some work, I think, done by Dr. Panja sir himself. Mustard oil consumption and uric acid considered to be one reason. We did, we called all our pacemaker patients in 2018-19, myself, Sanjeev, Devrato, and we took their dietary habit, their origin, where they native of West Bengal or they migrated here, and we also got some blood tests, and what we found was strontium was higher in these cases, level of strontium. So there is one report which is published, and we are tying up with a center in Raipur where heart block is very less common. Smith, who is doing around 100 angioplasties in a month, he says he does 1 or 2, 3, very less than 10 pacemakers. And I went to Srinagar to do a micra, and then I got to know that there are a huge number of pacemakers happening. So we are collaborating with 3-4 centers, and we are also planning for some genetic studies and PETs. Let's see what happens. But we are there to dig it out. Yeah. Sir.
Yeah, thank you very much. Firstly, I must congratulate Dilip Kumar, my colleague, who works 26 hours a day. So, and despite such a busy schedule, he is so enthusiastic and passionate to organize this device update every year. And this year is no exception towards this. Why it is important? Because if you look at the journey of this pacemaker story, it started the first pacemaker in the world. Do you know what was the size of the pacemaker? This big was the pacemaker. And then, to keep one person alive, that person was this much, pacemaker was this much. And he used to push the device, and he walks the device, somebody has to push to keep him alive. From there, it has come to micro, like a capsule pacemaker, as we see leadless today. So this is the journey. And in this journey, just not only the heartbeat, so many other things like arrhythmia detection, timing, MRI compatibility, so many technology have been taken into it. So this is an interesting thing. So every year when this happens and when I attend it, I actually see and learn that a lot of things are there. When I was given a talk, I have to read and then say, oh my God, it is not just update, it is updating myself. That is why I think this meeting is very important. So please continue to do that. And I think it should be done in a broader perspective at national level, so that I'm sure this is one area which I always felt is a little bit ignored, because people talk more about cardiovascular intervention, but arrhythmia and rhythm management, particularly the bradyarrhythmia device therapy, needs more and more physicians' input, physicians' intake, physicians' understanding to update our knowledge and to pass the benefit towards our patient population. That is important. The other thing what is happening, as you all know, from the update point of view, I'm sure that it will come up very soon. Now all the devices, I can see the industry people are here, they are also trying to incorporate AI in the algorithm, that how AI can actually change the understanding of pacemaker, a lot of battery thing, the durability of the battery, the precision of the shock therapy in ICD, precision of the pacemaker sensing and pacing has to be improved, and for that the AI incorporation would be perhaps very much important. So this week actually, after 3 days time, there is a company coming up as an Indian company with a global platform, and they are trying to incorporate AI in that. This gentleman is a very qualified master degree in AI from United States. He is trying to build up this company, and we had a long discussion yesterday. So I'll be there to be with him and trying to see whether we can incorporate AI and develop the pacemaker and device technology in particular, especially the detection of arrhythmias, and also because a lot of to minimize the heart rate, to detect the arrhythmia, to deliver the shock, these are the things which are coming up, but it will take a lot of time because validation, standardization, these are required. So we are in the very preliminary stage of this. So I'm sure that in 5 years' time, you will see the devices are not only leadless, not only tiny, there are a lot of update, a lot of incorporation like artificial intelligence and other things will certainly improve your patient's quality of life and the fear attached to pacemaker implantation. So please continue to do that. And I wish this meeting to be a great meeting, a continuous meeting, a successful meeting. And I personally thank all the people who are supporting such endeavor by Dr. Dilip Kumar every year. Please continue to do that. With that, may I have a wonderful meeting, and I'm sure that you will all enjoy your session. Thank you very much.
Thank you, sir. So let's begin with the first session of today's program. And may I invite the chairpersons and the moderator. May I request Dr. Sumanto Chatterjee and Dr. Debrato Majumdar to chair the session.
So good morning, everybody. So we'll start the session. May I call upon Dr. Sanjeev S. Mukherjee to deliver the first talk. The topic is timing cycle and basics of pacemaker.
Respected chairpersons and my dear friends, good morning. I thank Dilip for the opportunity. So I think in the 10 minutes, most of it is covered. We'll have a quick kind of a revision. Okay, yeah. Is that fine? Yeah. So timing cycles and basics of pacemaker. The whole day we are going to devote to devices, patients, so I think a touch of history is important. And as Robin sir was saying, this is what we started with, a large device connected to a AC line, for patients to have pacing. And till there was a eventuality which Dr. Lay had. He operated a child, and that was in Minneapolis in 1957. There was a power failure for 3 hours, and the child died because there was no power. So the next day he called Earl Beacon and the engineer there and asked him to get him a battery-operated device, and that's how a battery-operated device came. And also a company, Medtronic was Earl Beacon's company. So that's how this came. But then this was a big device. It needed to be miniaturized, and that went in 1960. Again, an event. This time, Dr. Senning. There was a lady. Patient's name was Larson, and he had recurrent episodes of Stokes-Adams. So wife was extremely devastated. She went to Senning and said, "Give him a device which was in research," and that was the implantable device. It was put at night to avoid publicity. He got the device. And he lived till 86 years, 20 device changes. The first device lasted for 8 hours. He outlived both his engineer and the surgeon. So that is what pacing is. And today we are looking at devices which do not have lead, and maybe in future we are looking at devices which will not have battery also. Probably it will be, by the cardiac motion. So in that background, let's quickly go on some of the basics that we'll discuss today. So any device, when we talk, and this is mainly for, not for veterans, but when we talk about devices, we talk about a code, the NBG code that is there for devices. A device has got a name. When you say VVIR, you mean something. When you say DDDR, you mean something. So the first code essentially means the chamber that you're pacing. It can be ventricle, it can be atria, it can be dual. The second is for sensing. The third code is what effect the code, the device is going to have. Is it going to inhibit or is it going to trigger? And the last is rate modulation, which is purely dependent on whether the device had got sensors. So these are devices, codes that we use. So what do you do in a complete heart block? Obviously you put a dual chamber pacemaker. What do you do in a sick sinus syndrome? An atrial based pacing. So this helps you in, to reach a decision like this patient. Now, if we say hypothetically he has got permanent atrial fibrillation, so what we see here is a patient with permanent atrial fibrillation, a low ventricular rate. What are you going to deliver? What are you going to give? So you're going to give him a VVIR device, which essentially means that you are going to give him a device which will pace the ventricle, which will sense the ventricle and inhibit itself when there is intrinsic activity, but deliver when there is no intrinsic activity. Few terms that have very often come and that you will all come across and you should be aware of. One is blanking period. What is blanking period? A period when the sensing amplifiers are totally off, essentially meaning by that the device is blind. In a blanking period, the device is blind. It will not see any activity, while refractory period is an interval where the device will record the event for diagnostic counters. So it will record it for diagnostic counters, but it will not affect the timing cycle. So whenever you see a refractory event, it means that it has been recorded, but it will not affect the timing cycle. So these intervals are important. So quickly going into the timing cycles, let's start with a simple device, a single chamber pacemaker. So what you have, a lower rate interval. What does it mean? So most of our devices are pacing at about 60 beats per minute, which is essentially 1000 milliseconds. So your lower rate interval is 1000 milliseconds. So you have got a spike, the device will deliver an impulse, and then it will wait for 1000 milliseconds to deliver another impulse if there is no intrinsic activity. That is called the lower time interval or the lower rate interval. And that way the cycle continues. So you have got 1000 milliseconds, it will wait. But as you can see in this image, there is an intrinsic event. So that intrinsic event will break this cycle and the cycle will restart for another 1000 milliseconds. So that is how your lower rate interval is set in a single chamber device. What happens at the level of asynchronous mode? Dr. Sabri has already discussed about it. A mode where it is only going to pace, it's not going to sense, useful when patients go for surgery, and that has been discussed. So let's go back to the timing cycle. What happens when a device pace in a single ventricular mode, in a single ventricle? So you've got a V pace. So in the PG, this is what will happen. There will be an essential blanking period. Blanking means the device will not see anything at that time, followed by a refractory period which will last till the T wave comes. And this continues. So as you can see, the last is a VR. VR means the device has seen something, it is in the refractory period, not going to change any timing cycle. So it will continue. So this is for a single chamber device, a standard timing cycle. So in dual chamber is slight extension of this. In a dual chamber, you have put another atrial lead and you have got a ventricular lead. So when there is an atrial pacing spike, in the atrial channel, there will be atrial blanking. That is, the atrial channel will be blank for some time. The durations, all this program, both blanking and refractory periods some of them are programmable, some of them are not. Essentially, because they are programmable, you can troubleshoot these devices. Right. So you've got an atrial pacing or a sense. That time, the atrial channel will have a blanking period. What happens in the ventricular channel? There will be a blanking. So that's called post-atrial ventricular blanking, in simple terms. Followed by that, there is something called as a ventricular safety pacing interval. This is only applicable when there is an atrial pacing spike. Why is it meant for? It is about 110 milliseconds. It is essentially meant to avoid any crosstalk happening between the atria and the ventricular chamber, because atrial pacing should not cause any kind of a crosstalk. So you've got a ventricular safety pacing interval which is fixed for 110 milliseconds, meant to avoid crosstalks. Then you will have in a dual chamber a ventricular spike or a ventricular pacing. That time again ventricular chamber, like in single chamber, will go into a blanking period, and the atrial channel also will have something called as post-ventricular atrial blanking. So this is part of PVAR, post-ventricular atrial refractory period. Blanking period, the device will not do anything, will not see anything. Post-ventricular atrial refractory period is again something when the device will record the events but will not have any effect on the timing cycles. Because of time, I think I'm not going into intervals. So intervals, I think most of you will be aware, but we can always discuss. So this is a standard timing cycle events that you will notice in a device. Quickly going into some of the basics. The devices have a pulse generator and a lead. The leads are nowadays called IS1 leads. What does that mean? That essentially means that they all have got a 3.2 millimeter bipolar pin which enters into the pulse generator. So you can have a pulse generator from a different manufacturer and lead from a different manufacturer because they all are IS1, essentially meaning that you can interchange because of this specific nature that all of them are built with. All the leads, as we discussed today, most of the ones that we use are bipolar leads. That is, they has got two poles. One at the tip, which is a cathode. One, the anode is close by, so they become bipolar. But you can also program them unipolar. As Dr. Sabri discussed, there are certain scenarios where you might program them to unipolar for troubleshooting. Otherwise, they are better in a bipolar mode. So this is what we have now. Sensing is a point that I think many a times I see a lot of students coming up with this confusion. What is sensing? So if a layman's language, if I say what is sensing? Sensing is the capacity of the lead to look at a depolarization event in the chamber that it is implanted. If it is implanted in the ventricle, it will look only at the depolarization event. It will avoid, it will not see other repolarization events like a T wave, a far field event. Those things it will avoid. That capacity of a lead is called sensing. And scientifically, if you look at these leads, the leads around 80 to 100 hertz is in the atrial channel and about 10 to 30 hertz in the ventricular channel is what these leads are capable of sensing. That is the, scientifically, these are values that the leads are capable of. It will not look at any morphology. It will not look where the event is coming from. It will only measure the size that you have programmed in the sensing interval. If you say that my ventricular threshold, sensitivity is 2 millivolts, only, so it is like a marker you have kept. It cannot see till 2. Above 2, when there is an electrical activity, the lead will sense it as a ventricular activity. And that is why you can have these kind of problems. As it was shown, if you have got a myopotential happening, the device will think that yes, there is a ventricular activity and it will stop giving the ventricular output. So that is why knowing sensing is extremely important. These are some of the terms that we'll see in the marker channel. I'll not go into detail. I think I'll straight go to my last slide. I'm closing it. Okay, now some of these intervals. Why should we know about these intervals? Because they help us in troubleshooting a device. So if there's a far field signal from the ventricular channel, which is being sensed in the atrial channel, what timing interval will you change to avoid this? Now, something that can happen. I'll give you an example. This. So what happens in this device is the device recurrently sees this as a atrial arrhythmia and goes into mode switch. So you can use an atrial blanking to kind of troubleshoot this. Let's go magnet, we have already discussed, so I'll go into my last slide. So this is a ECG of a patient who has come for a regular follow-up. So looking at it, it looks absolutely fine, But when you look carefully, you notice that in 2-3 AVF, you've got P waves which are inverted. It's inverted P waves. The simplest thing, what is your doubt? Probably an endless loop tachycardia. So how will you troubleshoot? Just put a magnet. The moment you put a magnet, the tachy will terminate because we know that it is based on V to A sensing. So it will terminate and that will give you a diagnosis. It is an endless loop tachycardia that this patient has. So I think I'll end it here. Thank you.
Yeah, so excellent talk, Sanjeev, as you always give us. So there's a lot to timing cycles, a fascinating topic as far as pacemakers are concerned, and extremely difficult to cover that up in 10 minutes time. What you said was that the crosstalk window post-atrial event, and you have that ventricular safety pacing. And that is a sweet spot, as you would agree, because you said 110 milliseconds. So we know that the impulse, the leading edge of the impulse can still be covered up in that VSP, but at times you would agree there would be a trailing part of the impulse which might fall beyond that VSP. So there lies a sweet spot where we can, if you increase the VSP, then both the trailing and leading can be covered up, yet that intrinsic signal from the ventricle, the native signal from the ventricle, can at times be masked. So it is again a sweet spot that in all timing cycles, that how you adjust the crosstalk part as well as avoiding or maybe not overlooking the intrinsic ventricular part as well.
Yeah. So if if I understood it correctly, you are saying that can we play with the ventricular safety pacing interval? Yes. So that we cannot play. As I said, certain intervals are fixed. You cannot program them. So VSP is fixed at 110 milliseconds across all devices. So you cannot play. So therefore, when if for all my friends, young friends, if you see any pacing spike happening, A pace, V pace at 110 milliseconds, please be careful. It has to be a ventricular safety pacing. Something is going on, you must interrogate. You cannot play with this pacing interval. But as Dr. Mujma said, yes, you can play with other intervals. Of course, the sensed AV delay and the paced AV delay you can always play. So that we can do. Yeah. Thank you.
So it's not a question, but just a comment that in the timing cycle, especially for young implanters, they should also understand the upper rate behavior, because suddenly the pacemaker, if it goes into 2:1 conduction rather than going into Venki back, then the patients are likely to develop some pre-syncope or syncope. So maybe one word about upper rate behavior.
Yeah. So because of the time I didn't go into it. So as Dr. Anupam said, I agree fully. This is another interval that you should be aware of. It's called upper rate interval. That is, as I said, lower rate interval is the one which is, you have programmed it that is essential. It will pace at that lower rate interval. Upper rate behavior is what you are telling the device that you can maximally go up on. Like you can program it at 120, you can go it at 130. And this particular interval, the upper rate behavior, will actually be decided by what we called as total atrial refractory period, or TARP. TARP is essentially a sum of sensed AV delay and the P warp. So suppose my sensed AV delay is 150, my P warp is 250, it becomes something like 400 milliseconds. So my upper rate behavior is fixed at 150 beats per minute. So you can play in that upper rate behavior, you can program, you can play. So you are essentially telling the device that that is the maximum it can go. Why do you need it? For an example, if patient is a coronary artery disease, you have implanted a device, you do not want that patient to go very high, you program it at say 110 or 120. Then it is called a device Venki back. So the device will go into Venki back the moment it crosses the upper rate. And when it reaches the TARP, it will become a 2:1 AV conduction. So you should be, that also you should be aware while programming, because suddenly the rate will drop. But this is the device behavior. A device Venki back happening at above upper rate interval, and at TARP, it will go into 2:1 AV block. So that is the upper rate behavior. I didn't talk much because of the time.
I think these are very important points. Device is going to do most of the things. Now the PMT is, I think, thing of past. The device will automatically increase the P-warp and take care of that. But these Venki backs and all with upper rate behavior, if it is coming, we have to at least know that this is not a problem. This is the device which is not able to track that because of the limited TARP which has been fixed. So I think wonderful presentation, Doctor. And may I request Dr. B.N. Jha to join the chair, the chair.
Thanks.
Very good morning to all of you. Our next session will start now. And very important problem nowadays, we all are seeing that it is the era of the obesity, diabetes, sleep apnea is one major cause. So many of our own relatives, patients suddenly died during the midnight. They are coming to hospital in a stage of almost collapsed or here. So sleep apnea is such a big problem. That we can't, it is a coming days, one sort of, we all are in a stage of volcano. So sleep apnea, cardiac arrest, medical diseases, options and devices. This is a very interesting session. I would like to speakers, forum is yours. Yeah.
Thank you, sir, and thanks to Dilip Kumar, sir, and the organizers for inviting me. So, as sir has already initiated the flow, that sleep apnea and cardiac devices. Sleep apnea, I mean, in a pacing session, we are talking about sleep apnea because sleep apnea is mostly it is underdiagnosed because we don't give much importance to sleep apnea. Many times we simply overlook that sleep apnea can be one of the contributing factors for that. So what happens? When we stop breathing for some time, the oxygen saturation goes down, the heart rate goes up because there is a sympathetic stimulation in the body. And as we know that sympathetic stimulation is at the core problem in many cardiac problems, be it myocardial infarction, be it tachyarrhythmias, or be it sudden cardiac arrests. So overall it increases the CV cardiac risk. The cardiovascular risk is increased. Previously, we used to say that if somebody is snoring, then he is having a sound sleep. But now we have understood that there is sound, but there is no sleep. So, I mean, these things are pointers towards sleep apnea. For example, excessive daytime somnolence, then of course snoring is present in most of the cases. Obesity is a very common risk factor. Patients with heart failure, they also have high incidence of central sleep apnea and obstructive sleep apnea also. Usually it is defined as more than 30 episodes of hypopnea or apnea in one night and more than per hour. And if it is 7 hours, then it is a huge number which can drastically increase the incidence of cardiovascular problems. So just to highlight the problem that the sleep disordered breathing, it may not be clinical sleep apnea, but sleep disordered breathing where the sleeping pattern is not normal. And with the era of mobile phones and gadgets, fancy gadgets, we know that many of our patients, they do complain of lack of sleep, which has become very prevalent. Disordered sleep has become very prevalent because screen exposure after certain times in the night can actually impair the quality of our sleep. So as the quality of our sleep is going down, so sleep related problems are also becoming very common. In the population with resistant hypertension, I mean honestly, we see patients who are on 3, 4, 5 antihypertensive. But how many of these patients have we ever thought about that sleep apnea can be one of the reversible causes? And how many of those patients have we actually subjected to sleep study? So just to highlight our thought process, just to make us think that this can be one of the factors in patients with resistant hypertension, in patients with atrial fibrillation, especially nowadays, HEPF is becoming very common. So heart failure with preserved ejection fraction, reduced ejection fraction, patients with stroke, CAD, pulmonary hypertension, again, up to 80% of the patients can have some sleep disorders, sleep disordered breathing, not sleep disorder, but sleep disordered breathing. So just to highlight this, that whenever we find a difficult to treat cardiac situation, sleep apnea may be contributory. So the number of times we are ordering a sleep study, I think it should drastically increase because it is a modifiable risk factor with lifestyle modifications, with CPAP, it can be managed. So sleep apnea basically it increases AF risk by 4 times, VT-VF risk by 3 times, and sudden cardiac arrest again is increased, heart failure mortality, heart failure morbidity, everything is increased. And at the center of the problem is the hypoxemia, is the sympathetic stimulation that is contributing to the cardiac problem. So some of these devices that are coming up, for example, the Boston Scientific has come up with this apnea scan in some of their models, the Accolade pacemakers and some of the ICDs and CRTs, they have incorporated this. It is a common comorbidity, and in the population with cardiac devices, in the cardiac rhythm management population, the prevalence can be as high as 50 to 60%. And we all know that it is often ignored because we are not programmed to think about sleep apneas as a problem in this population. So there are now automated algorithms like the FSCAI, developed by Boston Scientific. So EpiScan, it allows to identify the implanted patients at risk of severe sleep apnea. It is just a screening tool. It will not give the diagnosis. It is just a useful screening tool because it is already implanted. It does a continuous monitoring, and once we identify this by screening, once we identify, then we can refer the patient for a polysomnography for a proper sleep study, and then we can go for management. Even if the patient is not suitable for a CPAP therapy, but still we can go for aggressive weight reduction, we can go for aggressive lifestyle modifications, so that the incidence and severity of the problem can be controlled. And how it is done? It basically, the technology that is used is to use the transthoracic impedance measurement to monitor breathing patterns. So the pulse generator, and the leads, through that the transthoracic impedance is measured, and the pulse generator considers a respiratory disturbance event to be 26% or greater reduction in respiratory signal amplitude, and that is lasting for at least 10 seconds. So as compared to this is the normal respiratory movements that is sensed by the pulse generator, and whenever there is a 26% or more reduction in the amplitude, then it is taken as an event, and it has to last for around 10 seconds so that it is recorded as an event. So then the EpiScan displays the average number of RDE per hour that the patient experiences during the programmed sleep period, and finally we get the number of occurred RDE, define the event grade, different grade of sleep disordered breathing, and severe disorder is defined as more than 30 events per hour. That is like the traditional definition of sleep apnea with more than 30 AHI more than 30. So EpiScan on pacemaker population shows the following performance. RD is correlated with clinical AHI with 80% correlation and 82% sensitivity and 88% specificity. 88% positive predictive value in identifying severe sleep apnea, especially in the patients with AHI more than or RDE more than 30 in the severe category of patients. So these are the different programming parameters. So we just need to program the sleep time when the patient usually goes to bed and what is the usual duration of average duration of sleep, and then the machine will activate during that period and it will record the RDE events during that period. Even though the therapeutic options, there are studies like therapeutic options, for example CPAP for all patients, and so in the severe category only there has been some mortality and morbidity benefit. The less severe category of patients, CPAP has not shown definite benefit. In fact, it had shown some increase in mortality also. However, to diagnose the problem and to identify the high-risk patients so that who can benefit from interventions is important. From our own cohort of patients, we have some more than 200 implantations of Accolade pacemakers, and out of that we could actually diagnose 3-4 patients who are on CPAP therapy. So the diagnostic pathway, basically the implanted pacemakers will do the screening part, and once the screening part is done, then the pulmonary people will do the proper sleep study and then go for the management. So the treatments will vary. First is lifestyle modifications, weight reduction, comorbid condition management like CKD, diabetes, and then finally it is the continuous positive airway pressure should be considered in patients with severe sleep apnea. The current guidelines, they are beginning to stress the importance of careful screening and treating heart failure patients with sleep apnea. Sleep apnea often remains underdiagnosed in this population, and CRM patients are not symptomatic as usual patient despite positive diagnosis, because they sometimes confuse with their, for example, the dyspnea. We sometimes may not give importance that how much, what part of the dyspnea is contributed by heart failure and how much is the worsening due to other comorbidities unless we do some rigorous evaluation in such patients. So just from my short talk, the key take-home messages are cardiac implantable electronic devices are equipped with intrathoracic impedance or minute ventilation sensors that can continuously screen for sleep disordered breathing. While these tools do not replace polysomnography, they provide a powerful and real-world screening for high-risk cardiac population. Integrating device-detected sleep signals into routine follow-up and remote monitoring can enable earlier diagnosis, targeted referral, and potentially improving cardiovascular outcomes. Thank you.
Hello. Excellent, Dr. Jana, excellent talk and overview over the sleep apnea. We know the sleep apnea is a basically obstructive sleep apnea particularly is a multi-system disease.
Yes, sir.
It has an implication now from the cardiac to all other system of this. And polysomnography, sleep study in layman terminology, is one of the key point to pinpoint. But the AHI sample seeing a AHI more than 10, 20, 30 is of the, yeah. This your instrument is very easily put up without going for the detail of the polysomnography. Polysomnography, there are 6 investigation is included, including ECG,
Yes,
EEG, retinography, muscle, and all activities being able.
Yes, sir.
But this your new devices is making our works easy. I think this is scan per newer device for that. But of course, the obesity reduction, CPAP therapy, nocturnal oxygen support, and the complication, high level of suspicion by clinician of the OSA complication is very, very important. We'll share you just like driver, particularly we are coming from railways hospital, whether the driver, pilot, your airline pilot, all are sleep apnea obstructive is such a danger that it is the life-threatening for all. Ajay ji here, we have seen so many obese loco pilot and very difficult to locate whether he will continue with OSA or not.
Exactly.
So it is a big challenge for us. I think any questions from, any comments from sir, Yadav sir, yeah.
During apnea, if say bradycardia occurs, significant bradycardia also has been reported, does pacing helps to break the apnea?
No, because pacing will not break the apnea, it will temporarily support the heart.
Temporary support.
Yes, sir.
Nowadays they are saying semaglutide in patients having recurrent sleep apnea are found to be, because of weight reduction, sleep apnea is reduced in...
Exactly, sir. Yeah. So basically my idea was to just highlight the problem, to just little bit change in our thought process that it is one of the common problem and it should be in our mind that sleep screening or sleep studies should be ordered more frequently. Thank you.
Thank you, Anupam. Thank you, chairpersons and moderators. Thank you so much.
Just one important that severe sleep apnea was known as Pickwickian syndrome already, and Pickwickian was the one character in the French novel having a big obese personality, and that was the curiosity. So this type of obese personality of it is not a good thing. We have to look for sleep apnea. Don't ignore it. Otherwise, we will lose the patient. So many patients. Thank you.
Thank you. So thank you, chairpersons, and now may I invite the new set of chairpersons and moderators on dais. Ashish, can you chair the session? Dr. Siddharth Samrat, can please come to the dais. And may I request Dr. Adi Yadav to speak on new insights in management of device-related infections. So we have good solutions for infections now. We can avoid infections by going leadless, but and also so many solutions to prevent infections even with normal conventional pacemakers. So, Dr. Yadav.
A respected chairperson and dear friends, first of all I want to thank Dr. Dilip. He always calls me during his device update every year. Can you go for slides? So what are the new insights in the management of device related infection? It's a prevention and solution. This is the showing that with time, the device implantation incidence is increasing, and not only that, with that, infection risk is also increasing. And most of the infection is coming from the skin. So skin preparation is the most important. And with each infection of the device, mortality is also increases by 30%. Not only the mortality, but the cost of treatment is also increases proportionately, and very high needs of antibiotics, hospitalization, recurrent surgery. And so it's a very, very devastating and very, very frustrating to the patient, to the doctor, of this if infection occurs with a large device. And this is the way they present with the pus, erosion, and granules, and the infective endocarditis in the systemic infection. Not next. How to go next? Okay, so these are the way this device infection present. And once the device you put, infection comes from that very time, is from skin contamination. The skin containing bacteria goes to the, it's a competition between the normal tissue to cover the lead and pacemaker generator, and they form a EPX matrix over there, and that's why once you put the device, and thereafter antibiotic will not work until you have local antibiotic support. So if you will give oral antibiotic after you have put the device is of no value. And with the CID infection or removal, the mortality also increases. Mortality is more if the endovascular infection occurs, particularly the infective endocarditis involving the tricuspid valve or lead vegetations is there. And the risk factor are early reintervention, CRT-D or ICD implant, larger device, or requiring more than 2 leads like CRT, device replacement and revision has the high risk. Temporary pacing lead is also very high risk for developing infection. If the patient is on corticosteroid, if the patient is on oral anticoagulants or DAPT or SAPT, they develop hematoma, and hematoma increases the risk of infection. Dialysis dependent patient, renal failure patient, and fever below 24 hours of implantation should be avoided because they increases the risk of septicemia and infection. And diabetes, congestive heart failure, male gender are more at risk of developing infection. And if there is a pocket hematoma, you have to clearly make the pocket hematoma free. Otherwise, the infection rate increases around 10 times. And most of the bacteria is from the skin. So skin preparation, cleaning is the most important. And cleaning with the chlorhexidine, not with the povidone iodine, is the choice. And 70% of them are coagulase negative Staphylococcus epidermidis. Their infection is indolent, date onset, expert biofilm and producer, so that what happens? Sometimes you put the device today, infection comes after 6 months, 1 year. Oh, you think, what happened? That time we have done everything fine, why not? Because of this coagulase negative infection. And staphylococcal aureus infection is in 25%, 5% there is negative, that is gram-negative bacteria and fungi infections. And they comes from the skin. And few infective endocarditis come if the patient is on the dialysis, hemodialysis. And then there is a PADIT scoring which has shown that if prior infection has occurred, the chance of reinfection is higher. If immunocompromised higher, CRT device higher, revision upgrade require 2 points, depressed renal function is 1 point, dual chamber device 1 point, age below 60 1 point, and if you have more than 7 points, PADIT risk score is 7 points, they are at high risk of device infection, and they should be treated with the local releasing device, that is Tyrex or Illupro. And this is how the infection can occur. It can be superficial infections where you need only 10 to 14 days of antibiotics. Pocket infection occurs. Once pocket infection occurs, you have to remove the device. If infective endocarditis occurs, you have to remove the device. Otherwise, how to know that the infection has occurred? If there is a redness, swelling, pain, and symptoms fluctuates, and don't drain the pocket with the needle. And if you have device erosion, purulence, fluctuance, sinus tract, all this indicates infection, it is better to take out the device with the lead. And if you have blood cultures positive, it suggests systemic infection, and look for TE or your PET CT, FDG PET CT to see there is infection on the lead or on the or on the tricuspid valve or in the pulmonary valve, and you have to totally remove those things by surgically, and also the lead and pacemaker should be removed. So these are the diagnoses already cleared. If you have like this, there is no need any test that infection has occurred. You are confirmed that infection has occurred. Infective endocarditis, you have to do the blood culture. As you do infective endocarditis, particularly if the patient is having fever, acute or subacute, septic embolism, pocket infection, look clearly swing and positive blood culture, and all infective endocarditis criteria you use for the detection of systemic infection and infection in the lead or on the valve. HASEC group causes infective endocarditis in 22.1%, highest, Staph aureus 18.2%, Enterococcus faecalis 11.5%, Streptococcus species is 7.1%. And as the your bacteremia increases, the risk of infection to the septic infection also increases. These are the minor criteria. If you have two major criteria, one major plus three minor criteria, or five minor, they have definite indication of infective endocarditis. They should be treated after device removal 4 to 6 weeks of antibiotics. And same thing has been demonstrated here. This is the vegetations and lead in sometimes septic embolization to the lungs occurs, and they can present with lung abscess also. So they should be treated, and diagnosis by PET CT is the diagnostic choice. You can do WBC CT, WBC scanning also, that is 99 technetium level WBC scanning, but they will show that there is inflammation there only. And these are the vegetation taken out from the lead. So if superficial incisional infection occurs, antibiotic therapy 7 to 10 days. If isolated pocket infection, remove, extract, and give antibiotic for 10 to 14 days. If there is a systemic infection, treat, remove and extract the whole device, antibiotic therapy for 4 weeks. If culture negative, then 2 weeks. If CID endocarditis has occurred, remove everything and give antibiotics for 4 to 6 weeks. So, prevention of infection now. Prefer operation theatre with cath lab facility, if available. Always fumigate the lab overnight. Put soaked gauze with chlorhexidine at patient subclavicular region for at least 12 hours. Put a gauze and soaked with chlorhexidine for 12 hours before doing the procedure. Pre-procedure antibiotic with cefazolin 1 gram. Nowadays we give your vancomycin, or you can give Tajak along with the amicacin. And use Tyrex or Illupro. Illupro has come from the Boston, Illutia company. It's a bio envelope. Like Tyrex is synthetic, where Illupro is the bio envelope. And particularly in CRT, ICD, CRTD device during replacement or revision. Drape after cleaning skin with chlorhexidine solution. Chlorhexidine is 5 times more effective than povidone iodine, and covered with ioban which fixes the bacteria and also kills it. And when putting the device, don't put the device by touching on the skin. Don't allow the device to touch in the skin. So make the make the pocket open and then put the device. Just 2-3 more minutes. Close the wound in 3 layers. Close third layer by absorbable monocroral suture and also stapler it, so that doubly you are covering the lesion. So avoid pocket hematoma, avoid infection during the implantation, and fix the lead and pacemaker properly so that twiddler doesn't occur, because it also increases infection risk. And keep the pocket, if the patient is lean thin, keep the pocket submuscular pocket. I prefer submuscular pocket or more deeper pocket where the infection risk is less as compared to subfacial pocket. And also put the devices more medially. Don't put more laterally. Puncture laterally so that extrathoracic puncture can occur. But put the device, make the pocket more medially so that loose tissue and collection of the hematoma doesn't occur in the pacemaker. And then close with the 3 layers which already. Cefazolin and saline randomized trial has been done in 2009 and cefazolin has been found to be superior in preventing infection. And then PEDIT trial was done where cefazolin was compared with vancomycin and bacitracin, irrigation of the pocket, and then 48 to 56 hours of oral cephalosporin. There is no benefit of post antibiotic after that, and there is no benefit of bacitracin antiseptic cleaning also. So same thing has been demonstrated, and as I told you, there is a biofilm formation, so you need a device which gives antibiotics in the pocket, not from outside, oral or antibiotic, IV, because it will not able to reach. So Tyrex has been developed, which has biodegradable polyarylate mesh coated with minocycline and rifampin, and which releases the drug for 7 to 14 days, it's a dissolvable device in 9 weeks. And another new device come from the Boston is the IluPro device, which is from Ilutia company. They have bought it. It's a porcine small intestine submucosa device. It causes vascularized tissue and not the fibrous tissue, and so it's a more healthy, and it promotes and releases the same minocycline and rifampin. So it's a new Tyrex-like device. Tyrex is synthetic polymer. It's a biological polymer, biological device. So this is the new device which has come and bought by the Boston, and this is the IluPro device having 2 sizes available, 6.9 centimeter into 6.5 centimeter, and another one is 6.9 centimeter into 8 centimeter. 2 sizes. Heal study has done, which it also fixes the lead, it fixes the device, so device migration, lead migration like Tudor syndrome are less common, lead mobilization less common, and the capsule thickness is slightly smaller, and it covers all the bacteria, minocycline and rifampin. Minocycline is bacteriostatic, rifampin is bactericidal, and it covers all gram-positive, gram-negative bacteria. And this is the dose of rifampicin in moderate size envelope is 8 milligram, and minocycline is 5.1 milligram, large size envelope 11.9 milligram rifampin, and 7.6 milligram minocycline. And it maintains the MIC from 2 hours to 7 days, more than 7 days. And this is the rapid trial which has shown in more than around 7,000 patients that it reduces the infection risk by 40%. But number needed to treat is 200 to get one benefit, and 60% reduction of the major pocket infection. It does not reduce the systemic infection. Be careful. It does not reduce the systemic infection or infective endocarditis. That you have to take care. So it is safe, and the same it has been shown in beneficial in almost all groups, and PEDIT risk score has shown that higher the risk, higher risk of the infection, and if there is a hematoma in the wound, the risk of infection is 13.1% as compared to without that. And people with CRT devices has been compared with the envelope, without envelope, what they have found with the CRT envelope is better than without CRT. In prevention of infection. So high-end devices like CRT-D, ICD or CRT-D devices, the number needed to treat required is only 100 to get one benefit. And these are the groups where high risk, they require your infection control. Another group is the just one minute, that those requiring pacemaker defibrillator on anticoagulation, don't bridge with the heparin because it will lead to more hematoma and more infection. So don't bridge with the heparin, directly continued warfarin, or you can put the device with the cautery, using low thermal cautery to prevent the bleeding inside the hematoma inside the wound. And bruise control 2, where DOAX has been used, and all 3 DOAX was used and found to be a reduction of the continued DOAX. There is no need to just do low temperature cautery, and it will there is no difference in continuing the DOAX versus stopping the DOAX. You just stop one day before. Say tomorrow you are doing, you just evening you stop the DOAX and you do the procedure. And the next wave emerging pharmacology adjuncts is the taurolidine. And taurolidine has shown that it's a very effective, and this is the published in in Italy, and they have shown that it prevents taurolidine is available, taurolidine M available, and you can irrigate the wound with the taurolidine and pocket with this taurolidine, the infection risk is almost 0%. And even if you are thinking very high risk or multiple infections, not able to put from the subclavian or anywhere, you put the leadless pacemaker, which reduces the infection risk by 48%, or subcutaneous ICD where ICD is required. And so CID infection increases mortality, cost and disability to the patient. Prevention is the most effective way than solution. Leadless pacemaker, extravascular ICD and subcutaneous ICD and modular pacing through emblem and leadless empowered device may be an option. Once infection occur or pocket or leads, both has to be removed in total. Thank you.
Sir, very insightful talk. I would like to add few points like, so number of pacing devices are increasing day by day. So onus is on us physician that we train all our cath lab technician nursing staff, because if we are taking the precaution but they are not taking, if anyone not giving their 100%, then there is risk of infection. Yeah. And second thing, we have to keep the timing of the pacing open pocket for reduce. So we have to reduce the time. So as fast as we have to do the pacing.
You see, most of the infection come from the skin. So skin, I clean my patient for pacemaker or devices myself. I do take chlorhexidine, first gauze piece we put for 12 hours and then take out and then clean myself by rubbing properly 3-4 times. And then we don't rely on the nurses.
That we have to.
Number 2, always wash hands. And the wash hands, you wash with the tap water. It is better to use filtered water to wash the hand. And that also contains bacteria. So best you always wash your hands with when washed your soap and chlorhexidine soap. And then you take chlorhexidine solution on your hand and keep for 10 minutes so that all bacteria in your hands dies in 10 minutes time, and then put your gloves and then put the device. So these, and when putting the device, don't allow the device to touch the skin, and must use IO1 because it fixes the bacteria, it is antiseptic and does so most of the infection starts from the beginning. So you care that beginning, infection will not occur.
As usual, wonderful presentation, sir. I would like to ask you one question. There is a trend that we usually give antibiotics inside the pocket to prevent infection.
Yeah, so also I give antibiotic because you need local antibiotic. So there is, although there is no randomized trial, but since in Tyrex or in Ilupro, what we do? We give local antibiotics. It's a local releasing antibiotic. So same antibiotics, either you give antibiotic, I irrigate nowadays with the taurolidine. Now taurolidine has come, so taurolidine, we irrigate the pocket with taurolidine and chlorhexidine, both. So that all antiseptic bacteria will go away, and then we put the device in.
But Ashish, I don't give, and we can compare the, I have been implanting since 2007 pacemakers, we can compare the rates. Some operator is giving, some is not giving, I am not giving. No difference, sir.
No difference.
No difference, no difference.
But
and there is no evidence also in
yes.
Scientific community.
But I give.
I think we have to move on. Thank you so much, sir. And thanks Ashish and Dr. Samrat. So now I invite the next set of chairperson and moderators, Dr. Sonali Sarkar. Please come on stage. Dr. Ajay Gautam, Ajay and Dr. Anand Pandey. Anand, please be on stage. Ravi sir.
Good morning, everybody. This is an interesting talk, but it's tough actually. It's not that simple as you perceive. So we are talking about redefining shocks in ICD with pulse width change. So just let us focus on this point. It's very important, very interesting, and there could be some controversy also. So what we all know, this is well proven, that therapy that protects, ICD therapy that protects, reassures and improves life, provide appropriate therapy, avoid inappropriate shock, peace of mind for the patient and peace of mind for doctors. The clinical implication of shock therapy, why it is important? Because the quality of life decreases, mortality may or may sometimes it may change, and lesser shocks leads to better quality of life and certainly less mortality. If you do not give shock therapy, then of course there is a chance of death, chance of the quality of life improvement is very low. But the point is that the shock itself can cause problem. So what we need to understand now, from here the concept starts. In an ICD, when they deliver the shock, you have to understand that there is a can and there is a coil, right? So, and it delivers shocks, it goes from can to coil and then delivers a shock. That's what is being commonly perceived. But what happens, that the current goes like this and it actually comes back from coil to can. So that is the reason nowadays all the devices, they have got biphasic shock, right? So in biphasic shock, the shock goes from there to the coil and then depolarizes the myocardium and then it has to come back. Now, as you understand that in the myocardium there are multiple cells. So the shock goes to the cell and changes the whole the polarity and so depolarizes it. Then the abnormal impulses, they stop. And if it doesn't come back, then there could be some cells which are still irritable. And then again there could be ventricular arrhythmias or any arrhythmias. So that we took a lot of time to understand this, something like 10 to 15 years. If you go back to the old generation of devices, which I used to use, in fact, of late I use this biphasic shock, of course. I think it is popular from 2006-07 onward. But before that, early late 90s and early part of the 2000, this shock is to go and then we deliver the shock and again there is another shock. So then patient was getting, I still remember a patient who had 21 shocks at a time. The reason is that the biphasic component was not good. And then the question comes that what would be the time interval between the forward movement from the can to coil and the backward movement from coil back to coil back to can. So it took a lot of time for all the industries to calculate that what would be the actual time interval. It is biphasic then also it was not clear that what percentage, what component would be this way, what component would be that way. Still it is not yet settled. There the term comes the tilt. The tilt comes there, so we will going to talk about it. Now let us take this example. So shock effectiveness matters. Now if a device continuously gives shock, one, then the battery gets depleted. Second, the myocardium is fatigued, and then that causes much more death, much more complication. And this is the data. So defibrillator therapy is crucial for ICD shocks for efficacy. So shock is and efficiency, shocks for efficacy and efficiency, which means minimizing energy and battery use, balancing shock energy, amplitude and width with heart's electrical properties to prevent refibrillation. When we talk about defibrillation, we do not remember there is another what called refibrillation. If defibrillate and if you do not maintain the sinus rhythm and if it doesn't sustain for some more time, it can refibrillate. So you have to take some precaution to not to do refibrillation. Therefore, optimization of therapy to treat dangerous arrhythmias like ventricular tachycardia and ventricular fibrillation effectively while reducing unnecessary shocks. And this is an example that there is a VT going on and there is a shock and finally cardioverted to a normal rhythm. But point is that even with ICD patient, if you can see this is the data, which shows that there could be very high percentage of death happening even on patients with ICD, something like 32%. And what is the reason? And if you look at the data much more, this is a very interesting slide saying that saying that the post-shock pulseless electrical activity could be 35%. There could be primary pulseless electrical activity, there could be VT storm, there could be shock failure. There are so many causes of there which may cause 65% of sudden cardiac death in ICD patients could be avoided if you can program it or if you can design your device in a very specific manner. So therefore, the basics of defibrillation is important. So nowadays, for all practical purposes, shocks are biphasic. Monophasic has gone, all gone, even our usual defibrillator has gone. So the precision technology, shock technology is important because in precision shock technology, now you can see in this slide that we can see very clearly that the pulse width, if you have the pulse width You can see this is one phase, the pulse width phase 1, that goes that way and then comes back in the phase 2. So that time from in phase 1 time and phase 2 time, optimization is extremely important. Some device, the industry claims, some companies' device claim that this is already kind of automatic. It has been done in such a manner that they calculate on their own, depending upon the shock impedance, depending upon the impedance, or depending on the underlying substrate, whether it is cardiomyopathy, ischemic heart disease, myocardial fibrosis, and then accordingly they calculate and they deliver. But some companies, they program it and accordingly it goes. And so therefore, that is what is important, that the tilt is important. This is an example which I am sure when you program your device, you can see the BF shock, first phase 65%, second phase 65%, which means that if you give, let us say but nowadays, in good old days, it used to be, after biphasic, it used to be 50%. So 50% means that 50% you are delivering, another 50% is with you. So that 50% actually going back, what is happening here, if you give 50% tilt, that means only 50% of the energy will be delivered, and the second phase another 50% will deliver. For example, let us say 400 voltage you are delivering first phase, second phase will be 200 voltage. Therefore, that 200 voltage may not be, the first 400 voltage may not be optimum. So if it doesn't sort of terminate, then the remaining 200 voltage may not be able to terminate. So therefore, the many people thought that let us make it 60%. I think nowadays many companies are making 60% on the first phase and 40%. And I think the Abbott company made it 65% tilt, if I am not wrong. So that is what is the current tilt concept. So let us, if you go back further, so the timing matters because the timing, the 3 to 5 millisecond window represent the tissue time constant. So eventually, the tissue time constant is a determinant. What is determinant? You terminate the shock and make sure that there is no refibrillation after the shock termination. Right? So the 3 to 5 millisecond probably is a good, but much more than what is important is that background, the substrate, whether what is the background, is a good heart, like just a simple heart, or it could be a fibrotic heart, or it could be ischemic heart, it could be a cardiomyopathic heart. That also important because that modifies what is known as tissue time constant. So tissue time constant may not be the single factor, it could be different. So as I said earlier that some companies, they thought that automatic change of pulse width depending upon the high voltage shock impedance may be beneficial. And then conventionally 60% shock tilt starting from high voltage to the low voltage or minimum voltage and to the opposite polarity would be beneficial. But this company, the Abbott, may have 65%. So adjusting the pulse width is important. I will probably go quickly, I am going to finish my talk shortly. So hypothesis is a good membrane block is, the time is about 40 millisecond. Another example is 40 to 75 millisecond if it is not that good, and the typical one, and type 3 is very slow if it is very diseased thing. I give an example. This is an example where the slow is this one, faster is this one, and this is a typical, that is what the conventional thing that we have. This is a very interesting slide that you can see from the onset to the termination is 16 millisecond, that is a good myocardium. But sometimes it could be 40 millisecond, which is more than that, which could be bad myocardium. This is an example. The primary prevention, the ICD has been implanted. The 40 joule shock failed. You can see clearly all failed. Then you change the pulse width with a fixed tilt of 65%. You change the pulse width from to 5.9 to about 6 millisecond. And with that, you can actually see that it's getting terminated properly. So pulse width programming is important in certain individual because that can actually deliver the shock appropriately, terminate the ventricular fibrillation and or ventricular tachycardia and prevent tachycardia or refibrillation. That is what is important. So this is another example of similar sort of thing. So greater programming flexibility with DFT response technology is important. It is only available at about high voltage device, as I said. Non-invasive programming flexibility in the management of defibrillation threshold is to ensure adequate safety margin with exceptional energy delivery. More options for adapting to changing the patient's condition following implant with or without induction testing is important. These options are intended to help physicians to prevent fluctuations of DFTs and minimize a safety margin from 1 to safety margin. Pulse width programmability available only from about that part, as I said. Greater programming flexibility, this slide, this is called shock truncation. Shock truncation, as I said, that 3.5 millisecond is the maximum. This is a kind of slow membrane response. Quick membrane response is 2.5 millisecond, is good myocardium, and very slow is 4.5 millisecond, which is probably the myocardium is not that good. So depending upon that, it decides how to deliver the shock. Finally, it is also important to know the lead. The leads are being covered, as you all know, silicon and polyurethane, right? Polyurethane and silicon, because silicon, it helps in molding the advancing the lead. Polyurethane to prevent the friction or abrasion. But then the certain the companies nowadays, they made the lead, the mixture of both silicon and polyurethane together. So they covered the lead as insulator. Therefore, it can have a combination of both in a very nice way to prevent abrasion, prevent friction-related complication, and of course, flexibility continues to remain, and lead can easily navigate across the vein right up to the ventricle, wherever it is to go. By doing so, it has been found that with all this technology, with the new lead insulation technology, with what is called the pulse width modification and the tilt modification, it has been shown that patients could have 100% freedom from externalized conduction failure, 98.9% freedom from all-cause insulation abrasion failure, 95.9% freedom from all-cause mechanical failure, and 85% reduction in abrasion risk with optimum lead compared to silicon and insulated lead. I think Abbott has that lead, no other company has it at the moment, but I'm sure it is going to change. So, and in addition to that, it is important for us to understand the pulse width. Pulse width change is important. Therefore, the more kind of a successful delivery, more appropriate shock, less inappropriate shock. Therefore, the quality of life will improve and mortality will decrease and patient will survive sudden cardiac death. Thank you very much for attention.
Thank you so much, sir. Sir has been my guru and teacher. So again, I would like to ask a simple question. In my experience, there was a young boy, 21 years, with ARVD. He had a similar issue, recurrent shocks. So finally it was resolved. So in ARVD cases also, the same...
Agreed. I think probably you could have enhanced the pulse width a little longer. And because as you all know, pulse width, the use of pulse width is very common for all of us when you do pacemaker, isn't it? Sometimes we do not get appropriate threshold. So what you did, let's say threshold goes up, 0.7, 0.8, then it's 1.5. Then what you do? You just ask that, okay, let us change the pulse width. If you change the pulse width, the same patient now start pacing at 0.7, isn't it? That same technology, that programming of pulse width is not available with most of the ICDs. That is a problem because the many companies is still automatic. They claim that automatically recognize and change it. I'm not quite sure because we do not have any data. But this data which Abbott has at the moment, they got actually multiple studies being collected together and then they found this conclusion. So probably this will be an advantage.
Ravinda, I think what patient wants from you, a doctor, less number of shocks, that is less inappropriate shocks, less number of painful shocks, and the battery longevity of the pacemaker. Now you have to tell us which device is fulfilling all these criteria rather than going into intricacies of knowing these algorithms or the pulses, because it is already AI generated or AI modulated programming done in the device. So out of the Abbott, Medtronic and Boston and this Biotronic, which pacemaker has got these features?
Excellent. I think that's I was waiting for this question because the same question I have in my mind. In fact, before this talk, I spoke to all of them, all these companies. Biotronic could not. I spoke to Boston, spoke to Medtronic, and spoke to Abbott in detail. We do not have any answer, to be very honest with you, at the moment. And as you said very appropriately, that AI has to be incorporated in this to understand this, what is going on. So now each company they claim, for example, Medtronic claimed that they got the previous device 50% tilt, now 60% tilt, the new one. And they also claim that the pulse width is optimal, there's no need, it's automatic, it will calculate on its own, and they are quite happy about it. And there is no data to support it. The Abbott companies, they said that it is 65% tilt, and with programmable pulse width from 2.5 to 6 seconds, you can probably improve it. But it is much more complex because the substrate is so different. As Ajay said, that this patient is right ventricular cardiomyopathy, ARVD. We do not know that how they behave. We do not know the extent of the myocardium damage. So I think there are so many factors. Probably AI incorporation to understand the cell membrane structure, the potential inside the myocardial cell had to be much more integrated, much more analyzed by AI system. Probably then only we can achieve a kind of optimum ICD.
Sonali, Anand, if you have any comments.
I think what you can predict at the moment that if the heart, if this is just a primary VT or ventricular fibrillation, and probably the simple way is heart function is preserved, maybe a good idea to, for these patients who are undergoing ICD, maybe a good idea to do MRI scan and understand the inside of the myocardium, what is the late gadolinium enhancement, as kind of volume of the myocardium, that then you can probably predict that this would be the kind of case where the failure could be high, refibrillation will be high, and success will be less. So depending upon that, that is what I can think of.
Sir, one more point. An excellent talk, as always, as you delivered. It is a very difficult topic to understand, not a very easy thing, and this is something which we don't follow in our day-to-day practice, as you mentioned. And again, sir said, Dr. Hajra, the intent of increasing the pulse width would be to prolong battery life and to lessen the discomfort of the patient. So is it time now that you feel that at each, there are certain patient substrates who would benefit from this increase in pulse width? Likely a very large ventricle, a scarred myocardium, you have obesity where the impedance is very high. And so you need that typical, and per se we don't do that defibrillation threshold also nowadays. It has been shown that if you increase the pulse width, defibrillation threshold decreases by 30%. So more effective single shock delivery, tailor-made shock delivery is something that which is the need of the hour. Should we, in each of these patients, sit with the company personnel rather than relying on the automated setting, see whether that typical patient who would benefit from that?
Yes, I agree with you. I think so many factors in addition to cardiac, extracardiac. Some patients may have associated pericardial disease. Some is obesity, COPD.
Yes.
So many factors are involved, when you deliver. But then I think even the circuit itself, the electrical component itself is very, very complex and not so simple, I would say, the physics involved in delivering the shock.
The concept of tilt, these are not very common
No,
things.
not at all. I agree with you.
To bring these topics.
But it's a good topic, the physician should wake up.
Thank you, sir.
Thank you, sir.
Thank you, chairpersons. And may I invite the chairperson for the next session, Dr. Dipankar Mukherjee, sir. Dr. Soumitra Ghosh. And Arun, his flight was little late. He will be coming in 15 minutes. So may I request Dr. R.D. Yadav, sir, to present 2-3 very unique cases of CRT implantation. So he will be giving case-based tips and tricks. And then we have a quick short discussion on a case scenario where Dr. Abhijit will be presenting and we all will be discussing. So we'll, maybe I can invite Dr. Anupam, Dr. Prakash sir in the next, case presentation to give their comments. Sir, please.
So, respected chairperson and dear friends, again thanks to the organizer, Dr. Dilip, and all the team of device updates. So my topic is tips and tricks in CRT device implantation. I am showing just few challenging CRT cases. So here this is already effectiveness of CRT has been demonstrated. Now say CS dissection has occurred. So here we always take levophage, a very good vein. If you can see, this is the very good vein. Very good vein. So I usually do, so my colleagues also do with the decapolar, prefixed decapolar, and they put in the proper place. They put the lead also very nicely, no problem, but lead came out. While slitting, lead came out. So what they did, again rehooked. So what we have planned, once lead comes out, since this company, this is St. Jude company's lead, so they have no screwing system as it is in the Medtronic. So we do stenting of the, we entrap the lead with the stent. It doesn't cause any defect of the insulation or any problem. So for that we put two wire like this, but what they have found that this wire is not in the, this wire as well as the seat is not in proper place, not in the CS. So what we did, we confirmed with the, when you are in doubt, we confirm with the coronary angio that my seat is outside the CS. Anyway, we repositioned, rehooked and put the device. There was mild pericardial effusion which subsided itself without any problem. So another case, similar patient, this is the white QRS, LBBB, and this is the levophage, showing the vein in the lateral vein. So we put the device in the lateral vein. But while slitting, it came out. So how to do the stenting? We hook the CS, put two wire, and then take out the seat. And one seat, we put the right coronary guiding catheter. Here you see two wire, one lead, one wire with seat, one wire with lead. Here seat and lead. And another wire kept to put the right coronary guiding catheter through the 6 French seat. So first we hook the CS, put two wire, take out the seat, with the one wire put the delivery sheath and lead also, and with the another wire put the 6 French seat and put the 6 French guide. How to stent? And this is, you see, guide, another wire we put the guide, and then put the PTCA wire on that guide, and then put the stent, deployed the stent, and we fixed entrap the stent, and it doesn't cause any insulation defect, any problem. So this is the technique of stenting, because with the same delivery sheath, stent will not go. So you have to take another guide catheter, and then it's done. There is no problem. Narrow QRS, same. Another patient having dysynchronous LV dilated cardiomyopathy, dysynchronous contractions. You can see clearly restrictive filling pattern, and so we have put the delivery system, and again put the stenting similar way which I have demonstrated. Now another patient, venoplasty was done here. There is a narrowing at the origin of the posterolateral vein, so we put the balloon and then subselect, and then with the help of subselect we put the your lead, LV lead. And another patient having persistent LSBC, just will show you LBBB, typical diastolic, yeah, I think it will. I don't know, it's running. So here persistent LSBC is there. I don't know, it's not running. So we put the, it's not running, I don't know why. So we put the device LV lead here through the persistent LSBC. This is the LVCS lead, and this is the RA lead, and this is the RV lead in the septum. And so this is the way we can, in persistent LSBC, we can put the lead. And this is the final result of the same patient. Narrow QRS, you can see absolutely better position. And this, so here another patient, lead extraction, and then angioplasty. There is a stenosis of the vein, which is left innominate vein. So we took the angioplasty of the vein, and then lead extracted. and then we put the device having narrow QRS. Now persistent LSBC with left innominate vein, another patient having one vein is connecting, another is persistent LSBC. So what we did, we put ICD lead through this vein. This upper one is here, ICD lead through this vein and LV lead through this vein. So here LV lead, this is the sub-select from Medtronic, and then put the lead here, and ICD lead I have put through the innominate connecting vein into the right SVC into the RV apex, and another atrial lead from the persistent LSVC. And this is the final result of both the sites was used here. So DCM with LBV requires CRT-D implantation for SCD and pump failure. Anatomical complexity may demand skill for CRT implantation. Now selective cannulation of the CS tubules by subselect. Here again, last case, I'll show here. This is the subselect. We use subselect, and then if subselect goes, then your lead goes. Lead goes there. So I use subselect quite frequently, and then the device has been put in. So I can show similar cases several. Thank you.
Thank you, Dr. Jadhav. We have much time. You have finished much, at least 2 minutes before. So the opinion from the...
So what about stenting of CS lead? So how many of us, go with that idea? Is it recommended?
No,
or only cases are there?
Only cases
are there
like that.
But we have seen implanters struggling with the electricals after that. Many patients.
I have done more than 10 stenting of the lead. It does not cause any insulation break on the lead, and no problem with the lead. And if say infection occurs, you can also take it out. It's not a problem that you cannot extract also. So this major problem, that lead insulation defect doesn't occur. And infection, when infection occurs, you can take out the lead. It's not a problem. You require some force, but it comes out. The stent has no that much strength, so that you cannot take it out. But it is enough so that it compresses the lead and it does not allow it to come out. Otherwise, you can use Medtronic screwing lead at the screw at the side, active fixation lead. But nowadays they are available in quadripolar only. Bipolar they don't have.
Severely dilated heart. So if your employee is not, helping you to take the, wire inside the CS, so how many times you have to resort to your EP catheter, or you start with EP catheter? What's your choice?
90% I use EP catheter, and mostly prefixed DECA. Prefixed curve DECA from Cordis I use. But other companies DECA you can use. You can use St. Jude's TPI lead also, which is prefixed curve. Or you, sometimes I use AL2, AL3 angio catheter or multipurpose catheter. So these are the catheter by which we hook the CS.
I think the biggest fear of doing CRT in younger's mind is the entry of the coronary sinus. Yeah. Difficult coronary sinus, different angulations of the coronary sinus, small size coronary sinus with a valve, coronary sinus with a previous procedure done, and maybe in the future you will have a coronary sinus reducers, a stent inside the coronary sinus for refractable angina. The whole anatomy changes. I found that CSP, that sheath itself, is a very elegant way of entering coronary sinus without any effort. Sometimes, when you're doing CSP, the CSP sheath, your coronary CSP sheath is already there in the coronary sinus most of the time. So it is inherent tendency of entering into the coronary sinus.
No, they have made beautiful curve, but still you cannot hook with the delivery sheath directly to the CS. You need some catheter, either multipurpose
once you enter,
or L or L2, L1, L3.
No, once you enter, into coronary system, half of the job is done.
Yeah.
Half of the fear is gone.
Yeah.
Then you can change with the ampullator, extra steep wear, any other wear. And
You can take Grand Slam, I take extra support Whisper most commonly, but you can take companies extra support wire also.
Thank you, Dr. Yadi Yadav. I think we have
Antiplatelet
to.
therapy. One question. Whenever you stent the CS for securing the lead, what is the antiplatelet therapy you follow?
We don't give any antiplatelet.
Because
Artery blocks doesn't matter. Vein blocks doesn't matter because these veins are very much collateralized. All veins, so you know, it's well connected veins. All veins in the CS is well connected. So you pass your wire, it comes out from above, it comes down from below. One case, Dr. Sanjeev Kathuria has shown persistent LSBC. He was not able to put the lead into the, throw the persistent LSBC into the So what? The wire came out into the RA, they snare the from femoral vein into the IBC and then stabbed it and then put the lead. So these veins are connected. It doesn't cause, no need of doubt.
whenever when dialysis
We don't want it patent.
When in dialysis patient, we do venoplasty with avoid stent because we know at times it will thrombose.
No, venoplasty in dialysis patient, even if there is because lot of having fistula, we don't stent. We don't stent. Here also, when we put the lead, we don't stent. Here we have only dilated with the balloon and put the lead. No stenting is done.
No.
Avoid stenting in both dialysis patient with fistula and also those who require stenosis of the subclavian vein, brachiocephalic vein, they require only ballooning, no stenting.
Sir, I have some comments regarding your presentations, what you showed. Now, in our initial learning curves, when we used to start doing CRTs, there we had a finite number of patients, or percentage of patients who had an acute lead dislodgement, CS lead dislodgement. But with maturity and the, your distal placement of your CS lead itself, now we, in our series itself, it's a rarity. Lead dislodgement, CS lead dislodgement is a rarity if you have properly placed it. Most importantly is...
No, it can occur late also.
No, I understand, but point is the technique of peeling off your sheath at the time of your taking out all the devices before putting your generator, that is the most important step. Somebody was asking about the sheath regarding engagement of the CS. What I tell to all the people who are doing CS cannulation in their learning curve is not only the entry into the CS is important, but more important is actually exiting out of the CS. Because the curve,
actually, you see,
not only the
I don't use
whatever technique, whatever technique one is adapted to, he can follow that rigorously or religiously. But point is selecting the curve, because the curve has to sit on the floor of the array unless, and you have to always peel your sheath or slit your sheath in the RO view, looking at the ostium of the coronary sinus to see whether you have a redundant loop. If you have a redundant loop, you're gone. Because at that moment, your CS lead can come out.
You see, I think good comments. I think we can have discussion over that. So there are many ways. I prefer slitting in LAO.
Because I use sliter only.
Bring this, to mid.
I don't use peel away. I use sliter only.
So maybe, so we have to
so
go to
I
next
have tricks and
presentation,
tips
sir.
how to avoid it.
Sir, we have to go to next presentation.
Okay.
May I request
Thank
Dr.
you, sir.
Suchit Majumdar to present on intrinsic ATP. So a lot of tips and tricks, like everyone has to do, his way of doing CRTs. And Suchit, please, to start. Dr. R.D. Yadav has got so many, people doing how to do a CRT. He's a veteran. He's been doing for last 25 years.
Thank you, Dilip. Thank you, chairpersons. Should start or? Yeah. So I think this talk was to be dealt by someone else, but I got the information yesterday that I have to deliver. Anyway, I'll just try to do justice to this talk. So regarding this intrinsic ATP, So historical ATP success for fast VT, that is less than 320 millisecond, is low, means it is around 50%. And if you see, even it is lower in case of you have an extended detection interval as per the different studies like the PREPARE study and ADVANCE 3 study and MADIT-RT. So average it is around 50% success rate of fast VT termination by ATP. So we should think of some ways of modifying the ATP so that we have a greater success rate of termination of not only the fast VT but also other monomorphic VT. So IATP is a individualized therapy in real time. It is dynamic. It is not fixed from before. So in usual things, you are fixing the ATP to a particular cycle length of the tachycardia, sometimes 88% or 91%, and you are assigning the burst and ramp or only burst. So, but here the machine or the device itself individualizes the ATP therapy for each VT. And if VT is redetected, then IATP automatically adjusts the next ATP sequence. So this is the usual IATP protocol where if the first ATP fails, it engages in a search for effective ATP train rather than following a pre-programmed progression. So there is a burst and then there is an extra stimulus protocol. So burst means S1. There is a pointer or something. Yeah. Pointer is this one. Yeah. So I got it. Yeah. So there is a burst. So S1 burst means at a particular interval it comes, and there is a S2 means which comes at a shorter intervals. And sometimes if S2 is also not resetting or failing to capture, it gives an S3. So this is how IATP works. Here also you can see this information is very important by which IATP adjusts its algorithm. So that is by calculating the post-pacing interval. I am going into details of that. So if you see here, normally cycle length of a circuit or a scar VT occurs because of a re-entry. And in re-entry there is something called as a physical length of the circuit. Then there is called as a wavelength. So the physical length of the circuit is the whole circuit length, which should be more than the wavelength. Wavelength is in the blue area. And the rest of the area of the physical circuit in which the wavelength is not there is called as an excitable gap. So this green area is called as an excitable gap. So when you pace from a place which is some distance from the circuit, so if you place from the RV lead, for example, the circuit is in the LV, in a scar VT mostly. So first there are 2-3 things. One, the circuit is running and there is an impulse coming towards the lead, and the lead is also pacing, the impulse is coming away from the lead. So if you pace faster than the VT, slowly this impulse wave, this collision area will go towards the circuit, and finally it will enter the circuit. And it can enter the circuit in different places. It can enter the circuit at the end of the excitable gap, or it can enter the circuit at the front of the excitable gap. So that is what makes a difference, that how this ATP is going to succeed or not. So again the same thing. So there are few scenarios. One, it can collide with the wavelength. So for example, the refractory area, that is green area, not the excitable gap. Then again this ATP is not going to be successful. If it enters the circuit, there are 2 ways. It can go back or front. So if it goes back and extinguishes the wavelength, but in the forward it entrains the tachycardia. So it speeds up the tachycardia in this form of ATP. What we want is that it should go in the leading wavefront of the excitable gap, such that it not only extinguishes the tail of the circuit, it also extinguishes the head of the circuit. Now how to do that? So that is why you have to calculate the electrical distance. So what is the distance from your pacing lead to the circuit? And the more you pace number of beats, S1, the more this faster than the VT, the more this electrical, the wavelength goes towards the circuit. So usually it takes around 10 S1 to get into the circuit. That's why 8 to 10 S1. That's why we have usually S1 is 8. And then if you pace at a faster length, shorter cycle length, you go to the circuit faster than pacing at the longer cycle length. So here you see S1, 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 it goes into the circuit, but it enters the circuit, extinguishes the head end, but tail end, but again the head end goes away and the VT continues. So what we do, in this case we give another impulse which is an S2. So what S2 does, it comes at a shorter interval than S1 and extinguishes the tail end. So unless you give this S2, this VT is not going to terminate. So you need not only require an S1 but an S2. That is the importance of this algorithm. So there are a few scenarios how ATP succeeds. One is an ATP success which extinguishes the head end and the tail end of the wavelength. Number two, ATP failed because the S2 doesn't reach. So S2 is not reaching the circuit, so it fails here. So it does not enter the circuit. Third, S2 reaches, but it resets the VT, but does not extinguish the head end, tail end of the circuit. And lastly, ATP fails because the S2 doesn't capture, because the whole area is refractory. So these are the four scenarios which can occur. And the remedy in each scenario is that if S2 doesn't reach the circuit, then you have to give more S1 because you have to manage the electrical distance more. If S2 resets the VT but doesn't terminate the VT, you have to give an earlier S2 that it reaches the tail end of the circuit. And thirdly, if ATP fails due to non-capture of S2, then you have to add S3. So this is how IATP works in all these scenarios. So again, it calculates something called as a post-pacing interval. So it paces the circuit and you see the return cycle, and return cycle is nothing but total cycle length plus 2x. X is this distance. So it goes like this, exits and come back. Then only it detects. So it is TCL plus 2x is the PPI, and by which it calculates the thing. So there are three scenarios again. So it can be failure to reset. Second, it can be in the reset zone. Then it can be in loss of capture. I'm not going to detail. So how to know this thing? The post-pacing interval will be extraordinarily long if you are having a failure to reset. The post-pacing interval will be normal if it's under the reset zone. And the post-pacing interval will be short if you have a loss of capture. And then the device calculates if you have a post-pacing interval which is long, it adds S1 stimuli. That means it is failure to reset and you need to shorten, you need to go again along the electrical distance to enter the circuit. If you have a reset zone normally, so you shorten the S2 so that the post-pacing interval is normal. So if the post-pacing interval is normal, still the VT is not terminating, you shorten the S2. If the post-pacing interval is short, then you lengthen S2 or add S3 because that means the S2 is refractory in that case. So regarding the study result, the IATP success is around 80% in overall. In the fast VT zone, it is for 58.7. In the VT zone, it is 84.9. So this was the initial studies. And another thing is the VT acceleration is not that great in this. It is 1.3 like other things only. And if you see the syncopal events or the arrhythmic syncope is again 0.4% if you use an IATP. Modeling study result, I am not going. This is digital twinning using this thing MRI and then the scar and then modeling it. So that was also studied in 259 virtual patients, and it showed that IATP resulted termination in more than 17% of the patients than the normal ATP. And coming to the real world result, so in real world result we can see that this is the result. So you can see that shocks are avoided in 93% of monomorphic VT, and IATP works in around 75% in case of fast VT and in case of 80% in case of monomorphic VT which is not fast. Okay, so IATP virtual modeling study demonstrated a relative shock reduction of 30% compared with traditional ATP, and real world analysis demonstrated a shock reduction of more, actually 48% compared with traditional ATP. And this is the personalized therapy study of IATP algorithm. This was published initially in IBHRE and then again in the Heart Rhythm. And it was a post-approval study. It was highly effective across all programmable therapy zone. 90% of IATP treated MVT episodes in the FVT zone, and 92 and 73% IATP treated MVT episodes in the VT zone and VF zone. And it is safe because acceleration is only around 4%, and shock is around 2.3%, and syncope, arrhythmia-related syncope is only 0.4 to 0.5%. So the Cobalt device, they have this IATP and eligible device programming. It is chosen as a chosen ATP therapy in any zone. It can be chosen in FVT, FVT and VF zone. And additional eligibility criteria, they are enrolled in the Medtronic network. In this study, it showed that 9 out of 10 monomorphic VT episodes were treated by IATP and it avoided shock. 84% IATP success for fast VT, highest reported among Medtronic ATP studies, and it is demonstrated safe because there is low rate of acceleration and less rate of arrhythmic syncope. So you can see here in this study you have an 84% success rate of IATP versus around 75% and 58% of usual ATP as seen by pain-free SST and advanced 3 studies. So thank you. No randomized trial is there. No.
Regarding the delay to deliver shock, means the time frame, means what is the limitation for IATP in the present scenario? How much delay it takes?
Delay to deliver shock, that is what you program in this, that is already there. IATP works in that even if you have a delay, means normal algorithm where you have
the patient
hemodynamical unstable, it will again shock, that there is no doubt in that. So it will be very fast, no? So it will not do that there.
Because the calculation of the post-pacing interval and all those. So the
no, in that case, I understand. So it is mostly effective in this algorithm, but if the VT is very fast in forming a VF zone, so again it will do ATP while charging and shock accordingly.
And
so it will not wait.
And your suggestion in the real world practice, do you recommend yourself programming your patients initially with IATP?
No, I think this is scientifically sound. We need more data. I think I will agree to that, programming in this IATP.
Yeah, Sujit, three issues. ATP-induced VF, how it works in slow VT, and third, if you incorporate too many AI or algorithms in the device, automatically drains the battery. So do you think we should harp on S1, S2, S3, more algorithms, more AI into the device that will decay the battery faster, or will make the device more smart and intelligent?
I personally think it is not going to change much of battery life. That is my idea. But exactly how much it decreases, I think company people can say exactly
so
how much.
VF and slow VT?
Slow VT it is working better because you have a bigger excitable gap. Definitely slow VT it works better.
VF, ATP-induced VF?
ATP-induced VF. So this acceleration and VF that occurred only in 4% of all the studies. But that is a real issue. Definitely it can happen, but it is less in case of IATP because it is calculating the excitable gap and it is not giving a very short S2 or something.
It's the most difficult topic, and I think it is not practiced regularly, but do you regularly practice it in all cases of ICD?
No, not. So I think this is limited to some devices, and I think it is not that I have a very big experience on using this. But what I think, what I read and all these things, it looks scientifically sound, and also the data as we have now looks good. So we can use, I think.
Thank you. Thank you,
Suchit. Thanks, chairpersons, for the session. And may I invite the chairpersons for the next session, Dr. Munna Das, Dr. Rohit Kumar, and Arun will speak on CRT non-responders.
There is no need to introduce Dr. Gopi because he is a lecture speaker. Yeah. So no need to introduce Dr. Gopi because he is a prolific speaker. Straight away to sir for your deliberate.
So, respected Chair, friends, colleagues, a warm good afternoon. At the outset, I thank Dilip for the opportunity, and so I'll be talking on one arena which you would all be dwelling on one time or the other, that is how do you manage a CRT non-responder. So everyone is equivocal in this, that CRT is highly beneficial with mortality reduction in care heart failure and companion trials, and this is a very well established data. Nobody has any doubt on this. But every implanter goes through this. The Achilles heel of CRT is 1/3 of them don't respond. There are numerous reasons to this, and the therapy also, the algorithm also caters to the reason behind a non-responder. So to first set things in the objective way, to define a non-responder, we go by LV, the reversal of the remodeling process. So look at the end systolic volume reduction. So if you have end systolic volume reduction between 0 to 14%, we have a rather end systolic volume reduction between 0 to 14% would be an average responder. A super responder is an end systolic volume reduction more than 30%. A responder is somewhere when the end systolic volume reduction is between 15 to 29%. A negative responder is where paradoxically end systolic volume increases, and 0 to 14% you would typically still call them as a non-responder. So the whole dictum of this talk would be how to convert a non-responder to responder, because you see that of all your heart failure patients, only 1/3 have LBBB. And once you treat them with this device, again 1/3 tend to be non-responder. So we would cater this towards a patient optimization, a device optimization, and what all you can do with the algorithms in the device. So primarily when you consider CRT, the crux of the thing is you need to understand you're giving an electrical therapy. The disease can be either a myocardial disease or an electrical disease. So every person who comes to you with heart failure would have a combination of an electrical dyssynchrony underlying his heart failure and a myocardial pathology. In fact, there is a combination of these two diseases existing in most of the patients, but some of the patients have a pure electrical problem causing heart failure. These patients will be super responder. Some of the patients will be having a purely myocardial pathology. These patients are just not going to respond. And the patients in between these two are the patients on whom we work on. So the first step in ensuring CRT response is selecting the right patient. So if you select a female with a non-ischemic heart failure, LBB morphology, typically white QRS, this is a sure shot responder candidate. You select a narrow person with narrow QRS, no LBB pattern, it's the sure shot candidate for non-response. So some of the areas in between are the gray zones. Again, we tend to believe that the QRS duration would be the single most important predictor to predict response, and the defibrillator benefit again goes up if you have an ischemic pathology. Now, first you select the right patient, next is to do the procedure in the right way. So in the lab, work on achieving the best QLV. Try to pace the part of the left ventricle that is last activated. So pacing at the site of latest activation, ensuring the maximum QLV is definitely going to improve your response rate. So you can do a wonderful CRT, you can get your LV to part of the vein which is the only vein you have, but finally you can end up your LV lead in a scar, and despite having done a good procedure, if your finally LV lead leads in a scar or in an area which is not last activated, you can still have a non-responder rate. Now, this has been systematically analyzed in studies. They have found suboptimal AV timing to be the biggest cause for non-response. The frequent arrhythmias, other causes, anemia is something which you can treat. Suboptimal LV lead position is one which you need to work during the procedure time. Ensuring better biventricular pacing is on which you work on the follow-up time. Medical therapy always needs to be optimized. If you have persistent mechanical dyssynchrony, you have an underlying narrow QRS, you have a compliance issues, you have RV dysfunction, these are no-brainers. You're not going to fit the device in these kind of patients. Now, when a non-responder comes to you, the first thing is go on your patient again. Was the patient a real good candidate for CRT? Was there a large scar in the lateral wall? Was there a real LBB that the patient had? If that was not the case, then there's no point of working around the algorithms. The next is look at the device that you have put in. Are the lead parameters okay? Are the pacing thresholds okay? Ensuring that there is LV capture. Are the AV delays optimally programmed? Do you want to have an echo assessment to program an AV delay? Are you ensuring adequate BIV capture? Are there arrhythmias which are compounding your BIV delivery? Is atrial chronotropic incompetence playing a role? And there are other things which you can work on. The thing that is again more neglected is optimizing the non-device part of it. Optimizing your medical therapy goes a long way because GDMT has gone a long way. Ensure RNEs are all there, Versiguat is there, and the medications are already in the best suitable way to ensure that the patients respond to a CRT as well. Look for any other cardiac conditions which is responsible for the non-response, like if there's residual ischemia, is there a valvular pathology like a persistent MR or an aortic valve obstruction which is causing the LV dysfunction. Again, go beyond the heart, look for any non-cardiac causes like sleep apnea, COPD, which might be again the reason for the patient's persistent symptoms. Now coming back to the device hardcore, ensure that there is more than 98% BiV pacing. This might be due to atrial arrhythmias, it might be because of improperly programmed AV delay, it might be because of frequent PVCs, it might be because of sensing issues in the device. So these are things which you need to work on. So this was a patient who had frequent ectopies which led to loss of BiV capture. So you can treat them with medical therapy, give them amiodarone, suppress the PVCs, you can ensure better response. This is the other case, you had a CRT non-responder rate, EF, the class was NYHA 3, 30% EF, BiV pacing was only 82% because of frequent PVCs. The PVCs were mapped and ablated, and after that you can see the biventricular pacing has improved and you have the EF recovery once you have suppressed the PVC which is causing a loss of BiV capture. Atrial arrhythmias are common entities. You can overdrive pace and suppress the arrhythmia. You can do an AV nodal ablation, obvious, and the best thing would be to avoid AV nodal ablation and treat the primary arrhythmia. You can do an atrial tachycardia ablation or an AF ablation and improve your CRT response. AV optimization is something on which you work in the device clinic. You have to have a satisfactory AV delay which gives you this, the mitral inflow pattern, that is E and A wave separated. The termination of A just after the QRS onset or the mitral valve closure click should be aligned with the end of A wave and the QRS. So if you have a AV interval which is too much short, you will have an absent A wave. If it is just too short, you will have a truncated A wave. Or if you have programmed AV delay which is too long, you will have merged E and A, on which you need to work on in your echo lab. In one point of time, we used to do this. There are numerous algorithms, iterative method, Ritter's method, all have been said and debated on, and these are more or less our time of the past. We don't do this much in the current scenario. Again, you can program the VV optimization as well, looking at the VV delays, which gives the narrowest QRS, which is the simplest thing which you can do. Otherwise, you can take the patient to the echo lab, ensure whichever VV timing gives the best LV outflow VTI, that can again be programmed. But you need to understand that none of these things are fixed. You are not having a patient lying on the echo lab and having the same AV delays or same VV delays programmed. It will change as per the activity of the patient, which might vary from minutes to hours. It will change based on the medication that you give. You give beta blockers, your PR is going to prolong. As the disease progresses itself, the QRS can widen and the disease can progress. And so these things, programming at one point of time in echo lab is not going to optimize. So the best way is go by the device algorithms which have been time tested. You have different algorithms from different vectors, different vendors, QCOP, SYNC-AV, adaptive CRT, all of these have been well tested, and they are in fact, I would say, better than echo optimization. Adaptive CRT, SYNC-AV, all what it looks at is ensuring minimal RV pacing. So what it does is, whenever there is a native good AV conduction, it allows the right ventricle to be depolarized by the native AV conduction and paces the left ventricle just after the native conduction depolarized right ventricle, and that is in way reducing the RV pacing, and that translates to a significant improvement of CRT. So adaptive CRT leads on to a 44% reduction of RV pacing and improving the response rate significantly. The other thing that you can do during a procedure to ensure that the LV lead is positioned in the right side is one of the things that Dr. Adi Adave said earlier. Using the active fixation lead, you have active fixation lead from Medtronic, which is screwing quadripolar lead. It can actually be fixed at the site, which gives you the last part of the LV to be activated. You can actually map the site, or you can go by QLV and then screw the lead, whichever has the last part of the LV to be activated, and fix it there. You can fix in the basal part, you can fix wherever the QLV is longest. Multipolar leads have actually changed the way we do CRT. It ensures stability, it avoids phrenic nerve stimulation, it avoids apical pacing, which is disastrous. It can circumvent a scar, and it gives you a lot of options to pace around. So moving on from bipolar to quadripolar, you have numerous vectors. You have opened up a Pandora's box. Now you have 16 vectors to play around. You don't have to reposition the lead to avoid phrenic nerve stimulation. You can do what is electronically repositioning the lead. You can actually do multi-point pacing and ensure better response. So this has actually improved the response rate of CRT, because you can now even pace LV from two different sides. You can circumvent scars, you can capture larger areas, you can improve hemodynamics, you can improve resynchronization, and thereby improve your CRT response rate. And this is what has been shown in trials. Multi-point pacing ensures that at least 19% more of patients are responders, and a 44% relative reduction in non-responder rates. Now, what are the options when you have a failed CRT? So you have something which is called an LV, endocardial pacing. We still don't have it. You can do a transeptal puncture and pace the LV on the endocardial side, which is the last part of the LV to be activated. Concerns regarding stroke, concerns regarding mitral valve issues were always a concern. You have wireless CRT, which might come in future. Still, the EBR-Y CRT is still already approved for human use in the US. They are already doing it. We might have this in future. But till all those things are there, conduct system pacing is the way you want to go forward when you have a CRT non-responder, because this all relies on the concept of longitudinal dissociation of fibers. Those are fibers which are designated for left bundle have already been dissociated earlier itself, and 90% of the time the block is actually in the proximal left bundle. So if you have a block in the proximal left bundle, you can always, so if you have a block in the proximal left bundle, you just have to place a lead in the site where you have the block. You can just pace distal to the site of the block, and that can actually ensure that you are able to resynchronize it well. So most of the time when you have a block, it's always in the proximal left bundle. You just have to place a lead distal to the site of block, and you can have a narrow QRS and ensure better resynchronization. And so this was earlier done with his bundle pacing, but now we know that this is uniformly done with left bundle branch pacing, which is actually more stable, which is actually giving a larger area to target and gives you more stable lead parameters. And this is well tested in trials, which shows that left bundle branch area pacing gives narrower QRS, better mortality reduction, better heart failure reduction, and better NYHA improvement. And this has also been shown in meta-analysis that you have better ECG parameters, better echo parameters, and better symptom reduction with conduct system pacing compared to CRT. The battle between CSP and CRT will go on. There are trials which have shown some benefit in favor of CRT recently, and a lot of trials which have showed some data in favor of CSP, but still the final verdict as per the guideline is CRT being the gold standard, CSP to be followed if you have a difficulty in implanting a CRT. But in scenarios where you are doing an AV nodal ablation, definitely there is data that left bundle branch area pacing is better than conventional CRT and his bundle area pacing. You can also, if a person is poor, you can, if cost is a constraint, you can put a dual chamber pacer, give the RV lead to be in the left bundle area and have a narrow QRS and ensure better response rate. You can also use it in QRS which are non-left bundle branch area morphology, like an RBB morphology, which can always be narrowed down with a his bundle pacing or a left bundle branch area pacing, and you can ensure better response rate. Or you can use best of both worlds, combine a CS lead with a left bundle branch area lead. That's what we typically do. Every patient, most of our CRTs would get a left bundle optimized CRT, which you can clearly see that the LOT CRT has the narrowest QRS. And this is shown in trials that HOT CRT or LOT CRT has better QRS reduction and better improvement of ejection fraction. Despite all of this, if the patient still continues to be a non-responder, involve the surgical team. There's a point of LVAD, there is definitely a role for heart transplant, and that is the final therapy or final destination therapy for all of our heart failure patients. So to conclude, ladies and gentlemen, whenever you deal with a person with a CRT non-responder, primarily assess your patient well. Understand the primary reason for a suboptimal CRT response in your clinical practice. It might be a very poor electrical substrate that you're dealing with, a non-LBV morphology, underlying narrow QRS rhythm. There's nothing much you can work around with this. You might have done a poor procedure by putting a lead in a suboptimal LV lead position. Again, there is a point of revising your lead, because if you have placed your lead in the apical position, or if you have placed in a lead in an anterior position, or the part of LV which is not last activated, again, you cannot work around with the lead and ensure better response rate. Or if you have placed your lead in an area of scar or functional block, again, this won't work. On the device, look at ensuring adequate BIV pacing. If you have persistent AFib, high PVC burden, you need to work on it. And you need to understand that every disease progresses, and you might reach a stage of end-stage myocardial disease. There, nothing much works. So the final thing is, if you're dealing with a poor electrical substrate, try what all things you can. You can try your fusion pacing on. You can actually even work around with a left bundle branch area pacing lead to have a better narrowing of QRS. You can try multi-point pacing. Try working around what all parameters you have with either a LOT CRT or multi-point pacing, and try to get the narrowest QRS. If you have done with a suboptimal LV lead position, try to relocate the lead. Whenever you do this, you use a quadripolar lead or an active fixation lead to pace the site of left ventricle which is last activated. Work on QLV. Whichever area has the best QLV, screw the lead there and then program it around. If you have loss of BIV pacing, this is one thing which you really need to work on. Every time patient comes on your follow-up, ensure more than 98% BIV pacing. If it's atrial arrhythmias causing the problem, you can focally ablate the atrial tachycardia. You can do a pulmonary vein isolation for AFib. And if it's persistent AFib, do an AV nodal ablation that significantly improves your CRT response rate. If it's a focal PVC which is causing the problem, ablate the focus of PVC, you can improve the biweave pacing. Again, work on all the device algorithms which really are time tested and you don't need to adjust it frequently. And once it is advanced heart failure, understand that you need to optimize your guideline-directed medical therapy better, use the other newer tools like CSP to improve your heart failure response rate, consider LV assist devices, and finally transplant when nothing works around. So thank you.
So, Dr. Gopi can take any questions from the house.
Right.
That's excellent overview. This active fixation lead, if you have chosen, taken from the packet, and you find that your coronary sinus is small and not active, it's a frequent problem I have seen. The coronary sinus distally becomes so diminutive that you cannot accommodate it. So what do? You take out and then take a different non-screw lead?
You need to understand that these veins are capacious. They respond to balloon angioplasties. You actually need, this screw will catch up. You just need to torque it up. If you even have 2 or 3 electrodes in, you can always screw the lead in. And most of the time, even if you are in the basal position, if you have 2 or 3 electrodes in, you might be in a good position which has a better QLV and still do it. You can actually still work around. It is seldom that we have opened up a quadripolar screwing leads and we have not used it. Majority of the time we have been able to somehow use all the interventional tools you have. You can do a balloon angioplasty, you have all the subcellular catheters in, you can open up these balloons, they will actually open up these veins, they will allow the distal part to go in, and then you can actually always screw in even in the CS body or in the proximal part of the vein, and then it will stay there.
Thank you, Arun. Shanmuga has to catch the flight, so may I request him to start his presentation. Thanks, the chairpersons.
We conclude the session. Thank you.
May I invite Dr. Madhuvanti Panja and Dr. Suni Banerjee sir to come on the chairs. Madhuvanti, please. Arijit, please. So next 1.5 to 2 hours will be really very high voltage conduction system pacing and leadless pacemakers. We have the best in India who are doing and performing these therapies. So Shanmuga will talk on future of conduction system. We are so excited that we started the session with the future of conduction system. What else is there in store for us?
He has already given a lecture probably 2 years back on the same. And let's see how, 2 years down the line,
further,
you are encouraging us to do the same thing. Thank you.
Thank you, sir. At the outset, I would like to thank Dilip sir for giving yet another opportunity. So I'm a frequent visitor of this place, at least for the last 7 years. I'm coming for the device update and giving the lecture on conduction system pacing, my favorite topic. So now it's a time to go for the future. So what is there available in the future to deal with conduction system pacing? First of all, why conduction system pacing? So you know any patient with white QRS and LV dysfunction needs some sort of resynchronization therapy. So this particular patient had a burnt out dilated cardiomyopathy. You can see the LV almost reaching 8 centimeter. And the left side you can see an image where the echo looks near normal with a good muscle mass. The difference between these two echoes, just 2 leads were added for this patient, and I waited patiently for 2 years for normalization of the LV function. So this happens quickly if you are intervening them at the early part of the natural history, but it takes time when you deal properly, getting the leads into the proper position. Unless proved otherwise, the patient with the dilated cardiomyopathy with left bundle branch block, when you're doing a clean...
Can I request Dr. Amrita Pal to be there on the chair, please?
So when you do a clean his bundle or left bundle pacing, they need to have improvisation of the LV function. So target sites for conduction system pacing, it's not about his bundle or left bundle. We have huge targets to approach the cardiac conduction system. In the ventricle, we have proximal left bundle, which can be approached above the tricuspid leaflet, distal his bundle just below the tricuspid leaflet. These days, we started penetrating the proximal aspect of the membranous septum to catch the left-sided his bundle just below the coronary cusp. Left bundle branch, you can target the proximal trunk, that is the most desired site. If you're not able to, then probably you can go into one of the fascicles, either into the anterior or posterior fascicle. Rarely we do right bundle pacing, but you need to know the anatomy of right bundle fibers to avoid complications during conduction system pacing. So of late we started doing atrial resynchronization therapy by capturing the Bachman bundles. So it all started with an experimental setup by Dr. Narula, who has used a temporary quadripolar catheter, EP catheter, to correct the wide QRS. So he has shown that pacing his bundle could correct both a left bundle branch block and right bundle branch block. So that was adapted by Dr. Deshmukh in the year 2000 and subsequently by Dr. Francisco Zenon and Dr. Pugalendra Vijayaraman, who has used that small 4.1 front sized 3830 lead to capture the his bundle. So how it works, we have learned that the fibers inside the his bundle are longitudinally dissociated. You can see any segmental disease within the his bundle could produce either right bundle or left bundle branch block. So this particular patient had a right bundle branch block. The lead was deployed in the proximal his bundle, proximal to the site of block. It was producing the same QRS morphology as right bundle with the baseline right bundle delay. When it was deployed just distally, it could correct the QRS and the patient had normalization of the LV function during follow-up. So over the last 15 years, we have also learned the nuances of this bundle pacing. So we know that it produces a lot of dislodgements, rise in threshold, and we are aiming for a narrow target zone. And it is always customary to put a backup right ventricular pacing when the patient is dependent. So there came the rescue, a left bundle branch block. Dr. Wong has introduced a simpler way of doing conduction system pacing by deploying the lead deep inside the proximal interventricular septum. So it was introduced in the year 2017, though he has done the first procedure way back in 2014, he struggled hard to get into the paper for almost 3 years, and finally, Canadian Journal of Cardiology, they have accepted it as a case report in the year 2018. Then the era of conduction system pacing has opened up. In the last 6-7 years, we have learned that his bundle pacing is the most physiological form of pacing, but it has its own limitation. Left bundle branch is technically easy, but it's always important to differentiate between the so-called left bundle pacing versus LV septal pacing because the outcome varies. We have also learned that during follow-up, there is a chance for a loss of conduction system capture in nearly 4% of the patient. And you can see almost 60% of this loss occurs during follow-up beyond 6 weeks. That is one thing which is of little concern because you have to serially follow up the patient. So I had a case where there was a loss of conduction system capture, not a true capture loss, a loss of conduction system capture after 4 years. So you have to clearly follow these patients, not only with the electrical parameters, but also with ECGs. And there are most important causes for this loss of capture, and you have to learn about what exactly is pseudofusion and what happens when the patient develops new onset LV dysfunction. What we can expect in the next few years, we will be having an improvisation in the implantation tools. Unlike the previous tools which were meant for doing RV septal pacing or for site-selected ventricular pacing, in the future we'll be having a dedicated left bundle pacing tools. And we have started using imaging to facilitate conduction system pacing. So just like doing OCT and IVUS for complex PCIs, imaging will help definitely for improvising the results of conduction system pacing. So we're going to combine technologies like defibrillation with conduction system pacing, leadless with conduction system pacing, and total cardiac electrical resynchronization where all possible cardiac conduction system fibers can be recaptured for producing better resynchronization. Obviously, future needs randomized trial for getting this into class 1 status. So these are the implantation tools which are introduced over the last 5-6 years, not only by Medtronic, but also by Abbott, Biotronic, Boston. In fact, Abbott went one step ahead in bringing a helix locking tool. So though 3830 luminous leads were the commonly used leads, the stylet-driven leads were also being used frequently now. The only challenge is to get the helix fixed while implantation and during follow-up. So at least during implantation, you can get it fixed with the help of the helix locking tool. It's a very simple tool which can be attached just before deploying the lead. It holds the helix in an extended position throughout the procedure. So that is very important because one of the most important cause for loss of capture during using the stylet-driven leads is helix retraction at the time of implantation. And Abbott is coming out with a dedicated leads for doing left bundle defibrillators. I'll be briefly touching upon it. It is the trial phases. It has not come into the market. So there is a dedicated catheter, there is a dedicated ICD lead which can be deployed right into the left bundle zone. Role of imaging, so we frequently do both cardiac MRI and CT coronary angiography for our patients who are planned for conduction system pacing. So how is it going to help? So cardiac MRI, it's going to assess the long-term prognosis of the patient. And in our centers where the resources are limited, so we decide about offering ICD therapy based on the imaging reports. And to decide about the modality of CRT, so I feel this is the most important step. When I'm doing a cardiac MRI, I'm going to decide whether my patient is going to get a dual chamber left bundle branch pacer, or a triple chamber LOT CRT, or a quadruple chamber LOT CRTD based on my MRI finding. And to measure the septal length, if I'm planning for a left bundle defibrillator, which is still not approved for clinical use, I measure the septal length based on my MRI finding. Cardiac CT angiography, can be done even before procedure or after procedure, just to decide about the site of deployment and to see whether the lead has got into the proximal conduction system or the distal conduction systems. I'll be briefly talking about hierarchical physiological pacing with the help of CT angiography. So this is how MRI is going to help. So all our patients with heart failure referred for device therapy will get an MRI. We'll try to classify them into 3 broad categories. One is no scar, where both biventricular pacing and conduction system pacing is going to work beautifully well. And severe scar, where you can see the whole myocardium is damaged, where neither the biventricular pacing nor the large CRTDs is going to offer maximum help for the patient. Ultimately, these patients will end up in getting a cardiac transplant. So the middle group, probably these are the most common group where the decision will be in a little dilemma. So I decide my device based on the distribution of the scar. So if I see the first image where the scar is restricted just above the conventional lead location, you can see I'm marked as 1 and 2. The conventional lead goes into, the left bundle lead goes into the zone 2 and 3. So if I see that the target zone for left bundle pacing is free of scar, I'll definitely go for a conduction system pacing. You can see the lower image where the scar is predominantly over 4, 5, 6. This is the infralateral valve where the coronary sinus lead is going to get into. So we know any lead deployment over the scar is going to produce high threshold, predisposition for ventricular arrhythmias, and they will fall into the non-responder category. And these are ideal candidates to go for left bundle pacing despite having a dilated cardiomyopathy and LV dysfunction. That is a typical example where the patient had anterior valve MI, scar restricted to the anterior septum and anterior valve. If you go into the MRI of patients with QRVB anterior valve MI, still you will have inferior septum supplied by right coronary artery, which will be scar-free. So even in patients with ischemic cardiomyopathy, you can see some surviving myocardium in the inferior septum where you can get the posterior fascicles. So it's better to get an MRI in patients with cardiomyopathy, especially ischemic cardiomyopathy, so that you can have an idea whether you will be able to get your conduction system pacing lead into the target zone. A complex congenital heart disease, it not only helps us in assessing the scar, but also about the anatomical challenges. This particular kid had a surgery for AV canal defect. The left bundle was injured at the time of surgery, developed LBBB-induced cardiomyopathy. You can see his bundle was displaced down. You know, any complex congenital heart disease will be having displaced bundles and AV nodes, and the course was it goes down and ascends up to reach the target zone. So luckily we get into the left bundle with the help of dual chamber pacer, and we could produce a good resynchronization therapy. So this is what we have utilized in our Madurai LBBP study, where we had risk categorized the patient into 2 major groups, those with low scar burden and those with high scar burden. So low scar burden group received only a pacer without ICD, and high scar burden patient group received both pacer and ICD. So the pacing is predominantly left bundle. Only if it is incorrectable, then we'll put an additional coronary sinus lead. So what we could show was those patients with a low scar burden who had received just a dual chamber pacemaker did excellently well during follow-up. The event rates were much, much less. And those patients with high scar burden, despite getting a LOT CRT therapy and LOT CRTD therapy, the event rates were very high because of a high distribution of the scar. So coming to CT angiography, so we started our preliminary study on CT angiography. So we used a specially designed software to reconstruct the conduction system anatomy. This is not commercially available. So these were all done in post-procedure patient. We did CT angiography during follow-up. We categorized the patient into main truncal pacing, fascicular pacing, and LV septal pacing based on the lead distribution. Since it was a preliminary study, we just compared it with the electrical parameters. So if the software says that it is a truncal pacing, we'll compare the electrical parameters to see whether the capture pattern is the truncal capture. If it says it is fascicular pacing, it was compared with the electrical parameters, and there was a 95% correlation between the CT angiographic data and electrical parameters data. Then we went one step ahead in doing a pre-procedural CT angiography, reconstruct the anatomy with the help of a software based on fixed anatomical landmark, and the 3D anatomy of left bundle fibers will be reconstructed, and this will be superimposed on the fluoroscopy. So you can see the fluoroscopy image is being merged with the conduction system fiber anatomy, and this is being used for doing a left bundle pacing, his bundle pacing, and for Bachman bundle pacing. So you'll have a rough idea of where to target. So this is especially useful for those patients who are going to start the procedure without knowing where exactly the bundles are. So this CT angiography, or so-called anatomy-guided approach, is going to facilitate targeted lead deployment, and it is going to increase the success rate in complex anatomy, and for beginners it is going to simplify the procedures. I believe I have another 3-4 minutes to discuss about leadless pacing. So the next thing is combining the technologies, so defibrillation with the CSP. So if you are going to do something new, we need to work on it before going or innovating the techniques. So we started doing lot ICDs and lot CRTDs, where the ICDs leads were still going into the conventional location, but with the help of a DF1 lead, we could add one more left bundle lead and convert it into a lot ICD. So what we did was we have analyzed that patients who were having a left bundle lead for ICD sensing. So we need to be sure that the left bundle lead in the deep septal location is sensing the arrhythmias properly or not. So only then you can deploy the ICD leads directly into the left bundle. So you need to be very careful, and you will be doubly sure that your ICD leads which are going to get into the left bundle will work well and it will not do any harm for the patient. So we did a retrospective analysis before straight away getting into the left bundle. What we did was we analyzed all our patients who had received lot ICDs and lot CRTDs. What we could find was almost 90% of the time the arrhythmia sensing and treatment was appropriate. So only in one patient, because of a particular device variety, the patient had T-wave oversensing, and that had contributed to nearly 10% of inappropriate arrhythmia detection. Luckily, none of this inappropriately detected arrhythmias received any shocks. Few ATPs were given, but what we have learned was when you deploy the lead deep inside the septum to capture the left bundle fibers, it's going to sense the arrhythmia appropriately, and it's going to deliver the therapy appropriately. So this is the preliminary groundwork which we have done. Then we thought of combining this CSP with the ICD technology. So the advantages being delivery of ATP will be very good, because you can quickly get into the conduction system to do this overdrive pacing, and it reduces the lead-lead interaction, reduces the lead fracture, reduces the incidence of lead-related tricuspid regurgitation. Obviously, it is going to reduce the cost constraint. But concerns, yeah, we need to have discuss about the concerns before getting into an innovation. So bulky lead, getting into the septum. You need to have a specially designed delivery catheter, and the ICD coil length varies between different vendors. Abbott has 5 centimeter, Medtronic has 6.5 centimeter. Atrial oversensing, Abbott has a true bipolar, Medtronic has integrated bipolar, and appropriate detection and delivery of therapy should be ensured to ensure the safety of the patient. So we started with the DF1 Durata lead, because one thing DF1 lead offers the using of this helix locking device, and Durata lead's coil length is 5 centimeter, and it has a true bipolar rather than an integrated bipolar. So we need to pre-deploy the lead while in the table. So this is with the help of the helix locking tool. The lead is pre-deployed, then it will be taken into the conventional locator 3D catheter. So this catheter takes this bulky ICD lead, though it will be great difficulty in initial few cases, it was challenging, but subsequent cases we could get into it and we could deploy the lead inside the septum. So this was a pilot study which we could get into the left bundle without much difficulty, and there was not much of concern during follow-up. So now I have almost 2 years follow-up of this ICD lead patients within the left bundle, and all these patients were doing well without perforation and without inappropriate arrhythmia detection. So this was a pilot study from the Abbott per se. So they have a dedicated catheter now. They have a dedicated sheath now. So it is super good for getting into the left bundle. The lead is specifically designed for easy penetration. So you can see, just like putting a Brady lead, your tachy lead, HV lead goes easily into the LV subendocardium. We did a post-procedure CT for this patient where you can show that lead tip is banging the LV subendocardium to selectively capture the left bundle fibers. Once you have selective capture, we'll be able to see this retrograde hiss, which confirms that you are in the true left bundle, not in the LV septum. So combining the technologies, leadless with conduction system pacing. So leadless technology is there in the market for at least 10 years now. So these being deployed in the RV apex or in the RV apical septum. So with the interest of CRT non-responders and with the interest in conduction system pacing, people are very much eager in getting these leads directly into the LV. So in fact, one of the main therapy for non-responders of CRT is to get this YCRT system in the LV endocardium. Previously, they were putting it on the LV lateral wall, but with the advent of left bundle pacing, they have learned that these electrodes can be directly implanted over the LV subendocardium just below the aortic cusp. So they've tried retrogradely. Initially, they were using the transapical approach. Then they tried retrogradely. Now, off late, they've started implanting it by a transeptal puncture. So all you need to do is take a venous puncture, femoral vein, puncture the interatrial septum and go across the mitral valve to enter into the LV subendocardium. This lead has a fin of 2.8 millimeter. It's all the more sufficient because the left bundle fibers are truly LV subendocardium. You just have to penetrate 1 or 2 millimeter into the LV subendocardium to capture the left bundle fibers. So with the 2.8 millimeter fins, I think it will be easy to get into the conduction system fibers directly. So you can use the electrodes, you can use the transmitter which can be placed in the pectoralis major muscle to directly stimulate it. And this is especially useful for those patients who are already having a CRTP or CRTD device and they were non-responders. So with the advent of leadless pacing, the leadless conduction system pacing is also being immersed. So Abbott is the first one to try clinically. So they have used their conventional AWARE device to implant it directly into the conduction system. So there are some limitations with the currently available model. The helix is just 8 millimeter. Getting from the groin will be really difficult, but getting it into the conduction system from the jugular will be much easy because it naturally aligns with the course of the catheter. So you just have to take a jugular puncture and go cross the tricuspid valve, flux it little bit, go into the proximal septum. Just like deploying the conduction system pacing lead, you have to just deploy it deep inside. So, but this being an 8 millimeter, majority of the patient which were presented in the late-breaking clinical trial were having LBB area pacing, not a true left bundle pacing. But when some modifications will be introduced in the future, probably they'll be planning to elongate the helix little bit longer, then probably you'll be able to get the conduction system. A word about atrial conduction system pacing. We know the electrical communication between left atrium and right atrium is through the Bachmann bundle, though some coronary sinus fibers can also electrically connect. The predominant electrical connection between left atrium and the right atrium is the Bachmann bundle. So it has some weird course. It's not a straightforward bundle as you thought, just like a left bundle or his bundle. So the fibers are differently oriented from the nearby atrial myocardial fibers. Starts from the SA node, winds across the SVC as two slings, and it reaches the other end of the SVC just below the SVC RA junction, and then it dips down little before ascent step and gets into the LA through the superior limbus of fossa ovalis. You can see the yellow marking. This is the typical course of a so-called Bachmann bundle fibers. So you can catch the Bachmann bundle fibers anywhere along its course, not on the crista terminalis side, but on the other side. So we predominantly work in left anterior oblique view with either S5 or S4 catheter, which is specifically designed for doing atrial conduction system pacing. So you know the atrial conduction system is little difficult to capture. You may have to have at least a thin size lead so that it stays there. We always use this 3830 leads. So you can capture it anywhere along. So what we have learned in the last 2 years was when you capture proximally, you need to have a disease-free atrial conduction system fibers. The Bachmann bundle might be diseased, so when we feel that the superior aspect is little diseased, we may go little below at the interatrial septal side to capture the bundles where you will be able to get a peak to P wave. So you can get a tall potential just like getting a his bundle potential. So combining the conduction system pacing technologies, you can combine his bundle and left bundle specifically for patients with baseline right bundle branch block. The first modality should be his bundle. So I urge every one of you to learn the technique of his bundle as well, because many of the times it salvages you from surprises. So we rarely do right bundle pacing, especially for patients with underlying right bundle branch block. This particular patient had a baseline QRBB right bundle branch block, anterior wall MA with severe LV dysfunction. Fortunately, the distal ICD lead got into the distal aspect of the right bundle. We could show a non-selective to selective capture of the right bundle fibers distally. Though we didn't use it for capturing this CRTD capture, but still it can be used when the patient has a baseline right bundle, or when you are doing an AVJ ablation, you can put one lead in the right bundle, one lead in the left bundle, because you know the atrium is not going to get any lead. So this can provide a total electrical resynchronization for the ventricle. So you can not only provide a total electrical resynchronization for the ventricle, but for also the whole heart. What we call it as a combined activation of both atrium and ventricle through physiological pacing. So this was again a pilot study which we did. We combined both Bachmann bundle pacing and left bundle pacing. The data was really encouraging. We could deploy the 3830 leads into both the Bachmann bundle and left bundle. And Bachmann bundle pacing probably will be useful for patients with underlying Sixina syndrome, where it reduces the incidence of atrial arrhythmias in patients with diastolic heart failure, where because of a better interatrial synchrony, it's going to reduce the LA pressure and reduces the incidence of the heart failure. So these are all the studies which are available so far for CSP as an alternative for cardiac resynchronization therapy. But what we need is a randomized trial. So this is the future. One of the largest studies is the left versus left, which is going to recruit 2,100 patients. The study is already underway. And once the results of this randomized trials will be out, probably you may have an upgradation in the indication of CRT for conduction system pacing. So from 2B and 2A, probably it will go up to reach class 1 indication for CRT. And thank you very much for your patient listening.
When you use ICD lead as a left bundle pacing or conduction system pacing, you have to induce the VF. Otherwise, you are not sure that whether it will able to sense the VF or not.
So
how much sensitivity you accept?
Yeah, so it was a routine protocol. Only if you are going to do a DFT, we will put the left bundle lead into the ICD lead into the left bundle. So all the patients were subjected for a DFT, and the threshold is if we get a shock reversal by 25 joules, it will be accepted, because the maximum available joule is 35 or 40 joules. So you need to have at least 10 joules safety margin.
10 joules.
Yeah, so that is a protocol which we follow.
How much, say, when you put into the conduction system, ICD lead, how much ventricular sensitivity you want? So by how much, like we want in the usual apex or septum, 5 volt, 5 millivolt of the sensitivity by the lead.
Ventricular pacing,
no, sensing.
Sensing,
so how much?
R-wave sensing.
Minimum required is R-wave is 5 millivolt. Whereas in conduction system, what is the minimum? Is there minimum?
No, actually it will be super
Apart
sensitive,
from that,
because
there is induction and then.
yeah, so here in fact the lead being in the deep septum, it is super sensitive. In fact, that was the problem with one of the patient where even the T waves were sensing very well. So sensing will be no issues at all. We just take the cutoff of the same ventricular thing, 4 or 5 millivolt with a good slew rate. But more importantly, it is important to avoid atrial oversensing, because in our study we have deferred one patient because the lead was picking up an atrial signal. It was a very transient, momentary atrial picking for a single beat, but still it was not safe for the patient, so we just deferred and put the lead in the conventional
Because it's
position.
quite high, no? That's why.
Yeah, it was. So it is advisable to go into the fascicles, not to the trunk, at least for integrated bipolar leads. But for true bipolar, still you can go for truncal pacing.
Any comments from our chairpersons?
Any lead
one,
modification?
One question I would like to ask, sir. Yes. In left bundle area pacing, the only concern seemed to be that there is a loss of capture leading to loss of ejection fraction, ventricular dysfunction, how to treat it if we are sure that is the cause? Do we take
exactly.
do we put a RV lead or what do
So
we do?
that's a good question. In fact, the loss of conduction system, and I'm not talking about true loss of capture. Loss of conduction system capture is a big concern, not only with conduction system pacing, but also with the CRT. We can have at least 2 to 8% loss of capture. So here there will be a consistent capture of the ventricular myocardium. Just because you are having a loss of conduction system capture, the patient can have LV dysfunction. In fact, we published an article last year where we had gathered patients with baseline normal LV function, CSP done, and LV dysfunction patient, CSP done, and LV function improved. So basically we had 2 different groups, 200 each in 200 patients in each group, where they had a normal LV function, either to begin with or after conduction system pacing. We have followed the patient. The mean follow-up was close to 2 years. The incidence was 4%. 4% patients had a new onset LV dysfunction. So we analyzed retrospectively what was the reason for this new onset LV dysfunction. The loss of conduction system capture was the predominant cause. So we went one step ahead in finding out why this happening, why loss of conduction system capture is happening. So we could see that when the patient was showing a non-selective to selective transition at the time of implantation. So what does that infer? So your lead is really deep in, it is touching the LV subendocardium, capturing the left bundle fibers. Only if it is touching the left bundle fibers on the LV subendocardium, you will have this non-selective to selective capture transition. So we did CT angiogram of 100 patients. We measured the distance between the lead tip to the LV blood pool. In those patients with the selective capture transition, it was 0 millimeter. That was really close to the LV blood pool. In those patients, the loss of conduction system capture during follow-up is less. But when you leave the lead in the mid-septum, for example, very high output capture of left bundle or only an LV septal pacing, the loss of capture is very high and these patients tend to develop LV dysfunction during follow-up. So it is very important to deploy the lead as deep as possible. It's not about that non-selective to selective capture transition is going to help the patient acutely, but on the long run, even if the lead comes back by 1 or 2 millimeter, the lead migration is close to 1 to 2 millimeters. So we did a PAT CT at 0 months and 6 months. The lead migration, 1 to 2 millimeter migration can still happen. And there was a histology study by Cabrera where he has shown that the thickness of left bundle fibers is 1 to 2 millimeter. That means that 1 to 2 millimeter margin of error is acceptable. Even if the lead comes back by 1 or 2 millimeter, still you will be touching the left bundle, you will have consistent capture. So your procedure should be clean. At the time of implantation, you have to go all the way deep inside the septum to capture the left bundle fibers, not the LV septal fibers. And that left bundle capture threshold should be less than 1 mole. In those cases, the incidence of loss of conduction system capture during follow-up will come down. And obviously, the incidence is more with styler-driven leads as compared to lumenless leads. And there are other factors like challenging anatomy, around fibrosis around that deployment site. But I feel this is the most important step. When you're doing the procedure, do it very clean and get into the conduction system.
About the conduction system, defibrillation by the Medtronic, they have Omnia Secure lead with ICD having 4.7 French with helix, fixed helix like 3830, where you can put the conduction system pacing along with the defibrillation.
Yes, sir. So I cannot tell the specification of this Abbott lead because it's a trial lead and
this is
we are bound
from
to.
Medtronic, Omnia Secure lead
That's
is
what
from
I'm telling,
Medtronic.
sir. Yeah, so that's what I'm telling. So I cannot tell the specification about this Abbott lead because Abbott lead has a different specification than the current Abbott ICD lead, Jurata lead. This Abbott lead has a different specification. The issues with Omnia Secure is it is going to be an integrated bipolar. It's not a true bipolar. And the length is, the ICD coil length is 6.5 centimeter. Though it compromises it has a good dimension when it goes into the ventricular cavity. But because of this, you have to push the lead into the ventricle to avoid atrial oversensing. So that is one challenge with Omnia Secure lead. Probably if you, in future we know, when you have a direct head-to-head comparison, you know.
Thank you, Sarmuga. It's one.
Omnia Secure is integrated bipolar.
I think we can, Madhuvanti, one last question.
What's the criteria of Bachman bundle pacing? When should we do?
There is a dedicated session on that. We'll address that. Yeah. So,
question.
Sir, Abhijit, yeah.
Do you still feel that with this intricate, to my mind, LVB pacing is an intricate thing. do you feel that it should be done blinded, fluoro-guided as we non-electrophysiologists are doing right now?
Which one, sir? I can't get you.
Do you still feel, after you are saying that you have to capture the left bundle branch very selectively to prevent further non-capture, and the percentage is almost close to 4%, do you still feel that it should be done as a blinded fluoro-guided procedure?
Yeah, so it's again, it's a big debate whether to do it with the EP system or not. So I feel for bradyarrhythmia correction still without EP system is good enough, but for when you are dealing with a heart failure patient, when you are doing it as an alternative for CRT, it's better to do it with an EP system. EP system assures you and it tells you whether you are capturing the conduction system or not.
Thank you. Thank you, Sarmuga. And we go to the next presentation by Dr. Devbroto Bera, and thanks, chairpersons. So may I request the chairpersons for the next session, Dr. Sandeepan Sarkar, Dr. Suasis Rai Chaudhary. And we have a very good panel discussion which I planned. I think we have to do it without Sanmuga. He has to leave for airport. So we'll do it after the presentations are over.
So at that said, I should thank Dilip for organizing this yearly sessions every year very consistently. And at the outset again, I thank Dr. Shanmuga, who has been the teacher for many of us like me, and almost like hand holding and teaching the conduction system pacing. Now, just because we have been discussed about the future of CSP, I have made the heading like coming back to the present. I'll take this opportunity to discuss about stellar-driven lead versus lumenless lead. And Shanmuga sir, have a safe flight. Bye-bye. Thank you. So we have already discussed that why conduction system pacing is beneficial, because it ensures resynchrony of the myocardium. And initially we started the his bundle lead. We went to left bundle lead now because of several reasons we can discuss separately. It is in one sentence, it is more stable lead. There is a minimal chance of threshold increment, and it is more easily doable. Now, there are two types of lead, lumenless lead versus stellar-driven lead. Lumenless lead comes from Medtronic, and stellar-driven lead comes from the other three vendors. So, I'll just take a quick through, because I can see many youngsters who are not doing that numbers of conduction system pacing. Before I go into the intricate details about a debate, almost a debate of whether you should prefer a stellar-driven lead versus a lumenless lead. Because many of us in the audience are non-EP, I'm trying to show how to do it without EP system. You just need a 12-lead running ECG on your monitor. Many of the newer Philips Cath lab actually have a running 12-lead ECG. And if you have the 12-lead ECG, just remember that this image also taken from Dr. Shanmuga, that if you have a temporary pacemaker in the right ventricle, just below this hump of the temporary pacemaker is your main left bundle. You can come up to here where you have the left posterior fascicle. You remember that your diaphragm, if you see in RAO view, if you draw a line near the dome of diaphragm, around the lowest 1/3 or lowest 2 centimeter you should avoid, because there is no conduction tissue. They are too much of bifurcated, but this is the large area. If I even remove that and you remove the his bundle catheter from there, you know that this is the area of target if you are targeting a left bundle pacing. Some people take a pigtail shoot from the right ventricle to see where is the coronary sinus, and rest of the myocardium, as in the RAO view, you can see it is the right ventricular septum. On the other side, you have the left ventricular septum. I'm just showing quickly that this is one of Abbott implant, and the sheath actually comes in the default shape. If you take it, it generally takes you to the lower side left posterior fascicle. So I generally reshape the sheath, and then I take the sheath with the terumo wire into the right ventricular outflow tract. And on that, you get a support to take the sheath and dilator into the right ventricle. Once you are there, sometimes you are unable to take the terumo wire into the right ventricular outflow tract. So you can just put it in the right ventricle. Be careful you are not in the middle cardiac vein. And on that, you reach with the sheath. Generally, it takes you just below that hump of the temporary where is your target site. Sometimes it will be too much ahead. You have to drag it back with the lead inside. Or sometimes you are too high, you have to pull it back to the site where you want. This will tell you, then you have to deploy the lead in the LAO view. Before that, what I'm trying to show you, that you have to, connection has to be in unipolar, because the tip is outside or just outside the sheath, but your anode is still inside the sheath. So if you do a usual bipolar connection, it will be showing a high impedance and you will be unable to capture the myocardium. So this is a unipolar connection. When you connect the black thing into the stylet and the red to the alleys or the mastoid forceps or the muscle. So once you in the right ventricular septum, how do you know from the right ventricle itself that once you drill the lead, you are going to achieve a left bundle pacing? So it is like predicting from the opposite side that if I drill the lead, I am going to capture the left bundle fascicle, which is on the other side, almost the subendocardium of the septum. So most important is a lead 2 and 3 discordance and AVR-AVL discordance. In this particular case, even before drilling, what you find, lead 2 is positive, 3 is negative, AVR is negative, AVL is positive. What do we mean by this? That if you are too high, your catheter is too high, you are going to get 2, 3 AVF all positive and AVR, AVL both negative. If your catheter is too low, you are going to get 2, 3 AVF all negative, and automatically your AVR and AVL will become positive. So again I re-emphasize, preferably 2, 3 discordance, and AVR, AVL discordance will tell you from superior-inferior aspect, you are middle of the heart. Similarly, if you look at the lead V1, if the lead V1 shows some notch like this, with a notch in the ascending limb, you know you are more basal. If your sheath or catheter is too much anterior, where you do not have the main fascicles or left bundle, there is no point drilling or attempting the lead to drill. Some people ask that if you have to begin with, you have a complete heart block or a right bundle branch block, is the process change or the procedure changes? It's not at all, because any patient, whoever has a right bundle branch block to begin with, as you pace, the whole procedure has to be done during pacing. You are anyway going to get a left bundle kind of a pattern when you start pacing on the right ventricular septum, and as you drill in, you will finally achieve a right bundle delay morphology. So irrespective of your baseline QRS, irrespective of your morphology, you are starting with a LBBB and preferably with a notch, and you are trying to finish, your target is to finish with a RBBB. So this is after you have gone to LAO. With the LAO, you just rotate the screw with the usual pacing of apical or septal pacing you do, and you expose the helix. Then you have to fix this with the lead locking tool, so that when you do the manual drilling, which I will be showing next. So rest of the procedure has to be manual drilling. The wire has been connected so that you have a continuous electrode and electrical picture you see. So as you are now drilling manually, there are many ways. It depends on the operator preferences. This is one of the way you do. So you start with the LBBB morphology with a notch. Don't look at the other leads. You have already decided on that 2, 3 discordance and AVR-AVL discordance. As you drill in midway, you will find something like this, which is called left ventricular septal pacing or a deep septal pacing. You have a narrowness of the QRS and the notch has slightly climbed up almost at the end of the QRS. As you drill a little more, you get a R prime or right bundle delay morphology. If you are happy with the parameters, thresholds and impedance, you are ready to slit the sheath. 2 things you need to see, whether you have a good current up injury, as you see here, that you have a good current up injury, it is like a local ST elevation. But if you drill a little further, you might get a loss. If you are trying to achieve a perfection, sometimes around 20% of the time, you will end up perforating the lead into the left ventricular endocardium. Immediately your thresholds will go up, the impedance will come down below 300, 200. And here as you see, the local impedance, local current of injury will be very low. So you know that you have perforated into the left ventricle, which is not a crime. You just reposition the sheath and redo the procedure again, just take out the lead, clean it. Once you are happy with your parameters, you need to slit it, because the usual leads come with a 58 centimeter. The length is not enough. You have to be a little careful. I rest my hand on my assistant's hand and slit the sheath. The initial part, there will be little resistance and then it will be fine. I'll just show one case to show that, how much time? 2 minutes, yeah. So this is one of a case where I have a LBBB and DCM and you have a done a procedure. This is the result on table. And next day you find this is the ECG. So this was done for resynchronization. You find that your purpose of procedure is lost. you still have a LBBB here. So what are the things in mind? First thing you should come in mind is my lead has dislodged, either a macro or a micro dislodgement. If your X-ray shows that you have not macro dislodgement, there could be a micro dislodgement and loss of left bundle capture. You also should think about something called anodal capture. If you have a concentric LVH, your septum is thick, this is the anode, this is the cathode. In addition to cathode, the anode starts capturing, and you can find this kind of a LBBB morphology on a next day where you have done a very beautiful procedure. You have to be careful. Always check any patient on same day or next day. Always check in unipolar mode and always check in VVI mode. Now as you see the pacing spike here, anodal capture is not a possibility because you are already pacing in unipolar mode. So when you checked in VVI, you find we have enough left bundle capture. The only thing in this case was to do that AV delay optimization. Your AV delay has to be ultra short because you have to compete with the native conduction. And in this case, we have finally programmed at a sensed AV delay of 50 milliseconds. You can do conduction system pacing without EP system, even without 12 lead running ECG. Just with the Abbott programmer, you can have this chest electrode, you see LBBB morphology. Once you have drilled the lead, you can see the RBBB morphology, but it's generally difficult to do. Now, if it is so great and these studies have shown that it is great, why don't you choose for all? So before you do that, I'll just go into a debate of few, because that main topic is conduction system pacing versus stellar driven versus lumenless lead. There had been many papers. This is the latest paper, which is a randomized trial, which have shown that reasonable results are very similar for stellar driven lead and lumenless lead. Although they have found that the fluoroscopy time, the learning curve, everything is very similar. There are one difference is the late loss of left bundle capture is slightly more on the stellar driven lead. Our experiences has been a little different. I'm just showing these unpublished data. Just I'm showing a data of around 220 patients of a stellar driven lead versus 35 patients of lumenless lead. The success rate to deliver the lead, can I take 1.5 minutes more, Dilipda? So, and thank you. So the success rate to deliver the lead is 95%, 94 to 95% in stellar driven lead, whereas the initial success for lumenless lead was 60%. The main challenge came to drill the lead because the Medtronic sheath is little flimsy, so it doesn't give you much stability, whereas the Abbott sheath is a sturdy sheath with a braided sheath. It gives you stability. Once you have anchored in a desired space, it doesn't move when you're trying to drill, whereas the Medtronic lead, as you try to drill it in rapidly, it sometimes dislodges everything. So I feel this is more of a operator dependent. There has been operators like Shanmuga who does it very smoothly. I have seen him doing, so I think it is operator dependent. The median attempt of screwing in stellar driven lead, I have found 1, whereas in Medtronic in my cases has been 3. The intermediate and long-term results are reasonably good. In Medtronic, generally the shape is such that it takes you to the main left bundle area, whereas stellar driven lead, it 50% of the time takes you to the main left bundle area once you shape the sheath. Otherwise, it takes you to the left posterior fascicle, which is anyway accepted way of conduction system pacing. So coming to the reasonable comparison, obviously lumenless lead is better and long-term data is available for us, but I think it is, the drilling is more operator dependent. And it has a little longer learning curve. It has, at least for me, has more attempts and longer fluoro and procedural time. Stellar driven leads are obviously easier to do because of the study nature of the sheath as well as the lead. Obviously, it also gives you where to stop because you have a beat-to-beat monitoring of the impedance, QRS morphology and current of injury. I'll just show one case here. This is one of the case where the LBBB DCM patient, we are doing conduction system pacing. As you see here, you have already seen a notch, the QRS has become narrowed. Shall we stop here? So because we have every beat-to-beat impedance monitoring, I had the courage or I had the confidence to go a little more. And then as Shanmuga was telling that you have to do the procedure as best as possible. So until I reached where there is a prominent R prime and there was a change in non-selective selective, I could drill in. Obviously there will be a little chance of on-table perforation, which is all right, you can do the procedure again. So I'm skipping some of the slides. I'll just show that one of the subset of patients where I have done procedure for LV dysfunction, almost 90% of them had improvement in the NIHA class by at least 1, 72% had echo improvement at least by 10%, and 50% of them were super responder, which is, I think, in my cohort is better than CRT data. This is just some meta-analysis and everything, just a summary of this, that I feel The acute success is more for stellate-driven lead with a shorter fluoro time. Obviously, the late loss of left bundle capture is lesser for lumenless lead, whereas more for stellate-driven lead. Helix retraction is something unique entity which is not possible for the lumenless lead. It is possible for stellate-driven lead. You have to be careful on table. Longer data is available for lumenless lead, longer safety data available for lumenless lead. For the stellate-driven lead, I have been very vigilant, and every 6 months I personally go and check the devices for any lead noise, because technicians will tell you everything is all right. The first abnormality will come in the device is like non-sustained VT, high ventricular rate episodes, or lead noise even before the lead goes off. This has to be kept in mind, because it has been proven that any lead, any of the stellate-driven versus lumenless lead has more complications, short-term complications than a conventional pacing lead. So you have to be vigilant when you are giving for a dependent patient. This is what I'm trying to say. Why not for all? If you have a reason to go for a conduction system pacing, like patient who has a moderate LV dysfunction, needs a ventricular pacing, you is not yet a candidate for CRT, you go for it. Otherwise, there are concerns for conduction system pacing lead, both for lumenless as well as stellate-driven leads. So the take-home message is select your cases. The best candidates are pacing indications where you have a moderate LV dysfunction, is a class 2A indication. For CRT indication, you take it as an alternative as well as complementary to CRT. There has been changeover from both arms. We have taken patients for CRT, finally ended up doing CRT, and the other way, CSP, and the other way also. In cost constant, CSP gives you CRT results with a dual chamber pacemaker with a lifetime warranty, and you can actually do dual chamber ICD can give you a result like a CRT if you're taking a DF1 device, you're putting one extra CSP lead. Obviously, lumenless is a longer safety data, but I think for easier learning curve and wide acceptance of stellate-driven lead, because most of, at least in this audience, we have non-EP doctors, so it will be much easier to adapt it. Thank you so much. I'll be happy to take any questions.
Great, Devbrata. As always, just two things. Are there devices with which you can do a bit-to-bit monitoring even with the lumenless leads?
So it hasn't come yet, but Medtronic is working on it, so that they are making a tool which will help you to connect it, and it will be soon available. Yeah.
So it's not practically
not yet practically available. I think it's available in US. It will come another 6-7 months. Yeah.
The second thing is, if you have a cardiac MR at hand, would that influence your choice of stellate-driven versus lumenless?
Can you repeat, sir?
If you have a cardiac MR report, the thickness of the septum, the fibrosis, whether there is a cheesy septum or not, would that influence your decision of choosing one over the other?
Okay, so no, to me, if the septum is scarred, the basal septum is scarred, the only patient where I will not do conduction system pacing is anterior LMI with septal scar. So it will be terribly, I have tried in couple of patients where I have consistently failed, and Shanmuga told if you can show that the lower septum is intact, maybe the basal septum is scarred, lower septum is intact, you can try a left posterior fascicular pacing, but still that is difficult. Yeah. So, but between the choice, I think both of them are same. It doesn't matter whether it is a 3 mm or 6 mm septum versus a 10 mm septum. It doesn't matter, because you need to drill till the end of the left ventricle subarachnoid. Please, Dr. Yadav.
Any late screw retraction, helix retraction in
long-term follow-up.
Yeah, stellate-driven.
So I would say among my 220 cases, 2 patients I have found on-table helix retraction, which led to left bundle loss. Fortunately, we don't have to repeat the procedure. We just opened the sutures and screwed it like usual screwing. We just take a chance, and both the cases it gave to left bundle capture. They are on my follow-up. They're still doing well with left bundle capture. On follow-up, I have not done any long-term screening of the helix, so I cannot answer that. Yes, there is around 12% patients.
We have a panel discussion on conduction system. We will address all these issues.
Thank you. Thank you.
So thank you, chairpersons, and we move on to the next session, and may invite Dr. Navanil Viswas, Dr. Aditya Verma, Dr. Saurabh Das, and Dr. Ramdhan to be there on chair. Can I have the slides, please? This is not my slides. Project, yeah. So, thank you so much for coming. I think it's wonderful to see everyone here. And we are diving into deep discussions into conduction system, and then it will be followed by leadless. So I will quickly go to the, specification of 3830 lead, what are the evidence. And there are a lot of concerns. There were some reports that these leads can fracture because it is deep inside the septum. There is a lot of movement there. And then what are the evidence with the lumenless lead from where we started the conduction system, and which can be better. We will have a panel discussion. We will be dissecting it deep. So 3830 is a wonderful lead, I tell you. We can do a left bundle branch area pacing. We can do a backman bundle area pacing. And it has got good evidence as well. This is a uniquely designed 4.1 French lead, which is bipolar. So the bipolar leads usually we see the thicker leads because of two conductors and there are insulators. But this is a bipolar lead where there is a small, two electrodes at the tip separated by insulation. And it is an active fixation lead with a helix which is, out every time. The length comes in 59 centimeter and 69 centimeter. The one which is available with us is 59 centimeter. These are steroid eluting, and this is the design. So this has a PTFE cable coating at the distal tip on the conductor or electrode, and then we have a silicon inner insulation which improves the crust resistance and decreases the creep. And the top layer is polyurethane, which is designed to reduce lead catheter friction, provides better lead pushability through catheter. So this lumenless coaxial design fits very well with 3830, the work which it does. And then these are the lumenless, the with lumen coaxial design and co-radial design which are available in normal leads. It has got a 1.8 millimeter helix which is extended, fixed extended helix, and 9 millimeter tip to ring spacing. So there is a distance of 9 millimeter and 1.8 inside, so you go 10 millimeter inside, and then you can also have an anodal capture. This is titanium nitrate coated on electrodes, and these are, it comes handy in reducing the polarization and also causing effective capture. So we have conclusive data at this moment as far as this lead is concerned. Lot of evidence with the meta-analysis concludes that LBB area pacing has better outcomes compared to RV pacing, which is well documented at this moment. And this is the first lead which is approved from FDA for his bundled pacing and LBB area pacing. And we also have this is approved for backman bundle area pacing where it is being used, but the BB area pacing is still not anywhere in guidelines. It's evolving science. We'll have a discussion on that also. So this fixed helix causes increased stability while we are implanting. So there's a lot of concern that when we stylus-driven lead which you use, you extend the helix, and then while going inside, the helix comes back. So my contention is, suppose we are going down and it is coming back. Once we have left it there is a cardiac motion. There is always, the tip will be under some pressure. And that could be the reason why you see late loss of capture getting more happening with this stylus-driven lead, not in lumenless lead. So this is one kind of benefit with lumenless. And this has got a unique isodiametric design. And the central cable minimizes the mechanical stress. It has got proven high implant success rate through many studies. And this is the bench test you can see here. And the conditions where there is acute stress, tip depth, bending, it has been evaluated in the bench test with fatigue testing, 10 years simulated mechanical testing with 400 million cycles of push and pull. Statistical modeling shows that it has a predicted 99.98% fracture-free rate over 10 years. So this is a pretty robust evidence with 3830. And we can also do atrial pacing, which I think in a while we'll be seeing and getting the presentation from Dr. Levantopoulos on Bachman bundle area pacing. These are some unique situations where 3830 was, handy in doing a successful procedure. This was a lady which I did, I think, 4 years back. I think in 2021, patient had a LBB, intermittent CHB, ejection fraction 45%. We had just started conduction system pacing. I thought it is the best patient with a LBB, a 45% EF. And she had when I took the patient, she had a very bad scoliosis of spine. And we could, with electrical markers, we had no clear-cut, fluoro markers, anatomical markers. With electrical markers, we could do this procedure. And the patient is now having a good ejection fraction. So even in disturbed anatomy, we can do with that. We published that. Another patient, you can see the dextroverted heart. The heart was on right side. There was a bad lung. The patient had a bad pulmonary tuberculosis in the childhood, and everything was so fibrosed, right? The heart was pushed to the right side, and we can see the venogram. This was the SVC is pulled towards right, and you need a system which is flexible, which you can take easily to a LBB area, anatomically and electrically, and with this some permutation combination, puncturing very medially on the left, we could reach there with this LBB, with this 3830, and this was the LVAT, and we could do the procedure. You can see the such a tremendously distorted anatomy of the heart in the right side of the dextroverted heart. We could do that, and this was we published in clinical case reports. So we have evidence of this lead coming from our lab. Again, we could do this LBB area pacing with 3830 in a hypertrophic cardiomyopathy. So there is always a concern. There is such a large, deep, hypertrophic septum around 21 millimeter, and then stylus driven you can't go in. This lumenless lead went there, and we also published that is very highly cited in an article. So with this 3830 we can achieve total physiological pacing, which is the way forward, and we have got enough evidence, practice endorsements by guidelines together on this 3830 lead. Thank you so much for the patient hearing. Yes. It's not true eluting. It's not.
So I have problem like late capture failure because of threshold rise, and particularly in dependent patient like complete heart block, where I have used left bundle pacing, but delayed development of complete capture failure has occurred. So this is the problem. This problem I don't know about the steroid because they are true steroid eluting leads.
It's not true. It's a dipped and then yeah.
Sir, any procedural differences between these two leads?
Any?
Procedural differences?
Yes, the procedural hindrance is, when I, ask Samshad, who is there, I think, he will find stylus driven very difficult to do. When I ask Deobrato, he will say, no, stylus driven is very good, 3830 is difficult to drill. Yes, 3830 is difficult to drill. But once you get in there, the capture is good, and the late, the capture loss is less, less common. So these are some advantages we'll discuss in our CSP panel discussion.
Sir, a very basic procedural problem. In a hypertrophied heart, say 1.5 or 1.4, which is a common occurrence, how many turns would you like to give the lead?
So conventionally it is shown, I think it is written that you have to take 10-15 turns, but have you seen Sharmuga doing the procedure, or maybe when we do the procedure, we just drill, we see fluoroscopically how much it is going in, and we feel that substantially it has gone in, the ring is also inside the septum, then we stop there, we look at the parameters. So it depends on how much the migration is happening, rather than the turn which we count. The counting, I think, even if it is 50 turn, it has not progressed, then it's a futile.
Basically, there is no upper limit for the number of turns.
No. And also in atrial Bachman area pacing, they say 4-5 turns. Nothing happens with 4-5 turns. You have to drill again 15, 16, 20 turns. You have to see fluoroscopically that has gone in, and then we can, measure it and come out. Yeah. So we can have a Dr. Levantopoulos lecture. Can you present audiovisual team, and then we will have panel discussion. Can you Zoom recorded presentation? Yeah.
So
You don't
the
have
topic
audio
today,
yet.
and thank you, Dr. Kumar, for the kind invitation to be invited. So the topic today, and thank you, Dr. Kumar, for the kind invitation to be invited in your conference, is about Bachman bundle pacing. It's something new, and it becomes, I have to admit, a little bit trendy. But let's see why is now we're all interested on Bachman bundle pacing. First of all, what is the Bachman bundle?
Sir, you need to make
The
it.
Bachman bundle is a structure of fibers that facilitates conduction from the right atrium to the left atrium. You can see here between the arrows. Let me go to the full presentation. You can see here between the arrows this strand of fibers that transmit the conduction from the right to the left atrium. The propagation is done through three different structures. Is one the Bachman bundle from the anterior part of the atria. There is another one through the CS that facilitates conduction from the posterior part of the atria. And there is another minor, let's say, conduction system between the posterior part of the SVC and the right superior pulmonary vein at the Waterstone's groove. So here you can see in other views how the Bachman bundle looks, and to the colleagues that are involved in electrophysiology, you may have encountered some problems to complete a line, an anterior line, because Bachman bundle is an epicardial structure, and when you ablate endocardially, sometimes the propagation is transmitted epicardially, so you have to give deep lesions in order to completely eliminate the Bachman bundle conduction. So sometimes it's difficult to complete an anterior line like this one here. Let's see if I will let this line here, because this is sometimes where the Bachman bundle makes our work difficult. Okay. Now, the Bachman bundle, it sits here. If you see the SVC and the left atrium, it is, of course, at the septal part of the SVC, quite posteriorly, I would say. Okay, so in this particular area here. And this is a landmark that we have to know when we do the implantation. First of all, why the Bachman bundle pacing is not something new. It was in the past. It was there was serious attempts and publications for the Bachman bundle, but the interest was faded out. I would like to say, but why it's beneficial for the patient? We know first of all that increased interarterial conduction time is associated with increased incidence of atrial fibrillation. How interarterial conduction time is defined? We know that the maximum normal duration of the P wave is about 120 milliseconds, and we have if the P wave becomes wider, and especially if it has this BFIT morphology in lead 2 in the inferior leads, not in lead V1, in lead 2, then we know that definitely there is an interarterial block. Here we have an interarterial block in this configuration here, and here we have a partial interarterial block, meaning that there is still conduction but with some sort of delay. But here we have complete interarterial block when we have this BFIT morphology. And what does it mean? It means that the propagation cannot be facilitated through the Bachman bundle, and the left atrium finally is propagated through the CS from low to high, and that's why we have this negative morphology. So the other conduction systems like the CS, I told you before, are recruited now to facilitate the conduction from the right to the left atrium. And we know that these groups that have this interarterial conduction time have more incidence of atrial fibrillation. Apart from that, we know that atrial dysynchrony that we can have when we have interarterial conduction time that is prolonged of course, can cause a diastolic heart failure. Let me explain to you this slide a little bit more. It's like the AV delay that we're trying to adjust when we do in CRT population when we do the AV adjustment. So in this space in here, because the interarterial conduction time is very much prolonged, you can see that the A is truncated. Okay, but when we perform pacing from CS at this example, not from Bachman, you can see that this is restored. And the A wave becomes wider and higher in amplitude. So this means that in patients that have interarterial block, they suffer also from diastolic heart failure, because in essence what happens is that the atrium is condemned to contract when the left ventricular contraction will start almost simultaneously. So the A wave will be very low in amplitude. And we know also that from a very recent publication from the book of Lustgarten that if we perform Bachman bundle pacing, the risk of atrial fibrillation is lower than the conventional right atrial pacing, and is also lower than the right atrial septal pacing. Now, let's see some things about Bachman, because the procedure itself, it's not anatomically guided solely. It's also EGM guided. What you have to look at when you go to this area I showed to you before at the junction of the SVC to the right atrium, you have to find this signal here. It is a fractionated signal, low in amplitude, the fractionation, and high in frequency. That is followed by a higher signal, which is a far field of the atrium. Also, you will see that you will get this far field V. This is because it's recorded by the aorta, because the Bachman is in close proximity to the aorta, and this is how you get this far field V signal, which in the beginning I couldn't understand where you get that from. So this is the landmark signal that you have to look at. When you look at this signal, then you have to screw the lead, and then you see immediately how the P wave becomes narrow, more narrow, and sometimes high in amplitude, but I think it's very, very evident here that it's narrow in amplitude. And as you can see here in this example, this is when we have non-selective Bachman bundle pacing, which we have a P wave duration of 79 from the onset of the stimulus, sorry. But when we have a selective Bachman bundle pacing, like here, that we have also this splitting, EGM splitting, and this isolectic, which doesn't exist here, we have a wider P wave, which we don't like this to happen. Although it's nice to have evidence of selective Bachman pacing, it's nice to have a shorter P wave that is, this is achieved by non-selective Bachman. So in this occasion, we don't have to look for selective, but it's nice to demonstrate this transition because we know that they're at the right spot. On the other hand, when we have some signals like this one, this is not the right spot. This is now, in this occasion, my catheter and my lead was placed more posteriorly, and if we go more posteriorly, we are close to the crista terminalis. So the P wave is still positive in the inferior leads, but is wider. It is 150 milliseconds. So we have not achieved atrial resynchronization in this patient because the signal we chose to screw our 3830 lead was not. It was not the right position. So by performing all these things, we can have total physiological pacing. I think the reason that now we have focused our interest on Bachmann bundle pacing is because we have the right tools to do that. We have the right tools because we have pre-shaped fixed sheaths to guide us to the SVC RA junction. And we have this lumenless lead that we perform also LBBP or his bundle pacing. With the same lead and by using a different sheath, which is shorter and with a different curve, a special sheath of Bachmann, we can perform at the same patient LBBP and Bachmann bundle pacing, and you can have some P waves which look like this, look like a pulmonary P wave when the patient has pulmonary hypertension. Now, it's not only to perform arterial synchronization. I think that in the future you will see that there's already some studies in the pipeline. I'm talking about the Elevate HFpEF study. So in the future you will see studies that coming about the accelerated arterial and ventricular pacing, individualized in an individualized form. Patients with HFpEF that have slow heart rate, the rationale is that if you pace them faster, then you can decrease things like PCVP and diastolic properties. And in this Elevate HFpEF study that is funded by Medtronic, you will see, and it's recruiting already patients in the United States, you will see that Bachmann bundle pacing is provisional in this patient. So it's better to use Bachmann bundle pacing and LBBP, total physiological pacing, because otherwise it wouldn't make sense to put a pacemaker and to cause the synchrony in patients that you want to increase their heart rate. The benefit that you would get from increased heart rate would be offset by the synchrony that you get from the paced wide QRS. There is also studies by your country, by India, about hypertrophic cardiomyopathy and Bachmann bundle pacing. And there was a randomized study that showed benefit by increased arterial pacing by Bachmann bundle pacing in patients with hypertrophic cardiomyopathy. And I'm very grateful to say that you collaborate with us in the study, the IBHRE BLAST, that is our study that will compare the IBHREs, the arterial high rate episodes, in patients that have conventional pacing versus LBBP versus both LBBP and Bachmann bundle pacing. We need many patients to be recruited, but I think we are in the right way, and the patients are recruited quite fast. And we want to compare what is going to be the incidence of IBHRE. The duration of IBHRE is more than 6 minutes and more than 24 hours. We have divided in these two groups. And we want also to see, apart from IBHRE, of course, how many patients we will develop clinical atrial fibrillation as well. So that was from my side, and sorry, apologies for the technical issues we had before, and also apologies that this presentation had to be recorded, and I would like to be live with you. Thank you very much.
Now we'll move on to the much awaited panel discussion on conduction system. So may I request, thanks chairpersons, may I request Dr. Devbrato Bera, Dr. Gopal Ghosh, Dr. Rana Rathore Rai, Dr. Poppy Bala, Dr. Arun Gopi, and Dr. Anupam and Dr. Saujatyo Chakravarti to please come on dais. Arun, you are there? Saujatyo? Anupam, please come. I will sit. Can we have one more chair, please? Take chair. হয়ে গেছে So I have 10 questions with me, and I will have the opinion from experts, what they feel, and it will clarify, many doubts in those who are starting the conduct system pacing. So maybe begin with Sojatyo, right from there. What are the markers of true engagement of conduction system? So just markers of engagement of a conduction, left bundle branch area pacing, markers.
Yes. So I think there are fluoroscopic markers and there are electrophysiological markers. The fluoroscopic, so the markers are, I think, like we identify where the His bundle is, and then we draw an imaginary line to the apex, and around 10 to 15 centimeters towards the apex is the ideal area for His bundle, for left bundle pacing. I think it's more like not a point, it's like a radius, it's like a circular area. And the more, if we go a little bit more inferiorly, we'll go more towards the posterior fascicular part. And if we are more on the line and we get good signals there, so that's the actual left bundle area, pacing area. And other than that, there are signals. So I think if we have EP, we can identify the left bundle activation potential, which is not always there, but it's one of the markers. We can use the unipolar pacing to see an R prime wave, which should be quite prominent. The left ventricular activation time is another practical thing that we can always measure using a 12V DCG system on the if we have it on the Cath lab. And
perfect. So
these are the electrophysiological.
Yeah. So we have a right bundle branch, pattern on ECG, QRS which is getting narrowed, left bundle pacing on, the sensing, and LVAT, which is less than 90 it indicator, less than 75, 80 it almost more or less confirm that you are in that area, bundle branch area. So now, Anupam, many times we do LVB area pacing, but we don't get a R or R prime. So is this a LVB area pacing? What is the situation in which there is a conduction system capture, but you don't get a true R or R prime?
Yes, sir. So there are situations, for example, whether it is a disease of the myocardium, or for example, when we do for a DCM, dilated cardiomyopathy, it may not be truly that the conduction system only is the problem. There may be intramyocardial conduction problems will also be there. So even if we do a perfect left bundle branch capture, still the conduction will be little delayed because of the intramyocardial conduction problems. So it may not show morphologically on the ECG, but still the capture will be there.
So Arun, can you elaborate on that? No RR prime. What about right bundle branch area pacing? RBB pacing rather, not LVB area pacing. So RBB pacing is a physiological pacing, do you feel?
See, basically, if you need to engage the conduct system and try to replicate what natural His-Purkinje system activation happens. And so, primarily what you're looking at whenever you're doing conduct system pacing is quicker activation, the shorter LV activation times, and transition phase. You need to have a transition from selective to non-selective as you go higher and lower output. And there should be, as you go, the activation times need to be short and constant as you go on, even on the higher outputs. Or you can actually have this decremental pacing being done and demonstrating again that you are in the conduct system. So there are different patterns of ensuring that you have conduct system capture. But what is very clear is if you have LV septal pacing, that is definitely inferior to conduct system capture. You need to have more, this is more true for if you're treating, you are trying to resynchronize and ensure that you're treating heart failure. But for conventional pacing in the presence of just like you are doing a pacing therapy for a person who has some amount of LV dysfunction and you are doing just an RB pacing, then LV septal pacing versus left bundle branch area pacing does not make a major difference. But for resynchronization, better to have a pure left bundle branch area capture.
Yeah. So we were yesterday doing a lot CRT. So there was a good transition, good R and R prime, but the LVAT was 15, something like that, and patient had an anterior MI, scarred myocardium. And there was a latency. When there was a stimulus, there was a latency, and then the V5, V6, the QRS was forming, and the LVAT was quite high. And we were sure that we can't reduce it further because there is a scarring and there is a QR pattern in the ECG to begin with, and ejection fraction was around 25%. We put the third lead. So this is vice versa, it's okay. If you get sometimes you get a conduction system, left bundle capture, still you can have a high LVAT. But in these cases, you have to get a good transition and a good RS-RS pattern.
Yeah, so again, it all depends upon where in the conduction system you have the disease.
Yeah.
You have a proximal disease and you're pacing exact distal to the site of disease, and the distal to the site of pacing is all healthy, you're going to have a quick activation.
Absolutely.
Time. You have a distal disease, you have distal scar, you have distal functional blocks, you will still have activation time larger. There you need to have one more lead in the LV epicardium and then narrow it. Unless you have your LV activation time narrowed down and better resynchronized, you are not going to have a better response.
Absolutely. So our CS lead brought down the QRS from 167 to 118 in that case, and we were very happy. So Rana, what is your preferred way of doing a conduction system? 3830 or Abbott's stylus driven or other stylus driven?
I think for beginners and for I think 383 definitely is I think better. But if you have done enough cases, then I don't think it matters that whether you was doing 38320 or Abbott lead. But I think definitely for beginners, what I used to do, I was more comfortable with 3830.
Yeah. So now let me little clarify LV septal pacing versus LV area pacing. Devrito can do the justice. Many times we capture the LV septal in subendocardium, that side, but still you don't get a marker for true left bundle capture. It's a lefty, just subendocardium we are capturing. So LV septal pacing versus LV area pacing. What are the markers? And are you happy with LV septal capture or not?
So there are two aspects of this same question. I'll try to answer as a non-EP cardiologist. First of all, the primary target or mandatory criteria for successful left bundle area pacing is to show some kind of a right bundle delay, at least some notch at the end of the QRS, and if is a proper notch RS R dash, that is a reasonably sure shot sign that you are reaching left bundle area. Now, whether it is a left bundle capture or not, there is a non-mandatory criteria, but you actually need to fill up one of the 4 or 5. What are those? First of all, showing left bundle potential on that lead, which is difficult even for EP. So I am assuming that left bundle potential is very difficult to see. What are practically available? Practically available is called left ventricular activation time. That is from the pacing spike to the peak of V5, V6. Why suddenly V5, V6? Because they are lateral lead. What we are trying to measure from your pacing spike, how quickly your electrical activation goes to the lateral left ventricle. So now if this value, although there is no sudden abrupt cutoff, but the value, if it is less than 80 to 90 millisecond, you are reasonably sure that you are reaching left bundle area, obviously along with a R prime or a RS R prime. Now this value is LVAT, what we call. If in addition to this is another criteria called V6, V1 interpeak interval. This is also very practically measurable. What does it mean? That means you are reaching the V5, V6 which is left ventricular lead very quickly, whereas on the V1 is a surrogate of a right ventricular lead, so you are reaching it very late. So if the V6 to V1 interval is more than 43 milliseconds, which is very good. If it is 50 milliseconds, 60 milliseconds is great. If it is between 33 to 43 milliseconds, you are not sure whether it is a left ventricular septal pacing or a true left bundle area pacing. If it is less than 33 milliseconds, it generally tells you that although you have a right bundle delay or RS R dash, it is most likely left ventricular septal pacing. Now coming to the second question. Second question is, are they differ clinically? So there are papers, there has been literatures on this. So I'll just quote one of the very landmark paper. It is a randomized trial between in all centers of Mayo in US, where they have categorized them, where one group, both groups have R prime, that means right bundle delay, one group have a shorter LVAT, which is less than 80-85 milliseconds, whereas the other group has more than 90 milliseconds of LVAT. Categorize them left ventricular septal pacing. Remember, both the groups, all of them were done for DCM, LBBB, cardiomyopathy, not for pacing indication, for resynchronization indication, and all they were categorized into left ventricular septal pacing versus left bundle area pacing proper. Interestingly, both the groups did similarly well. There was some tendency that this left bundle area, proper left bundle area pacing was slightly better, but the p-value was not significant. So the message I want to say, if you have a proper RS-R prime, you don't even need to measure LVAT, you don't even need to measure V6, V1 interpeak interval. Obviously, if you can show they are corroborative, it is good. One thing I will try to emphasize, on a decremental output, let's say you are coming down from a high output to gradually low output. If you can show any change in pacing morphology, then you are very sure that you are at least capturing some of the fascicles. At a higher output, you will get more myocardial capture, less fascicular capture. At a lower output, you get more fascicular capture, more myocardial. So I will be more depending on LVAT, obviously, V6, V1 interpeak interval, and output dependent change in QRS complex.
Great. So if you have a RS-R dash, and R in, it will. That's what we are talking. That's what we are talking.
Correct.
That's what
Correct. So that's why the other criteria come in. Yeah.
But even then, if you see if your LVAT is more than 90 millisecond, you are still getting RS-R dash or good R wave in V1. Then you measure V1, V6. You also see left bundle potential because many times there is a disease down, distally, you still get a left bundle potential, but still you are getting LVAT is higher. So these are situations which are there. That's why it is called LBB area pacing, not a left bundle fascicular pacing or a left bundle trunk pacing, or LV septal pacing comes under LBB area pacing. So it is not an outlier, and the results are almost similar. So so Gopal, what is your concern about late rise in threshold which we discussed and injury of coronary vessel structures? So do you feel that because of these reasons the low profile leads or thinner leads could be better, or do you feel that these are things to be concerned about, or it's okay, there are not much of reports, one or two anecdotal reports are there, you should not be bothered about that?
No, I have I have used the lumenless lead more. I have few experience with the steelhead driven leads, but concern regarding coronary perforation or is going very close to the left coronary sinus or not, then it is very less. Probably never happen, and even the literature also showing is very less. And micro dislodgement can happen, as many of our presenter also told that micro dislodgement can happen, but even with that also, even with modification like Dr. Devabroto told that later also we can screw the leads and we can improve the outcome also. So with that, some changes in the position of the lead, we can improve our outcome and see better.
So now, final question, then we will have a discussion on left bundle potential. Dr. Poppy, what do you feel Bachman bundle area pacing will come into the future, or can you tell us which are the candidates where we should try using this?
So, what we learned about the last session, sir, because most of the pacing actually shifted from the conventional pacing from that to the CSP pacing. That means conduction system pacing. So more and more conduction system for the Bachman is going to be the future.
Okay. You are convinced?
Yes, sir.
So, but if there is a notching in P wave, the patient has 6 sinus syndrome, you'd be going for that, isn't it?
Patient who has the intermittent atrial fibrillation, who doesn't have the large right atrium and also has a tendency to paroxysmal atrial fibrillation, they are the candidates for the Bachman. 6 sinus proximal atrial fibrillation, And when you see, ECG, P is more than 140 millisecond, there's a notching, lead 3, especially there is a kind of, So these are the patients where we look for. And my last question goes to everyone. So anyone can volunteer. Left bundle potential, how many cases you get?
what are the types of left ventricular potential you get. So, all those who are looking for left ventricular potential aggressively, and what are the varieties of left ventricular potential they see, and how many percentage of cases you are getting.
So I'll just again simplify for even non-EPs that even if you don't have a EP system, or if you have a EP system, you can get a potential which is sharp and it is not attached to the electrogram you see on the tip of your lead, either on the EP system or on the programmer you are working on. If it is attached to the electrogram, it is generally not considered to be a separate left bundle potential. At least 15-20 milliseconds gap should be there. In my practice, I have found it less than 10% of the patients. But if you look at only patients who have a non-LBBB or non-complete heart block, finding left bundle potential will be around 50%. But unfortunately, we keep ending up doing CSP in LBBB, CHBs. So obviously the chances are getting is less. Another reason why we get less is because of mostly current of injury. If you just stay there on the same spot for 10 minutes, 15 minutes, you might be able to see a left bundle potential followed by a gap, followed by the ventricular electrogram on the tip of the lead.
Arun, Anupam, so anyone can give further comments.
One more thing, they've said the right thing. Okay, if you are mapping for it, you will get it. But majority of patients where you're doing in patients who have pre-existing LBBB, where you already have a disease bundle branch, the best way to pick up the left bundle branch potential is to do a pacing from the TPA lead. You have a TPA lead, and once you pace the TPA lead, you will get a retrograde left bundle potential. And it's always about like how you find the his potential. It's going to be a sharp potential with a small isoelectric line, which may usually be about 20-25 milliseconds prior to the potential. There will be an isoelectric line from the local electrogram that ensures that it's a left bundle potential. It depends upon how finely you map it. Most of the time it is there. You keep looking for it, you will find it.
Yeah, so from Chinese studies, they have classified this LV potential into, 3 types. One is manifest, which we see in 40-60% of cases, that sharp potential which you are describing. And once you go deeper, we get a negative signals, and then the potentials are buried in that. And they say that if you get this kind of LV potential in the downstroke, then these gives you more confirmation that you are hitting a right area, and the future prospect is even better. So these are 2 types of left bundle potentials which are described by Chinese.
If you're at exactly the site, it will be almost like a QS kind of.
Yeah.
So but the high frequency potentials, to get that sharp negative deflection to begin with, it's again a lot of.
If you are just going subendocardial left side, then reaching there.
I think before going into those kind of finer details, those who are planning to start their program, it has to be like, a very easy procedure without EP. So my few tips of doing CSP over more than 300 cases, they will start with RV angiogram. That is a must from my side. We started doing without RV angiogram. That makes a huge difference. And you have to see the septum like a straight line. If you do not see the septum like a straight line, you can struggle for 1 hour, 2 hours, 3 hours. You cannot never reach there. The lead can go this way, that way, and never. Especially if you have a lead, pre-existing lead, a very dilated ventricle. Second, if you are not able to see the septum like a straight line, remove the sheath again, go back again. Perhaps the next time or third time, you can see the septum. Second point, once you are able to fix the lead and seeing the parameters, please try to inject through the sheath, coming little away from the septum so that you do not produce the vascular complications or hematoma. And third, whether your lead is anchored or not, the Sunip is little hesitant of doing because he is not sure whether the lead will anchor or not the very first. So draw the sheath, draw the lead, and the sheath will go forward like a micra or AVR. If it is not moving, you are not sure whether it is really anchored. The last point, you should push the sheath and you should make it like an Achilles, like L separate shape. So these can be done, and I know Dilip doesn't believe in RV angiogram, but take it from me. If you start doing on RV angiogram, anybody sitting here can do CSP.
This comes from a person who has done maximum number of leadless pacemakers in India, so we can accept this. So there are a lot of angiograms we do. Any other questions, doubts?
One question from the panel.
isoelectric line that's confirmed that you are pacing the conduction system, even if you don't see the left bundle potential. So if there is a say 20 millisecond delay between the spike
Yeah, isoelectric
to the
line, yeah,
reticular
definitely.
depolarization, isoelectric line, that means
it indicates a
unipolar.
selective capture.
If
Yeah.
unipolar.
What the
Indicates a
concepts
selective
are saying
capture.
is, once you have
Unipolar
captured the
testing.
conduct system, you should get through the RV apex to come out of the insulated fiber. So that isoelectric line between the pacing stem, which is on
At
the
least 20 millisecond, 15,
Yeah,
20
20.
it will
milliseconds.
depend upon how high in the conduct system you are.
Yeah.
If you are more and more proximal, like a his,
For his,
you have
40
30
milliseconds and
35
downstairs
40.
20 milliseconds.
You go lower
So
down.
some delay
Isoelectric
proves
line,
that you are capturing the conduction system.
This happens when you're selectively capturing, but
Yes.
majority of times you're non-selective
Yeah, but
capturing where you
that's
see
why
the
you have to
transition.
test
point.
in unipolar,
So-
not in bipolar.
Any other comments, and otherwise we conclude? Samshad, yeah.
Actually, all of us in the panel are doing left bundle pacing. So, in what percentage of your cases you get M beat? Because M beat, at times, it is a almost confirmatory.
Template beat is what is saying.
Templates, okay, template, but yeah,
potential.
yeah, yeah.
Because it is almost a confirmatory that we have reached over there.
Yeah, so it's again, as you say, it depends upon many things, how fast you're screwing in and how much you're looking
And
for
where
it.
you're
If
concentrating
you're
or
going
not.
slow, see, it is like you are trying to hunt actually, the electrical system. You are going in, you are going slow, you might not even get actually, because some people go slow, check every time and then go penetrate, see impedance. But if you're going Shanmuga's way, one fast way, you will always get template beats because that will be your short side to stop screwing. The moment you see left side, you hit the tissue, like it's like putting a catheter into the LV. You are going to get ectopic. Similarly, when you're going to near the conduct system, you will get the typical QR pattern PVCs, which is indicating that you are near the conduct system. You can stop there and then check the electrical parameters for it.
Absolutely.
So in
it's
other
very
words, if
difficult
you are-
sometimes to stop there only.
Even
Yeah.
LV septal capture, even
Sudhir, yeah,
without
you have a
septal
question.
capture, no, even ectopics can come from the endocardial septum of the LV.
add
So
one
that's
comment.
not correct that it is
Most
capturing
of the
your
time.
conduction system.
If you are doing
Conduction
lumenless
system
lead,
capture all the
most of
criteria
the time
which
you will
you
get
have
it. Okay, because that is the end point. If you are doing slit-driven lead, most of the time you will not get it. Around 20% of the time you will get it. Because
One
you
more
are going
question.
slowly.
One more
Dr.
question.
Gopi
Final,
has said
yeah.
that speed is the thing, because in our practice, because we are still to reach that speed. So we hardly get in 5 to 7% of cases that M beat.
No, but
It's so practically it is not, no one looks at that.
Always
There is
pacing
a,
and going.
yeah.
If you're doing stylet driven, you are connecting your to the stylet and you're pacing and going, you're pace mapping and going. So even before template beat,
Yeah.
you will not get template beat, rather because you're continuously pacing. In a lumenless, you are just blindly drilling. Then you look for this. Again, it's to just say that you stop there, check electrical parameters.
So, Sudipto, then
I
we
have one
okay, sir.
point that in conduction system, look for current of injury, whether
That's
you have
that's
perforated or
important.
not.
That's important. Yeah.
Yeah, because if you have perforated and look for the impedance.
What's the lowest current of injury when we stop, sir? What is the lowest current of injury?
Rather,
8, 10,
at
11?
least 25.
No, sir,
25
20
means you are in the
mid.
muscle.
In the
If
muscle,
you have
yeah.
lost the injury, there is, you see, you have to see the current of injury in the proximal,
How
that is
low,
the anode and the cathode.
How low you go till you stop? Sometimes you don't have a, you want that a little more R prime should be
you
there.
can
You are going
compare.
in, going, current of injury coming down 10,
You can
11.
You can compare from the proximal, that is the anode, from the cathode.
No, sir, actually, as you're going in, your injury will go up. The only thing that you're looking is the morphology. The moment you see a Q, the initial deflection Q, you stop. You have gone the other side. Impedance will drop. Then your
Already
hip is
Shanmuga has
out, then
shown
you
that.
cannot go.
It will be maximum in the mid septum, then it starts coming down.
Yeah,
And
in
once
mid-
come to 8, 10, you absolutely should be trying to stop, or maybe 8 is the final, I think, number where you should not be going beyond that. Yeah.
RS pattern will come when you are, some part is in, some part is out. If US pattern comes, means you are inside the LV, and most important is the current of injury. You will not get the current of injury. You will get in the anode current of injury, but not in the distal cathode. So that means it has perforated, and then you pull the back and then recheck.
When you are about 8 and below, you are almost there. So I think we had a wonderful panel discussion, and thank everyone.
One more question. Is there time for that, sir?
Yeah.
Among the three criteria that we mentioned, which one should we most depend upon before drilling? That is the notch, W-shaped notch, the discordance between lead 2, 3 and AVR-APL. Do we find all three? Do we try
Just
all
answer it in 30 seconds. Let's say 3 criteria: 2, 3 discordance, AVR and AVL discordance and V1 notch. I will bank on AVR AVL discordance. On my personal experience, I will tell you, explain why. Because there will be places you are on the main left bundle, 2, 3 AVF, all will be positive. But most of the time, AVR will be negative, AVL will be positive.
If you are
That's why between these two, they are very similar criteria.
I think
2, 3 discordance and AVR AVL, they are very similar.
The session. I think someone will take LUT 2, 3 for me, LUT 2, 3 discordance for me.
Notch may not be there every time.
Notching
if you
is
are
the
capturing
second one.
the posterior fascicle, then 2, 3 AVF will be negative.
Yes.
So there will not be discordance. That doesn't mean you have not captured the conduction system. So if you have, say, fibrosis in the upper septum, you go down and capture the posterior fascicle and you can have 2, 3 AVF negative. So don't go directly on that criteria. Take the other criteria.
That's why I told that AVR AVL is more reliable than that.
I think we should conclude here. Thank you so much, and it was a wonderful discussion on conduction system pacing. Before we break for lunch, we will have this presentation from Arun. He has to catch flight. He has to leave at 2:30. It is 2:15. Let's hear from him about the leadless pacemakers. And we invite on stage Dr. A.S. Trivedi. Dr. A.S. Trivedi. Dr. B.P. Pandey, sir. Amit, please come on desk.
So let's hear from Dr. Gopi.
Down করে দিচ্ছি এটা ওকে need to just connect এটাকে সরিয়ে দে
Good afternoon once again. So, sorry to hold you on from your lunch. The next is actually moving on from CSP, another really breakthrough therapy which has actually made a paradigm shift in the way we manage bradyarrhythmia. So, this is a picture which I carry forth in most of my talks. This is the story how treatment of bradyarrhythmia has evolved. From the life of the first person who got a pacemaker, this is his cumbersome lifestyle. He carries along this cumbersome device with a nursing staff along with him wherever he goes. First person who got a pacemaker in 1958, this is how his life was. He went on to get 26 replacements and lived till 2001 from 1958, but his life was really cumbersome. From there on, we moved on to this dual chamber system. You can see that is conventionally being discussed, and that's the commonest thing that we deploy. And the newer paradigm shift has been the leadless pacemaker, which is almost the size of vitamin capsule. And why this development has happened is because of threefold things. Whenever you do conventional transvenous pacemaker, the Achilles heel happens at 3 points. One is pocket-related issues. It could be a pocket infection, hematoma, erosion, which happens in about 4% of patients. It could be a lead-related issue. That is the Achilles heel of pacing therapy currently, because leads can fracture, they can have insulation breaches, leads can cause venous thrombosis, it can cause tricuspid valve issues, and it's not uncommon because 1 out of 8 patients with traditional pacing systems have this kind of issues. And this era of cosmetology, no patient wants a visible chest wall scar or visible bump on the anterior chest wall. People want simpler procedures with no physical or visible reminders on the anterior chest wall, and that's what everybody wants. So cosmetically very appealing. I'll start off with a scenario which brought us this therapy to our place. 72-year-old diabetic hypertensive CKD has an STEMI, gets a left main stent and a distal LCX stent for the non-ST elevation MA for his left main triple vessel disease. 2 weeks later comes back with malignant syncope, 2 episodes of unprovoked syncope, EC showing complete heart block, no escape rhythm. Check CAG shows patent stents, no reversible factors. So he needs a pacing in a background of a recent LMCA stent, diabetic CKD patient, and these kind of patients are high risk of pocket hematomas. And these are not scenarios which are uncommon. We see in these scenarios in day in and day out. At one point of time when we had no other options, we would put a conventional pacing lead, get into issues into that because of infection, hematoma, erosion, and then put a leadless system. Later on, now preemptively, we know that these kind of patients are predisposed for conventional issues with conventional pacing. Now, these kind of patients, patients with renal disease, patients with tricuspid valve disease, patients who are immunocompromised, patients who have previous indwelling catheters, hemodialysis patients, patients who already have issues with pre-existing, patients who have already issues with the tricuspid valve, these kind of patients now we consider for leadless therapy upfront. Earlier, it was reserved for elderly patients because you want to have a minimal procedure. Now, even younger patients, there is a school of thought for leadless pacing because you want to preserve the tricuspid valve, you want to preserve the central vasculature for these patients. You don't want to put a permanently indwelling lead in them. You want to have a leadless solution for them. And cosmetically, this is the most satisfying thing for the patient. And in those patients who would require an infrequent pacing, why give a lead? Why give a pulse generator on the anterior chest wall? So there are more and more thoughts on the indication for leadless. There is dilution of indications, and this is how the therapy has been evolving. And rightly so, if you look at the real world scenario, there's a 56% reduction of complications with leadless system. Earlier, the system that came in was only single chamber, and that's why it was only indicated for those patients who had permanent AFib and high-grade AV block, or the VDD pacing could be given for those patients who have good sinus rates and needed AV synchrony. But this is a very few subset of patients who would require, who would satisfy this criteria, and that's why it has evolved. In 2022 April, Abbott brought in AVIR VR, and in June 2023, they launched in the dual chamber leadless pacing, the true dual chamber leadless pacing capability, and that got FDA approval in June 2023. So what is this new system? It has a capability of pacing and sensing the atria. It has a capability of pacing and sensing the ventricle. So if you have micro AV, it only senses the atrium. Here it can pace the atrium as well. It has extended longevity. That's AVEIR, that is what it stands for. Here is extended longevity, longevities which you have never heard of, almost 17 to 25 years of longevity for a device. It has eye-to-eye and eye-to implant communication and implant to programmer communication, and it can be retrieved. You can put in, take it out. That is very novel for a device which is still not applicable for all the transvenous systems that we have. So dual chamber leadless pacing is all about three major concepts: beat to beat synchrony, almost 98 to 100% AV synchrony, upgradable system, that means you pace, put a therapy which is needed for the patient at that point of time. Later on, you can always upgrade, and retrievability. That's a key thing. You can put in, take it out, and leave nothing behind. So this is the three major components: the leadless pacemaker, the delivery and retrieval catheters, and the link module with the programmer that is required for this therapy to be delivered. This is the VR system. It's just almost 38 mm in length, much lesser than size of a AAA battery. You have dedicated delivery and retrieval catheters, and you need a link module to connect it with the Merlin 3650 PCS programmer. This is the screwing-based leadless system, which has an active fixation helix. It has a retrieval mechanism or a docking cap, which allows you capability of retrieval later, and it has this X-ray code which keeps you capability of telling you how much you have screwed in, and it has some nose cone sutures you can see on the left hand side, which tells you whether it will prevent anti-rotation and prevent the unscrewing of the device. And this also has the first atrial based leadless system, which is again a dual helix system. You can see there's one more helix inside. It's 32 mm. It's placed on the base of RA appendage. That's where we place it in. The delivery system is just like Micro. It's 25 French delivery system, 50 centimeters in length. Use the standard protocols for getting it in. And this is the delivery system. The highlight is it has a protective sleeve, which is just a nitinol sleeve, which is always ahead of the screw, ensures extreme safety that you're not poking the myocardium, and gives you a capability of preventing the screw from catching any of the tissues. You have a dedicated retrieval catheter which has a snare at its tip, which gives you the capability of retrieving this any point of time in future. The biggest change is you can have upgradability. So that is the highlight, that you have a leadless system which caters to the patient's need. It is 3 Tesla MRI compatible, and when we say upgradability, we are more and more doing single chamber pacing for sick sinus syndrome. So suppose a person comes to you with sinus nodal disease alone, good AV nodal conduction, you would put only an atrial based leadless system, and then in future, there's only 1.6% of these patients who would develop an AV block in future. You can always put a second device in the ventricle in future, and then just do a software programming and activate it or upgrade it. Suppose a person has intermittent AV block, you put just a ventricular device at this point of time, and if he has a pacemaker syndrome in future, you can always put an atrial device in future, and just by doing a software programming, you can upgrade it. So you have a leadless system which caters to the patient's pacing need. You again see the resurgence of AI pacing for sinus nodal disease, which had almost dying out when the transvenous system was there. And the next is, as I said, retrievability. You have a dedicated retrieval catheter. You're not using homemade tools, you're using a dedicated retrieval catheter to get this thing out. And the retrieval success rate is phenomenal, 80% success rate. And this is all retrieved, even 9-year-old devices. So this is a 9-year-old earlier generation device which was retrieved. So it is feasible and it's very safely done. The other highlight is, compared to the Micra system, you are able to map. So it's exactly emulating what you do in a transvenous lead. You will map the site, find that the site is electrically good, and then screw in. So your chance of repositioning is very less, 83%. First attempt you are in the site. Only very few percentage of times you will require a repositioning. And it's all electrogram based. It's not blindly fixing the lead anywhere and then checking for it. You're looking at something called the electrogram. It's purely an EP concept. So you look at the ST elevation which was being discussed. This is the ST elevation you're looking at, and only once you get the ST elevation, you ensure that you're going to screw in there further. And that screwing is again monitored by the amount of ST elevation that happens and the impedance parameters. It's no longer threshold, it's no longer sensing parameters. It is only two parameters. One is the current of injury and the impedance. And the biggest highlight for us is the longevity. You see the longevity of these devices. Average is 17 years for the ventricular device. It can go up to 30 years. So 17 to 25 years, the average longevity, and that's phenomenal. So for an elderly person, you put it, it's a one device for the lifetime for this person, and that's phenomenal. And this has been for the single chamber devices. The longevity for the atrial device is 10 to 18 years. For the ventricular device is 18 to 27 years. And once you go dual chamber capability, atrial device is 6 to 9 years. Ventricular device is again 11 to 15 years. And why it has higher longevity is because of the conductive communication that it uses. No longer Bluetooth, no longer RF, it's all conductive communication. And it also is rate responsive. It gives a temperature based sensor, and it allows you a good rate modulation for a person who is physically active. So this has been tested. It's all not scientific jargon. It's well tested in studies. The leadless phase 2 study, you see the results, 98% implant success rate, extremely stable thresholds and sensing capabilities. The duration of implant is just 40 minutes. 83% got it in the first attempt. 68% implanted in the apical septum. And the thresholds, absolutely straight line. No rise in thresholds on long term, extremely stable thresholds on long term. Complications, almost just 1.5% risk of pericardial effusion. Overall put together, just less than 4%. So this patient, which I told to alluded to, we took him to the lab. We need to ensure the lab doesn't have noise because it matters on conductive communication. We have these electrodes placed in a particular pattern, which ensures the device is in between the site where you want to place it. We do an RV angiogram, as Dr. Hasra was discussing, to exactly map the site which you want to place. An RV angiogram, RO and LO30, you avoid the anterior groove, avoid the inferior groove, avoid the free wall, avoid the apex. And when you place this RO angiogram, 2 and 5 is the typical position you want. On the LAO view, the green area, that is the area you want. This red area, which is the 1 centimeter perimeter on the RO view, you want to avoid, because that's the area where the groove is. So what it just requires is one venous puncture. You take one venous puncture, you take your standard protocols of putting in larger sheets. So you would actually have a single venous access, do an RV angiogram, and this is the... I thought this talk was 20 minutes. I'll just, so yeah. So this is the 25 French 50 centimeter introducer sheet. This is the delivery system. Compared to Micra, this doesn't come preloaded. You need to load it. So there is a dedicated delivery. There's a dedicated loading tool for it. So this device, you load it from the loading tool, and then you can see that the device is attached to two threaders. And we dock the device, and this is the protective sleeve I was telling you. This is the protective sleeve is always ahead of the screw. It ensures extreme safety that the screw doesn't catch anything, and it's the protective sleeve which gets in touch with the RV myocardium. Chance of perforation and pericardial effusion are very minimal. So this is the device, and this is the valve bypass tool which takes the device into the 25 front sheath. And once you have this loading tool, you take it to the introducer sheath, and then you take the delivery system into the right atrium. As with Micra, you take it to the right atrium. You would actually unsheath the device, and this is the protective sleeve always ahead. You would actually pull back the protective sleeve. So there is an unlocking mechanism to pull back the protective sleeve. You expose the device. So here you expose the device. This is the first time the device is exposed. You would get the baseline blood pool impedance, and you would activate the device so that the moment the device gets in contact with the myocardium, it can actually start pacing. So here you have a deflection button, the blue button, and there is a deflection lock. So the deflection takes it from the right atrium to right ventricle. You give a puff of contrast to see where you are. Your typical target is always the 2-5 position, that is the apical septal position. Check on LAO that you are very well aborted to the septum. That's a time when you start exposing the device. You take the screw to the RV myocardium, get it in touch with the RV myocardium, And once you get in touch with the RV myocardium, you look at the electrogram. So you are looking at ST elevation. So this is the ST elevation that you're looking at. You also look for a rise in impedance as you get in touch with the myocardium. So you check for the pacing parameters also here. Once electrically you are fine, you start screwing. You see the chevron marker. As you start rotating, so you hold this blue knob and you start rotating. And you can see you need to have 1.5 rotations. And as you're rotating, you look for rise in ST elevation on the current of injury and rise in impedance. So everything should go hand in hand. As you start screwing in, the ST elevation should go up and the impedance should go up. And once you check the electrical parameters, you do a deflection test to look for stability and then release it. It's just a 20-minute procedure, and that's how the device stays in. It's always not essential to do the femoral approach. One case, this is the first case of jugular AVIR implant, which we had to do because there was a difficulty in getting from RA to RV. And second case scenario, I'll tell you, this is story of a 73-year-old, recurrent syncope, binodal disease, sinus nodal disease and AV nodal disease, intermittent AV block, recurrent syncope, tachybrady syndrome from sinus nodal disease on NOACs because of paroxysmal AF. Patient wanted a leadless system. He's 73-year-old, he wanted a leadless system. So again, this patient, we do RV angiograms, again to mark the site of right ventricle where you want to be. He wanted a dual chamber leadless system. So we do the RA appendogram. So this is the RA appendogram. So here on the RAO, if your pigtail is in at 12 o'clock position, on your RAO view, your RA appendage would be between 1 o'clock and 2 o'clock. On your LAO 30 view, it will be about 11 o'clock position. So you go on RAO and LAO 30, these are the working views. You do angiograms to decide where your RA appendage is. And your typical target is base of appendage. Never deep in the appendage, it's always the base of appendage. The green area is your target site. Why you choose this side? Because the moment you go deeper in, you can see this is the illuminated part of the right atrium. Deeper in, it's actually quite thinner tissue. The base is where you have dense pectinate muscle. The second most best position is always posterolateral part of RA. Deep inside, your chance of perforation is higher. Your chance of having a stable lead area for communication between devices is less. Septum you always need to avoid because it's softer. Posterior again has widely spaced pectinate muscle. You tend to avoid that area. And once you have these areas, subsequent procedure is just the same. You take in this 25 front sheet to the right atrium. You have the device coming in the right atrium. Typically you would expose the device, have it programmed, get to the right ventricle. Right ventricular system is just the same. So we take it to the site apical septum, angiographically see that you are in a good site, expose the device, look for the current of injury. You can see the ST elevation. You check whether it is spacing that site and there's a good R wave, and then you start screwing in. So what you do is you take a cine image of this. You have this V marker, that's a chevron marker. You keep a roadmap of it, and then you start screwing. You can see that chevron starts rotating. What you typically want is 1.5 rotations of the chevron. And during the rotation, the LCS would constantly be looking at the amount of ST elevation going up, the impedance going up. And once these parameters are fine, you would actually go on the tether mode. This is the tether mode. And once in the tether mode, you look for the anatomical stability. You would deflect the device. You can see that I'm deflecting the proximal part of the device. The tip is stable, the chevron is stable. This is a test of anatomical stability. And once that is done, you look for electrical parameters. If the electrical parameters are fine, you typically release the device. So this is how the ventricular device is done. Now, with the same introducer sheet, with a different delivery system, you take in this device to the right atrial appendage. So here, as I said, you go in between the 1 o'clock to 2 o'clock position RAO. And in LAO view is the main working view. LAO 30, you go around the 11 o'clock position. This is the 11 o'clock position on the LAO view. And as I said, this is the green area. The base of appendage is where you want. You would have some shoots of angiogram to see which is the anatomical site. So this is the electrogram. So you can see this is a sharp electrogram with an S wave. This S wave, as you start pitching in, you can see a current of injury. So this later part, what you see is the current of injury. That's what you're typically looking at atrium. You find smaller injuries there, smaller impedance trends there, but this is the electrogram you're looking at. Once you find a good position, you can see we actually start screwing in. We make a chevron marker here, and as you start screwing in, you can see the ST elevation going up. This is how it starts screwing into the base of RA appendage. So as you start screwing in, you see the ST elevation going up, and then you go on a tether mode. So here you can see the tether is almost 33 mm, long tether mode, and here is the ST elevation at the end of screwing. For the anatomical stability, you do what is called the tug test. You will pull the tethers, see whether the device is holding on once the proximal part of the device is static. With the pull, the device is not coming out, then it is very stable. and then you check for the electrical parameters. If the electrical parameters are good, you just have to release the device. So here you are doing the tuck test in the RAO view, and RAO view, the tuck test shows that it's a stable device, you would release the device. So this is how a dual chamber leadless system would good, and then this was the first dual chamber leadless implant in the whole of the country. You can see the longevity of the devices. 12 years for the atrial device, 19 years for the ventricular device, and the AV synchrony, that is the RA to RV communication is almost 100%. So, and the thresholds are all phenomenal, like 0.5 thresholds. And this, how those devices communicate is phenomenal. What it does is you have two devices, one in the atrium and one in the ventricle. What it does is, it's like a Morse code. It sends signals, subthreshold pulses through the blood pool. It sends some impulses through the blood pool. So the moment the atrial device senses or paces, it sends some impulse to the ventricular device. And the ventricular device, the moment it paces or senses, it sends some pulses to the RA device. So beat to beat, every beat, it's actually communicating. This is called eye-to-eye communication. And this ensures that there is AV synchrony, almost 99% is the communication success rate, and AV synchrony is more than 95%. So that's the beauty of this implant-to-implant communication. And with this, you can see DDDR pacing both the chambers with a leadless system, which is first time once the DR system was launched. And you can also have different pacing modalities like AA, VVI pacing for patients who have pure sinus nodal disease, which will conserve the battery. Just finally, I will put one more case. This is a case where this patient had diabetic kidney disease, non-healing wound on the right leg, typically quite sick patient where we couldn't use any much of contrast. What we do is we do it totally intracardiac echo guided. So we have this intracardiac echo, which is actually our third eye. I would just go through the faster part. So we have one more single venous puncture. We have this intracardiac echo. You can see this is the right atrium, right ventricle. So all the things that I said now is actually intracardiac echo guided. So we have the sheath placed in. We actually have the device loaded. So device loading and everything is essentially the same. So we take in the delivery system in. You can see the delivery system goes in. But the entire procedure here is not guided by contrast. We are actually monitoring everything with an intracardiac echo. Electrical parameters always need to be checked. The device is activated. So the moment it gets in, so here you can see on the intracardiac echo, the device being seen. You can lively monitor, you can throughout the procedure monitor for pericardial effusion. You can see whether the device is screwed in. You can also see how much stable the device is when you are doing a deflection test. So everything with an intracardiac echo is lively monitored, and the same intracardiac echo can guide your both ventricular implant, and here we have found a stable position. We have released the device. So here is the device on intracardiac echo. It's quite stable there. We actually go to the atrium as well. So same, and the delivery sheath is taken. We have the atrial device taken in. So this is the RA appendage. So you can see the device on this is the right atrial appendage. You can see the device in the right atrial appendage and the right ventricle. So this was a nice guided procedure. And again, this showed 100% communication and excellent parameters. Atrial parameters of 12 years longevity and ventricular longevity of almost 18 years. Difficult scenarios, like this was a difficult RA to RV entry. Again, what we used is actually a snare guided approach. So here it was not getting in from the right atrium, right ventricle. You can see because of a difficult angle, what we typically do is I'll actually show one video. This is one video where you can see that the snare catches the tip of the leadless system with an Agilis sheath, and it deflects this system to the right ventricle. And so it is actually a snare guided delivery of the leadless system to the right ventricle, and rest of the procedure is essentially the same. We had the device put in. So wireless CRT was already alluded to, and leadless CSP is the thing for future. So we have till now done about 64 of these implants. 51 were single chamber devices, 7 were dual chamber, 6 were purely atrial based system for sinus nodal disease. Predominant indications were patients with AFib with complete heart block, sinus nodal disease, patients who had infrequent pacing, failed transvenous system, and a lot of patient preference for this kind of system. So 64 of these have been done with average procedure time of 32 minutes, fluoro time was 18 minutes. We have stable thresholds, almost 0.75 to 0.5 thresholds, and you can see the longevity. The longevity is, you can see majority of the ventricular device, the longevity is between 70 to 25 years. Even on the atrial device, when you do a pure atrial chamber, atrial based pacing, it's 10 to 15 years. Only one pericardial effusion we had in the 64 cases, that was TPA induced. One of the cases we did IJ, and 2 of the cases we used snare and Agilis based implant, snare and Agilis guided implant of the RV device. So to conclude, leadless pacemaker has really revolutionized care by redefining patient experience, leaving absolutely no physical reminders, eliminating pocket and lead-related issues. AVIR is unique because it gives you dual chamber pacing upgradability. You can, for sinus nodal disease, purely do a AAR pacing. For patients with intermittent AV block, purely do a VVI pacing and dual chamber upgrade as and when required. It has extremely high longevity, 70 to 25 years longevity for the ventricular device, 10 to 15 years longevity for the atrial device, retrievability at any point of time, mapping prior to fixation, and the protective sleeve ensures extreme safety. You are always going by command electrogram and impedance based, so you are extremely going by electrophysiologic principles. And once you have this, so as I said here, you have two distinct devices which sense and pace both the chambers. You have AV synchrony with eye-to-eye communication to the tune of 95%, upgradability which matches the patient requirement, MRI compatibility, and with all these kind of devices coming in, probably you have advancement of leadless pacing system to every chamber, which is ensuring excellent device-to-device communication, and probably opening up the arena for expansion of this therapy to more and more patients. Probably in future, we might be almost, once it becomes affordable, and once it actually stays the test of time, it is probably going to eliminate the need for transvenous system, and you are really going to have this paradigm shift in the way you manage your patients with bradyarrhythmia. So that's all from my side. I'll be happy to take on questions.
Thank you, Dr. Gopi. Do these patients require any antiplatelet or anticoagulant?
No, sir. No, these devices, post these implants, they don't require any kind of medical therapy. None of them have been shown to have any thrombosis over long term. These are very small devices. They are 38 mm devices, and they mostly encapsulate, they don't develop any thrombus on long term.
Sir, I have one question. The couple of patients you have shown they are having CKD.
Yes.
So this device doesn't have an auto capture algorithm. So
yes.
If you set the threshold at 1.25 initially, are you comfortable keeping? Many of them might have a high threshold.
Yeah.
That time they will go.
Yeah. So that's a wonderful question, because this device to save battery has not put the auto capture algorithm on. But what has been very well proven over time is the pacing location as well as the fixation location is different. So once you have reached a stable threshold, even if you have hyperkalemia and all, your parameters don't change much. You have a wider area of capture, so your thresholds remain rock stable. A lot of them have been done on CKD patients. We always have a twice margin, because majority of the time your threshold is 0.25, 0.5, and you are placing them at 1.25, 1.5, which is almost 2 to 3 times. So you are always in the safety margin, and we have never had any issues with these CKD patients.
So we have a panel discussion on leadless pacemakers. We'll discuss it threadbare there. Amit, your comment, then we'll break for lunch. Yeah.
Sir rightly said that this is the thing for future, and I totally agree. Just one question in my mind. I mean, it's just out of curiosity, because this conductive communication between the two, atrial and ventricle. What happens if patient goes in shock because of some other reason?
Shock, you mean to say low blood pressure?
Low blood pressure. Cardiogenic shock, not cardiogenic shock, suppose he loses blood in trauma or some, whatever, vasovagal. What happens to the communication between
So this has been well tested. So this eye-to-eye communication, it actually goes through the blood pool. So this, what has shown is the success rate of communication irrespective of the blood volume or blood pressure is 99%. So the communication is quite robust.
Okay,
Thank you. Thank you, Arun. And it was, sir.
Right atrial appendage is a thin musculature and these cavities are small. How much possibility displacement of electrode?
Yes. So that's again a big concern which we had when we started this implant. So the right atrial tissue, the base of appendage, if you see autopsy specimens, are very thick pectinate tissue. So provided you stay base of the right atrial appendage, your chance of perforation and dislodgement is less. The moment you go deeper in, your chance of both perforation and dislodgement is higher. So that's why we give check angiograms, find that there's a good pectinate tissue. Majority of these cases we have used ice to see that we are in contact, and then we are screwing in. And then we do a tuck test too. We do pull the device and see whether it is stable, only then we release.
Thank you. Thank you. We'll conclude the session here. We break for lunch. We'll be assembling here in next 25 minutes. By maybe 3 o'clock, 3:10 would be the right time to reassemble here. We are still having the lunch break, and in the meanwhile, what I'm going to do is I'm going to discuss one, a gentleman who has been seeing me for quite some time, and pacemaker was done by me. Yes. So there is a challenge now how to go ahead in his therapy. Abhijit, can you present the his history and what all problems are there? Anupam, Sojato, Suchit, can you come here? Can you give your comments? Sojato, come. Okay.
Good afternoon, sir. Thank you for giving me the opportunity to present this challenging case.
As you can see that he is the gentleman who was generous enough to come to our conference and allow us to discuss about him. Him and his family are very cooperative. So thank you, ma'am. He is a gentleman who is currently 72 years old. In 2024, he has got few episodes of syncope in January and February. He is a known case of type 2 diabetes mellitus, hypertension and COPD. And for that syncope and he was put on halter, and we found that he is actually a patient of 6 sinus syndrome. So we put him on Medtronic. So this gentleman have been put on by us on Medtronic double chamber DDR pacemaker, and he was almost completely symptom free since 1 year. Then since the last 15 days, okay, thank you. From the last 15 days, he started having NYHA class 3 dyspnea associated with PND also, and he has generalized body swelling. You can see him, it is the picture yesterday. He was put on diuretics, and because of that there is no facial swelling at present, but there is significant pedal edema, sir. There was also sacral edema also. And this is the case history. On March 24, he was put on pacemaker. He is also a case patient of CKD. And in the last 15 days, he had been started having symptoms of failure, NYHA class 3. This is the image of his pacemaker programmer. In this, we can clearly see that the AF burden of this patient is more than 30% in a day. The longest high rate atrial episodes were more than 175 were significant, and patient was in ventricular pacing on 68.4% of the time. Longest AF episode was 7 days. Patient was in AF for continuous 7 days, and patient was also in AF yesterday. So this is the his echocardiography. In this, we can clearly see that there is biatrial enlargement, and his anti-proBNP was more than 24,000. So patient is this is the ECG. Now these are the key problems in this patient: high atrial fibrillation burden, heart failure with preserved ejection fraction, high ventricular pacing rate, anti-proBNP is more than 24,000. So we want to discuss what to do now.
Can we go to the echo?
Yes, sir. This is.
Run the slide, please. Run the movie, please.
Okay. Just a second. Yeah.
So how many of us feel that is 50%?
No, it's 50% because it is 4 chamber. Image is not in short chamber. It is 50%. We have seen clearly.
And coronaries and creatinine?
Creatinine is currently, his creatinine is 2.2 at present. 2 days back report is 2.2.
So the key issue is 2 points I want to have opinion from everywhere. He is symptomatic, disproportionately symptomatic, with these all drugs which is being given to him.
Patient is currently on Cardron. Patient is currently on beta blockers and Epixaban. Patient is currently put on.
He's on diuretic.
And also diuretic.
He was also on ARNI and DAPA.
No, patient is not currently on ARNI.
He's having a urinary catheter, so we have not given DAPA. Yes. So 2 issues. ARNI. What should be the going forward treatment? AF ablation, or we should go for a ablate and pace strategy?
Can you show the programmer?
Yeah, Anupam and
Okay.
Prakashda, Dr. Yadav, what do you say?
Yeah.
What is the LA size?
His LA volume index was 40.
Yeah, AF ablation or pace and ablate pace strategy versus AF ablation. In this, you can see the risk. You also see the risk of doing a procedure. Age is how much?
72.
72, but he looks
age
like.
Is not a.
No. Comorbidity also we have to take
Even
care.
Even comorbidities you can do the AFib ablation.
What do you feel?
AFib ablation
Personally, I feel ablate and pace.
Ablate and pace, because it will also give a QRS which will be narrow.
Yes, sir. And I mean, personally, for doing an AF ablation in this situation will be too much.
That's what I'm telling. The comorbidity and all we have to.
No, AF ablation doesn't require contrast. You have to do 3D mapping, just see, and then PVI, do the pulmonary vein isolation.
5-6 hours, it will 3-4 hours.
No, there is no need of GA also. No need of
Suchit,
GA.
what do you say?
One thing I just want to know, percentage of ventricular pacing is 68%.
57%.
57%.
Yes.
So usually it should not be so much. It's a six-signer syndrome, no?
No, actually, sir, patient is automatically going to OMS mode.
Okay, so I think you should not do that. You should,
Okay.
mode should be, if it, AF
No,
all
yeah,
around-
yes, no, he requires ventricular pacing.
Oh,
I
he
think
requires a ventricular pacing.
in atrial fibrillation there will be a
So there are two,
how
three
to program
issues.
the device is also very important. If you allow conduction and wait for this AV intrinsic beat, and if the patient has a AF, then chances of tracking can be higher. Automated AMS, what do you say? AMS should be
No, AMS,
stopped here?
repeated AMS in a patient is not good. So we have to decide what we are going. If it is always AF, I think you program a VVI or something. Means
No, that is all right. That is all right. But
If
still,
the patient is having paroxysmal AF.
paroxysmal atrial fibrillation. That's why the point of AF ablation versus ablate pace is
But
coming.
then also there is a significant ventricular pacing. That is
Ventricular
very
pacing,
important.
yeah.
No,
yeah.
if you will ablate, you
he-
have significant ventricular. You need ventricular pacing. No, that is okay. I'm just telling why the LV function has reduced. There are
No, that's what the 50% of the EF. So this is also, this is a use of fourth chamber in short axis view, and all my
In
team
short
I have
axis it
seen.
is not,
They see they are convinced that it is 50%. It's not around 30, 35.
Okay, and then
whichever it looks
one
like.
more thing I saw that tissue Doppler was showing a very low tissue velocity.
Tissue Doppler was 20, E by E prime was
No.
12.7.
What was the tissue velocity? Means
Yeah.
with less than 5 or something
Yes,
I was
sir.
seeing.
Yes,
So
sir.
did you consider amyloid and all these things in this case?
No, there is not of LVH and EC, you see, there is no disparity between, and he's a 72 years old gentleman, no echo versus ECG disparity, low amplitude complex in ECG, and echo very high thickness, we don't see that, only tissue Doppler less,
So if it
may
is
not be
not,
that.
then I think-
Yeah, so we can screen for that.
I think that is important.
That can,
If
that
not-
will definitely,
if not
but,
amyloid.
yeah, so
then
amyloid presenting as 72 with these kind of features, unlikely, but definitely
It
we can,
can- it can
I was
occur.
thinking, I was discussing, yesterday.
Because the
we can think
voltage
of
is
that.
very low, myocardial velocity.
No, QRS,
low
but ECG is good.
No, whatever, means I'm telling that.
There will get,
Sir, also I have done the GLS, there was no cherry on top appearance, sir. It was not
Okay,
there.
fine. So
I have
then
seen
I
that.
think for me, I think AF ablation should be tried first. AF ablation is the choice.
Hello. I think before going into the full discussions of device, should have a chat with the patient first. That is my
Yes.
first
Okay.
step one. That means it should be a conversation between the doctors and what patient wants. Every procedure has to be explained the risk and the benefit. AF ablation, nodal ablations. I also mentioned about the CCM technology. You have cardiac contractility modulations, like you have a pacemaker, which can work even in atrial fibrillations. So basically, he has got pacing induced cardiomyopathy.
Patients are actually,
HEPEP. Now, initially, his ejection fraction was normal.
no,
What was his ejection fractions to start with? Normal.
It was normal.
So now it is 50%. So it
Yes,
is pacing induced. So node plus
Is there QRS
synchronization. Very wide. This is pacing
Just
induced.
go back the ECG, show the ECG.
his
Just show
symptoms
the
suddenly
ECG.
worsened in last 15
Just see
days.
the-
He is
show
on
the 12
VVI pacing plus occasional
12 lead ECG, just go back and show the 12 lead.
It is not moving.
पीछे जाइए ना.
पीछे जाके
Sir, it is not happening from here.
Hello.
You close it again and go.
24,000 is the pro BNP. He is in heart failure. We had to give metalozone for just to diurese, get some diuresis.
Let's see the
Kidney function which is GFR is deteriorating. So it's quite a difficult problem to tackle.
Renal failure with
What I personally feel with
ejection
this,
fraction is not normal. It's around 40% because you see apical and part
that makes
maybe
more
40%.
that makes more a case of ablate and pace, I think.
Doctor, how long you are treating the patient for heart failure?
Sir, heart failure symptoms have been happening in last 15 days. Sudden
ECG.
decompensation.
I think you should manage the
ECG,
patient first
ECG,
as any patient
ECG
without
12 lead.
pacemaker,
Yes, sir.
with atrial fibrillation, with heart failure.
Yes, sir.
ECG 12
First
lead.
try that for few months. If patient improves by that, and
Yes, sir.
more likely that patient
No,
will
it's
improve by
QRS
that.
looks
Yes.
in
Then
echo.
consider
Echo looks white.
ECG.
In ECG,
That is
echo
already
looks
done,
white.
Dr. Subir. That is already done. Patient is on diuretics for 7, 10 days, 15 days, I think. It's
No,
quite
12,
symptomatic.
Yeah.
If,
This
if
is
you
clearly
control his heart
LBBB,
rate, ejection
LBBB,
fraction will improve
left
and
axis
his failure
deviation,
will improve.
and it's a pacemaker mediated pacing induced LV systolic.
What I also feel. If we do a optimized CRT, or maybe add the third lead here now, there's already a 2 leads, third lead, and ablate the AV node, that could be the final
Or
answer.
do the conduction system pacing.
If anything, yeah. So we have to normalize that.
System
So
pacing
I think that looks fair, the decision. LV function is not proper.
Or you
It's not
ablate
like
You ablate the AFib and do the conduction system.
AFib ablation, I am little bit scary in this high creatinine and
No,
yeah.
it doesn't matter.
Yeah.
It doesn't matter. Because it's an ablation, there is no need of contrast or anything.
Thank you, I think. Thank you.
Thank you.
Let's go ahead with our program, and thank you for coming. We had a discussion on you. We'll discuss 1:1:1. Thanks for allowing us to discuss him in front of everyone. It's not something everyone is okay with that. But even then, decision remains difficult. Decision remains difficult. Whatever we do, it has got pros and cons. If we do ablation, chances of risk is a little high, and also we can't say that AF ablation will work 100%. There is a recurrence rate is there. Ablate pace, if we will do, that will be giving a short-term benefit for sure, less risk than the AF ablation, and hopefully things can be managed. And he is already on medical management for quite some time. Okay, let's see. Thank you so much.
It's good real case discussion. It's very good. Real problem, real solution search.
Can someone help, please? Sabha, can you ask someone to come? Yeah. Monday? Kal parson आइए. Raja, please help him. So may I request Dr. P.K. Hajra sir to start his presentation, and may I invite Dr. Pulkesh Sinha, Dr. Lipika to chair the session. Please, Dr. Lipika Adhikari. Dr. Kumar Saurabh and Srishti, they are there. They can also please join us.
Right. Thank you, Dilip, for continuations of device update. When you know that almost 1/3 of the pacemaker implanted in India are done here in Eastern India. That includes Anupam Jena, and also includes Guwahati and other Shillong. So Shillong friend is here, Amit. So we have a beautiful experience of having newer technology And I learned it, Dilip learned it, Amit and Anupam will also spreading this innovative technology for the next generations to come. Now, this is a new kid in the town about the double chamber pacemaker from about before that. We had Micra AV, the Micra here, we had two. So difference between these from a longevity point of view, ease of implantation has progressed over time. So today's talk is on sinus node dysfunctions, where you have many debates whether you should go for many theories and viewpoints for many years, starting from my student days, whether AIR is sufficient. So here is a patient, cortical sinus syndrome, discovered to have long pause, and if it is young, one kind of pathology, if it is old, different kind of pathology, thyroid, etc., should be ruled out. So cardiac pacing is definitely indicated for his syncope. Now the question is whether he's got additional AV block. So that means you do a single chamber pacemaker and he may be doing well for next 10 years if you have hardly any pacing need. And on 11th year, he developed complete heart block. Now you are in a dilemma whether the first procedure was right or wrong, because he needs now a ventricular pacing. And you regret if he gets infections after opening the pocket. So some people go for VVI most of the time. So as long as the VVI lasts, who cares about the ventricular pacing induced atrial fibrillations? Our success of a great implanter is not to have infections. Patients should live relatively or a good longevity without a need for second device. Now, this pacing therapy, which therapy needs, there is a trial, and this trial is DAN-PACE trial. Large number of patients, this trial goes against going for single chamber pacing in the atrial positions. Paroxysmal AF was observed more frequently in AI, and the findings support the use of dual chamber pacemaker. And if you can have it about like pacemaker today, the longevity which we are talking about, the need for second device, can also be enhanced or prolonged if you can program this type of pacemakers. So programming this pacemaker, the leadless pacemaker in atrial position is very important to improve the longevity. So the slogan is one life, one pacemaker, which will last up to 30 years if patient needs less than 50% of PI pacing. It can be upgraded. So leadless pacing is the new talk of the town, and one life, one pacemaker is also talk of the town. Now what is the future? The future is, again, why not in a 40 years man with 600 syndrome has AIR leadless pacemaker today, and in the future we engulf this pacemaker with a piezoelectric coating. The piezoelectric crystal, it can be stimulated by motion. So the future is if you can embed or encase this leadless pacemaker with a piezoelectric crystal, and which will deform with systole and diastole. So bending also generates a lot of energy. So it will be lifelong. That means it can last for 50 years. So that's the future. It can be attached to both cathode or anode, the piezoelectric coating of this pacemaker. So the problem of one pacemaker do not last more than 15, 17, 20 years can be solved with this kind of, whether it is atrial position or in ventricular positions. So there is dedicated one company looking on this kind of enhancement of the battery life. This is not Medtronic, it's completely different, innovative, and they got the best award in IBHRE 2024. And perhaps we are also looking for a pediatric pacemaker which will be for sick sinus syndrome, born with sick sinus syndrome, sinus node dysfunction in kids, you cannot put a conventional pacemaker. And perhaps after top kind of surgery or Fontan procedure, if they develop any kind of conduction block, so you put a kind of rice grain size pacemaker on the epicardium, on the epicardium after opening the pericardium. That can be stimulated by infrared light. So how do you put this infrared light? So there is small hole in the sternum. Through that, a probe is there, an AI driven. So light, red, not blue, not green, only red light. If it is red, that frequency can stimulate this kind of pacemaker. So battery life is definitely going to improve. There will be leadless pacing in the conduction system. Leadless ICD we have talked about in the LBB area. And this is the system. Now since the talk is on sinus node dysfunctions, so this is the atrial appendage, and you should look into appendage. If you are really contemplating this dual chamber pacemaker, you can take a pigtail or multi-purpose and start injecting. The beauty is, the atria pulls the ear of ventricle, ventricle pulls the ear of atria, and both can pull each other. So it can be programmed separately. If you program the atria at 60 and the ventricle at 40, the longevity improves by almost 40%. So you have to have some backup pacing at 40. So those kind of possibilities never possible with conventional pacemaker. And if you come close to the ventricle, it will be much more easier. So there are certain pacemaker done on angiogram, coronary CSP, and this type of pacemaker, ventricle. So once you're done with this pacemaker in the ventricle, come to the RO. Nowadays, we tell that the same device should be used for locating the RA appendage. That's the best, but the company says take the pigtail is very difficult sometimes. So if the pigtail is going towards the neck, obviously superior vena cava, pigtail is getting stuck and bending, definitely has entered into the appendage. So 9 o'clock on LAO and 1 o'clock on the RAO, we take this device, inject, and we push the other things like this is the base we choose, and once we are happy with the anchorage, then we release the pacemaker. So if you have a difficulty in it's very small, post-CABG, deformed, it's sometimes very difficult, and especially the diaphragm is up, so hardly any space. So what do? You can use the snare, or you ask the patient to take a deep breath. So once you take a deep breath, automatically, like Dilip and me one day was doing a case, it was very difficult to enter into RA appendage on LAO. So I told the patient to take a deep breath, so he automatically dropped and push. So most of the time, the difficulty can be solved by simple maneuver, take a deep breath. The same thing can be applied to enter into the ventricle. So once you are done with that, then the rest of the things are very easy. The company people will guide you how to release, when to release. You don't have to bother too much. So once it is there, it remains there. Now, sometimes there is an apprehension. So this kind of double movement you will see in the atria, not in the ventricle. Now the problem is if you have embolism, you must have this backup pacing device sheath. They usually provide, not the Medtronic, but Abbott always should catch. And nowadays there is an Ono device. It's a beautiful device. And this Ono device can take anything from the bullet to the TAVR to the ASD, ASD to the VSD, VSD to the tumor, tumor to the micra, anything and everything. So there is a special basket and there is a snare which can drag this, but it is not available. So sometimes it gets embolized. So in sinus node dysfunction, you have a device which is not visible, wireless, lasts for almost ever. It's not like leaving nothing behind, it's leaving something behind which is invisible. To summarize then, in sinus node dysfunction, you will have an opportunity in some patient, if your Wenke back fails at 140, so if you do the Wenke back, if you exclude the AV block, perhaps he can live with single chamber pacemaker from Abbott. If he develops a AV block, then you can upgrade, or somebody who is on VVI can be upgraded to AI if he really needs this AV synchrony. Thank you.
Can AVHRE VR used as a atrial pacing for 6 sinus? Because longevity of AVHRE VR is longer than the AVHRE AR. Now the AVHRE AR 2 has come, which has 25% longer longevity, which is not available at present in India. So do you think VR can be put in the AR?
No, VR cannot be put in the air because there are 2 helix in the atrial system and the size is smaller in height.
Prakash, in case of 6 sinus syndrome, at least 30% cases develop the atrial fibrillation, but when you put there, how much it will not be effective at all. That is the one problem. The second thing, if you do the dual chamber pacemaker, even this leadless pacemaker, how much frequency of displacement by vigorous flaying? In case of ordinary pacemaker, when we do the vigorous flaying, displacement at least 20% in case of children. So what is happening during the vigorous playing on behalf of the children?
Reverse?
Vigorous playing,
Reverse playing, I didn't get.
Playing, khela dhola. Play.
Sports.
High intense activity.
Okay. Play. Oh, intense or contact sports. I think in 6 sinus syndrome, those athletes do not want to have any device. It's a kind of stigma, In our society, if somebody has got implantable pacemaker on the chest, from army, from your sea, from your air force, you are out. You cannot go back. For athletes, perhaps this is the only device where people still can play because there is no cord, nothing is visible. He can hide also, he can cheat. But ideally should not do that, but you can do this with leadless pacemaker, yes.
If by any means atrial lead is embolized, is that can be retrieved and reused or repositioned?
Oh, that's a good question. If the helix is not damaged, so if the device is embolized without any damage to the helix, you can see after retrieval, you can see the helix is intact or not. If the helix is intact, it can be reimplanted. And if the helix is distorted or elongated, they will provide you another pacemaker free of cost. On the same day, not on the next day. Yes. Yeah.
Since Sir loves innovation, I have one question. Now everything is coming with wireless charging. Why can't a pacemaker have a wireless charging?
Right. So if you go to this device, this is wireless charging of the pediatric one. This can be charged wirelessly. And we have CCM which can be charged wirelessly. So transcutaneous transfer of energy. Transcutaneous transfer of TCTE is possible even with LVAD. Now you have to have a coil. It's a big coil. The problem is if you charge this device with a coil, there will be heat generated. So heatless transfer of energy is also possible. And also possible if you have this room, like 10 patient comes here, and all the walls have magnetic waves, you can get charged like in teller in a barber shop and go home within 1 hour. That is also reality. That's the future. So if I can show you a rechargeability slide, I do not know I'm carrying it not. But it is true that in future, so these are the system which can be recharged. So not only recharge things, also the movement of the heart, systole diastolic movement of the heart also recharges the battery. Yes. So
What about the biological pacemaker?
So we will have a leadless pacemaker panel discussion, and we'll have all the question in this. Anupam, please join us.
Yes. Question list. So biological pacemaker again, sinus node transplant is possible.
SCN, like you, SCN gene, SCN4 gene causes the automatic pacing function. So can this gene be transferred to the SA node
Right.
and cause?
So the problem is if you implant this sinus node, So it can produce almost 40 to 50% of atrial fibrillation and atrial tachycardia. Okay, so you do not know which direction the cell will proliferate. This direction, or towards the proper pathway. So that's a problem with transplant so far. But we have a single cell transplant probably, rather than multiple transplant, and also genetic coding of that particular cell, whether it's a defective cell, or a degenerating cell, or a dying cell, or a just freshly born cell. If it is freshly born cell, then perhaps the chance of atrial fibrillations, etc. will come down. So since it is a panel discussion, if I start with Dr. Jena on the left is always right, then the right is Dilip. What clinical scenarios are you personally seeing today where a leadless pacemaker has become your first choice over a transvenous system? So transvenous pacemaker versus leadless, why it should be the first choice in 2025? Should it be or should not be first?
Sir?
Should it be first choice?
Yeah,
it should be first
definitely.
choice. Then you can go ahead.
So for me personally, first choice will be infected pacemaker, definitely. Because that is one scenario. We know that pacemaker infections are devastating for everybody, for the doctor, for the patient. So first choice is infections. Second choice is of course a person with multiple comorbidities. We don't want to put a device and we want to get away quickly. So second is patients especially on dialysis, very emaciated patients. Then patients, some post-radiotherapy cases, of course, post-radiotherapy patients sometimes we prefer. Then the classical indications like sick sinus syndrome and all those things are there. But these are the indications which are not quoted but which I prefer in the clinical scenarios.
Right. Dr. Mundal, I suppose. Dr. Mundal? Yes. So when we started our training post-DM, the pacemaker was done only by professor, because accessing subclavian vein was very difficult. That the sheath was larger. So what is the most challenging thing of doing transvenous ICDs or pacemaker, and whether that can be mitigated by leadless pacemaker?
Yes, sir.
Easy to do? Is it much easier to do than conventional pacemaker, or more difficult?
So I feel in most of the patients where Sir was telling that very old, except very old age where the venous anatomy can be different, challenging, and the possibility of previous infections which can lead to infection later on.
No, I'm talking about infection. Yeah. Is it easier to do than theoretically speaking, mentally speaking, philosophically speaking?
I think transvenous pacemaker is a lot more easier and convenient.
Right. Dilip, is easier or more difficult?
In most of the patients. Because we are familiar with transvenous pacemaker. I tell you the learning curve of this leadless will be even less. Because you get to see so many cases of transvenous. When you start going to your DM days, you see monthly 20 cases are happening, 30 cases are happening. You pick up very quickly. And in leadless pacemaker, if 20 cases happen, you pick up next 7 days. That is the
basic.
Malviya, let me frame the question for you, then you can answer in that.
I just want to add one thing. In interventional cardiology, there is one basic principle: unlearn and then relearn.
Right.
So once you do this leadless pacemaker cases, you will find it so easy that transvenous would start looking difficult to you.
Right. So Malviya, you are given 30 leadless pacemaker free of cost and 30 conventional pacemaker free of cost in a patient suffering from complete heart block. Which one you will pick?
Sir, I'm definitely going to pick leadless pacemaker, and the reason is not only the medical reasons which have been discussed here, like recurrent infections and all this. Patient experience is also a very important thing in the current era of practice. The amazing experience which patient has, that cannot be disregarded, despite the cost constraints and all those things. But if patient can afford the experience patients have, the comfort they have post pacemaker, and the quality of life they have post leadless is unmatchable with the transvenous lead pacemaker.
Right. So
Prakash, another important indication, the pacemaker syndrome. in cases of obesity, the rolling of the electrode over the pacemaker, chance of the pacemaker syndrome very common.
Jadab?
But in obesity, you see the ideal
Obese is
indication of
difficult.
the pacemaker.
You see, still I will prefer transvenous pacemaker.
Why?
Because I can do conduction system pacing. Because these patients, you are saying complete heart block. Complete heart block means patient is dependent on pacemaker. Because most of the indication for retrieval of the leadless pacemaker is pacemaker-induced LV systolic dysfunction.
You have a point. If somebody
Yes.
develops.
So if I need a complete heart block where pacing is required more than 20 or 40% of the RV pacing, I will prefer conduction system pacing.
Why not LV wise system?
LV wise system has not come in India.
It will come.
Whenever come, then we'll think of.
So by the time he develops pacing-induced cardiomyopathy, wise system will come.
Then leadless conduction system pacing will also come.
Okay, so you have a point. You have a point. I agree. So there is one patient came back to me. डॉक्टर साहब हमको तो पेसमेकर बैठा ही नहीं आपने मेरा फिजिशियन बोल दिया उसको लाभ मिला ना बाहर मिला ना कोई ईसीजी में भी मिला ना मैग्नेट में मिला आपने मेरे को बुद्धू बना दिया एनीवे डॉक oh there is Dhananjay has joined so I'll come back to you later third
Trivedi
third
Dr.
in
Kumar
the Indian clinical scenario, how do you view the current and evolving incidence of sinus node dysfunction requiring permanent pacing? So, what is your experience? No, the other one. Your name, sir?
Kumar Saurabh.
Okay, so please pardon me if I forget your name or because I am also developing dementia, name dementia only, not science dementia. What is the chances of developing 6 sinus syndromes, sinus node dysfunction in your practice out of 100 patients requiring pacemaker?
Sir, around 25%.
25%. Who are those? Young or elderly?
Sir, more in elderly only, but some patients of young have.
Okay. What is the spectrum of sinus node dysfunction like tachybrady, sinus pause, sinus arrest?
Sir, it has from tachybrady to sinus arrest, all patients I have found.
So what are the tests you do in practice to diagnose sinus node dysfunction? It's not like 5-second pause, somebody who has a syncope.
It's a mini EP.
Pardon?
With mini EP study.
EP, which EP? What parameters you do see? Sinus length.
SNRT.
Yeah, SNRT you should do.
Yeah. SNRT and SAC.
And also nowadays external loop recorder. So perhaps sinus node dysfunction you can do away with single chamber pacemaker AIR, especially in young people, elderly people. If you're 140, this Wankibak is not there, then you can. So fourth question, how does the availability of dual chamber leadless pacing influence your long-term management strategy for younger patients who need lifelong pacing? So one life, one pacemaker, do you think is reality or it's a myth? That leadless pacing longevity is far higher than conventional pacemaker?
So, as per that present scenario, the longevity has extended very much. So, in future it is possible, I think, as you have shown already, like the piezoelectric crystals induced. So, if we can save the battery too much, we can minimize the pacing. Even in a leadless pacemaker, we can achieve a 30 years longevity, I think.
So, you know this best feature in dual chamber pacing for improvement of the longevity is MVP. Or
MVP, yeah.
So it is not there in conventional this thing. So that may be a hindrance to have longevity. But they have improved the life of the pacemaker by AI and the different kind of battery. Different kind of battery.
Sir,
okay.
I have a...
Yes.
Yeah. People have done leadless AVIR VR into atrial position in 6 sinus syndrome when the AR was not available. Because the longevity is around 25 years. So those patients who is having 6 sinus syndrome and the AV conduction is normal, you can put the leadless AVIR VR at atrial position and have lifelong battery.
Micra?
No, not Micra. AVIR VR at atrial position.
Ventricle in atrial position. The company will not allow it.
No, the company don't require it, but people have done it. There are several reports where the patient is having 6 sinus syndrome and AR was not available. They put VR and found to be longevity is 25 years. So
that can be done.
In that case, long term, what you need is the lifetime. So it can be prolonged for lifetime. Or AVIR AR2, which has 25% more longevity of atrial battery. So that device, if comes in India, it is now available in US.
I think a lot of understanding is changing, and with more of experience with this programming and how these devices are communicating, how much is the battery range, will you come to know more in future.
But whether, say, once complete heart block develop, you put another AVIR VR in the ventricle, whether they communicate or not,
They won't communicate.
So Dr. Malviya, you know, if you put a heavier pacemaker like ventricle in the atria, what will be the chance of embolization versus a lighter designed for atria, dedicated atria?
Sir, as far as I know, they are designed, atrial is designed for atria and ventricle is designed for ventricle. The ventricular device is bigger and heavier. So I have no idea if it can be put in the atrial position.
Yeah, pajama is for the legs and shirt for the body.
Because there's a structural difference that there are two helix in the atrial device. There's only one in the...
But it has been reported that AVIR VR was put in the atrial and it was normal.
It can be done. It can be done. There are reports. I agree.
Both can be put, we are talking about the ideal scenario.
Both can be put, but the only thing is when you are screwing at the atrium, this is a thinner muscle and chances of injury will be there. So in that, the only one inner helix is electrically active.
Okay. So if you have a IVC obstruction, a IVC filter, what are the way you can mitigate for mitral TR or TMVR or leadless pacemaker? How do you mitigate interrupted IVC problem or a thrombotic occlusions or a filter?
It's a very quite possible. And we had seen
Mic to opere.
Yes.
Just pick up the mic. I can't hear.
I mean, jugular access is quite possible. We have seen in the morning.
So people have done from jugular, from axillary vein, also remove the filter by laser, can also recanalize the IVC by laser and balloon, etc. is possible. It's not impossible. So these catheters are so flexible. You can put through the azygous vein. So there is one case reported by Dr. Babu. He has done through the azygous vein. So it's not difficult most of the time. Now, you know, Lipika. So you have this Tabor, who is a master sitting here. He is a proctor in Eastern India for the first time. And we have learned wireless pacemaker. And initially there are a lot of large bore sheath issues, and he does every puncture on the ultrasound. To mitigate the complication of large bore sheath, do you think ultrasound is must? And what is the chance of developing peritoneal hematoma, retroperitoneal hematoma, or local bleed from large bore femoral vein access?
Large bore venous access?
Yeah.
Yeah, USG guided is definitely a good choice, but for venous access, I think if actually it should not be done in ad hoc basis. Right, if we want to do it in ultrasound guided, it should be regularly practiced, and USG guided puncture is always better than blunt.
Right. So coming to Dilip, if somebody is on dialysis or a future dialysis program, and a fistula in one hand, maturing fistula on the other hand or this hand, or a pump catheter, and the access is difficult now, how do you convince the patient who needs a future dialysis? For example, creatinine is 3, and he's got some indications for the pacemaker down the line, bifascicular block, recurrent, one syncope. How do you convince these patients who has...
So we require more, even if there is a fistula, we are not sure that this fistula is going, how long it will going to function. There can be problem fistula, they have to go over Cath, and then so the subclavian access should be there intact, and that's why in CKD patients leadless option.
Yeah.
It's a better option to say that even if fistula is working, you never know what is going to happen tomorrow. You should go for the pacemaker, which should be leadless.
Yeah, Dhananjay, nowadays we discharge the patient maybe same day or next day, even after replacement. How the patient comfort and the stay in the hospital differs from conventional pacemaker to wireless pacemaker. The hospital stay and the day of discharge.
Good afternoon.
Would you discharge next morning, same day? Or?
Yes, sir. My protocol is to discharge on next day morning, and I have more of a philosophical view on this matter. Is that?
Mic to upar do.
Yeah.
Thoda upar karo.
Yeah, I have more of a philosophical view on this matter. Actually, the problem lies in the conduction system. So the wire, the device outside is no use for the treating the disease inside the heart. So the technology should move forward, and coming days we should treat where is the disease lying. So we put the device, there is a coronary block, we put the stent in the coronary. It's not something going out of wire from the femoral connecting there. So in coming days, we don't have the technology right now. So coming days, it is miniaturized, it is getting evolved. Sometimes we might be able to put a device through the coronary sinus into the LV so that wireless CRT-P can be done. In future, D can be done, in fact, if the vision is there. So it's like Apple. So when Steve Jobs in 1995, he told, we can't put it in MacBook. We have put it in now, but in future we'll put it in MacBook.
Okay, so next is quick rounds. Anupam, somebody has got pacemaker, just quick round, just 2-3. Pacemaker infection today, pocket infection. Which day you will advise a leadless pacemaker?
Oh.
Pacemaker pocket infection today.
So explanted, so for personally, pacemaker explanted today, I'll give antibiotic for 24 hours, then leadless pacemaker.
Right. Mondal
is going to present, sir. Next,
I'm going to present
same
exactly
thing.
on the
Same topic.
Same topic.
Same
Then
topic.
I
Next
think we should final words from each one of you. Mondal, one line for leadless pacemaker. The slogan of leadless pacemaker: one life, one pacemaker.
I think the sepsis or the infection parameter should come down, or having downtrend, or at least we should give 7 days of antibiotic. Then we can put semi-permanent pacing for backup support if the patient is dependent.
Right.
Then we can go ahead.
Okay,
with
next doctor, one slogan for leadless pacemaker is coming
So
in your mind.
leadless is there to stay and will take over the...
Yes, your slogan for leadless pacemaker? One life, one pacemaker.
It's going to be the choice in the next.
Okay,
next
Onu?
phase.
Sir, it's not one line, but I just want to say 3 lines.
3 lines.
When leadless came initially, it was in our minds that it is meant to be put in patients where we cannot put the conventional transvenous pacemaker, like very elderly, very frail, infected patients. But now the indications are expanding. Now it can be put in various other indications as a primary modality of treatment. So that mental barrier we have to break. It is no more about the old conventional this thing.
One line for pacemaker, leadless pacemaker.
It is still not class 1 indication for all, right? So I don't know, the future will tell.
Right, Dilip, last word.
CSP leadless. CSP through leadless. Yeah.
Leadless ICD. Okay. Thank you.
Thank you.
Your slogan.
Some degree of RV dysfunction, or patient develops PHRV dysfunction, any concern with this leadless pacemaker? Suppose a patient has some COPD patient, TR, some degree of RV dysfunction, now developed in complete heart block, or any patient who was put on dual chamber, leadless pacemaker, maybe dual chamber, now develop pulmonary embolism, severe PHRV dysfunction. Is there any chance of problem with this pacemaker?
No, I don't think where you think about a conventional pacemaker, the same thing applies for leadless pacemaker nowadays.
Good afternoon, sir. Sir, I want to ask just one question.
Thank you.
Sir, one question.
No more questions. Guys have to catch the flight. Abhijit, you ask, sir.
Sir, just one question, sir. I am very curious about that, sir. Sir, you have told about athletes, sir, that in athletes you will prefer leadless pacemaker, and you will say no for activity in case of lead pacemaker. So I want to ask, is there any programmable parameter or thing to inhibit the upper tracking rate behavior or Wenkeback in those patients, sir?
Program, I think this is the program to null leadless pacemaker.
So, Abhijit will give you the answer. We move forward for the next presentation. Amit will show a very intrigue kind of subject which was discussed partially here, and he's going to address that, showing some evidence and what all is happening on that front on infection of the infected pacemakers. So may I request Dr. Amritesh Biswas, Dr. Arnav Chaudhary, Dr. Adit Ruya and Dr. Soumitra Dey to come on the dais, please. Satrajit Samant, Dr. Satrajit?
This thing about infected patient when to put the pacemaker. So obviously we are not going to discuss, I assume that in a patient of CID infection, we have already decided for the discussion purpose that we are going to put a leadless. Now the question is, what is the timing and how to do?
Sandeepan, please.
As we all know, there are no guidelines set and there are no very limited data regarding the timing of intervention in these patients. When do you extract the lead and when do you put the pacemaker? Do you, Amit, वो desktop में है हम उसके. So when do you, and what do you do first? Do you extract first, give antibiotic, and then put the pacemaker, or do you do it the pacemaker first, and then do the extraction process? Because it becomes a very critical issue, especially if the patient is totally pacemaker dependent. So we had done a small study on that. Dr. Dilip was the lead in this study, but I would be presenting on his behalf. So leadless pacemaker first strategy in CID infection, meaning that you put the leadless first and then do the extraction in the same sitting. And I will show you the results, which are quite encouraging. Why this matters? Everybody knows CID infection is a mess. And especially pacemaker dependent patients are at a high risk of recurrent infection. If you put a temporary pacemaker, do the extraction, and again put another device in the same patient on the other side also, the risk of reinfection is very high. And temporary pacing, this way it increases the morbidity, and the guidelines still now have not defined what is the optimal reimplantation timing. So there is a gap in the evidence. We all know leadless pacemaker reduce the infection, but timing relative to the extraction is not clear, which I was talking about, and a very, very limited data, especially in the Indian setting. So what we did, we did 7 cases of patients who are totally dependent on pacing with active CID infection, and we implanted leadless pacemaker before the extraction, and in the same sitting, excepting one patient, which was done after 48 hours, the extraction of the lead was done. So there was no need for a temporary pacing in these patients. And we had a follow-up of up to 12 months. It was a prospective study done in the eastern part. So the unique aspect of this study was that the leadless pacemaker was done in patients who had active bacteremia along with high markers of inflammation. The patient characteristic, they were ranging from mid to old age, all patients pacemaker dependent. Many of them had prior device revisions or generator changes very commonly, and all of them had either culture positive or high markers of inflammation. So the strategy applied was patients were given antibiotics prior to the planned procedure, and mostly they were broad spectrum antibiotics, and in case of culture had showed sensitivity, that particular antibiotic was started. Then leadless pacemaker was implanted via the femoral approach as per the usual protocol. And once the leadless pacemaker was implanted, then only the incision for the extraction process was started and the manipulation at the CID infection site was done. And excepting, as I told, one case, all other 6 cases, it was done in the same sitting, following a strict aseptic technique and a multidisciplinary management. Our success rate was 100%. There were no peri-procedural complications. Patients were in a mean of 2 days, they were discharged from the hospital. On the follow-up of up to 12 months, there was no recurrence of infection, and serial blood cultures were negative for any evidence of infection. So this is the summary where all the 7 cases where it was done. And in some cases, as I said, even in the presence of active bacteremia, this strategy of leadless pacemaker first and then the extraction worked very well, and patients who were hemodynamically unstable also, this worked. And as far as the literature goes, there is not much because there are only 2 studies available one is from China and one is from Italy. And they have, out of their series of 74 patients, they had done this type of leadless first, then extraction in around 14 patients. And the complication rates were 0 there as well. So the important message is that the strategy which we followed, it works. So the usual fear that once the patient is in bacteremia and we have to explant first, then give antibiotic for 10 to 14 days, let the infection subside, then do the next procedure, it may not hold very true. Although this is not a very big series, but this is something which needs testing and it may prove to be a good strategy in future. But we need a bigger studies, I accept that. And wide leadless pacemakers resist infection because they have a very small surface area limiting the bacterial adhesion. They have a special coating which prevents biofilm formation. And obviously there is no device pocket or a transvenous lead. And they endothelize very rapidly with fibrin encapsulation, which resists the bacterial overgrowth. And plus, sir, let me finish, then I'll answer, sir. So why LP first works? Because we have done the implantation in the heart before manipulating the pocket infection. And as you know, any surgical manipulation leads to a surge in bacteremia. So you have avoided that peak bacteremia before you have, after you have done the implantation. And the bacterial adherence to these devices are low, as I have already discussed in the previous slide. And we, in our experience, have found that it is a viable strategy and it works. So basically what, in summary, our strategy is pacemaker dependent patients who have an active CID infection, you get a blood culture, markers for inflammation done, echocardiography to rule out any infective endocarditis, start the IV antibiotics 2 days prior to the procedure, leadless pacemaker implantation is finished. In the same sitting, you go ahead and extract the leads and complete the procedure. It leads to early discharge and long-term follow-up up to 1 year, which we have. There are no recurrence of infection. So workflow I have already discussed. This is a safe procedure. This is not only like we have seen it, other 2 studies also have seen. And in future, it may become a default strategy for the tackling CID infection. Thank you very much.
Having systemic infection, one pocket infection, you can extract and put the leadless pacemaker same time, no problem. But if there is a systemic infection, if there is bacterial endocarditis, you cannot put, or bacteremia is there. You see, bacteremia with Staph aureus and Pseudomonas aeruginosa.
This is the data
I will not suggest.
We ruled out.
You came out with the case report is different, but it's not recommended.
What was the philosophy was,
It's not recommended.
in cases where it was possible to defer, we deferred. Cases where, we can do that. The idea was patient had to be culture negative. But one case where I did, there was odds were favoring that patient, let it get rid of the device and put a micra because patient was so restless. If you put a temporary pacemaker, he will move around and displace the temporary lead. Patient can die. For different patients.
For that, what we do, we put that from internal jugular,
this is very much possible.
lead and pacemaker external and entrap with
this is very much possible.
Yeah.
Our
with the bacteremia, Pseudomonas aeruginosa, Staph aureus, bacteremia.
Our series is about to be published in PS journal. Revisions have been asked and we have given the revision. Only one case there was some infection marker was positive and there was no other option. Patient was going downhill. I thought let's do it. Patient can be saved and patient was saved. See, and it all came at a background of doing such cases multiple times. 6, 7 in our series. I have done many times outside where I have
Sir, let me say one thing. Sir, we are not saying, sir, just a second.
That is the...
Sir, it's not about case report. What we are not saying this is the default strategy. We are saying that this is possible.
It's possible.
This is the first step, sir. Please understand.
Infective endocarditis has a 100% mortality.
80%.
If this is one disease, mortality is 100%.
Yes.
So must be must be
Sir,
excluded.
we have not
at least
included
before
IE
doing
patients,
that.
sir.
There is a
You see, you can
116
escape
cases.
with the one case.
So
doesn't matter.
bacteremia and IE are two
Yadav sir,
different
there is
things, no, sir?
116 case reports, case series. There is
Okay.
no, our is 7. Yes, no. Some of them had this.
No, it is correct. Dilip, you know very well, we have published the case of 425 cases of use of pacemaker in India.
Leadless pacemaker infective anacarditis is extremely rare. That is the foundation of our all this work. It doesn't happen. It doesn't happen because of the
Sir, every day when we brush, the amount of bacteremia we have is more than the bacteremia during the surgery.
First,
That is the basis of discontinuing the antibiotic
Any comments
prophylaxis.
from our chairperson?
No,
This
this
is
is
a concept
important.
building. This is a concept building, sir. We have done it, and we are very strongly founded on this because we feel that leadless pacemakers infections are extremely rare. I searched for the literature, then only I took this step. And there are, and it is not my series. No. Patient was afebrile when we took the patient. Patient had, culture positive also, but the odds of keeping the patient for long on temporary and all this extended temporary was higher. So we had to get rid of this, infection from there. That was the idea of dealing with this patient, and this strategy works. It will be conclusively proven in future, I tell you. Leadless pacemakers are very safe infections. They don't catch infection. That is our, hypothesis and principle which we follow.
Oh,
No, sister, it's all right, sir.
Dilip.
The patient was given treatment.
No,
Patient
question
was-
of that, you have to give the antibiotic at least 7 days. We published 425 cases of reuse of the pacemaker.
That's what was done, sir.
They are what to do.
That's
reuse-
what was done. Culture positive also, we gave infection in antibiotics prior, only then we gave.
You have to antibiotic 7
Doctor-
days. You put in temporary patient, it doesn't matter. You have to
Sir,
give the
one by
antibiotic
one.
for
I have
7
two,
days.
three very
Then it
strong.
will do it.
I have 2-3 very strong, groundbreaking kind of hypothesis thought process. One is, in guidelines, if there is a infection, pocket infection, and a little bit of, hyperemia, pocket infection, you have to give antibiotics for at least 2 weeks. How many of FSCAI patients and we practice, we take the device out from here, we put the patient temporary, next 24-48 hours we do 80 to 100 patients we have done, no infection, nothing happens to these patients. Some guidelines, they need to be challenged, and that's what we are going to do it. We will challenge this, we are collecting the reports, and this is also my firm belief that leadless pacemaker, because of unique coating, they don't catch infection, they don't allow the biofilm to happen. Even if there is a bacteremia, you treat these patients with antibiotics,
Dilip,
7 days.
I think
7 days minimum.
We should respect the viewpoints of people who are really doing good number of pacemaker. You have a viewpoint, he has a viewpoint, I agree with you. This is the groundbreaking, not the groundbreaking, the thought-breaking kind of. If you have a local infection, fine. If you have a systemic infections like your TE shows endocarditis, or a scan shows, hotspot, or a hotspot on scan, scintigraphy shows hotspot on a lead or the pocket, you should wait, remove the lead, PET CT scan hotspot. And
None of the
also,
patient had a vegetation,
some
sir.
best
None of
way
the
I would
patient.
say,
No vegetation
Sir,
patient we have
vegetation-
done. Only one patient had an infection which we treated 6 to 7 days. Patient was afebrile for 34, patient had never had fever.
Ashish has a point. Ashish?
I just want to convey one thing.
Yeah.
From the very beginning, how do you feel that you can be able to retract, lead extraction can be done safely? From the lead extraction procedure is not 100% like success rate. So it can happen that after putting a leadless device, you cannot be able to retract extract the lead. So in that situation, what will happen?
So anyway, even if you are not putting a leadless, you are putting something else, you have to get rid of lead. If you can't get rid of, cut it and then come and give it to surgeon.
So
anyway,
that
we are
means
going to same
that-
mechanism. So
sir,
this is just a point. This is a choice of
Lead extraction is possible in 100% of cases if you have a laser. If you have a laser.
No, sir.
Otherwise
Laser
it's
also
not
not.
possible.
No, sir. Laser
Even
success
with a laser.
I tell you, says laser success rate is 92% and mechanical rotational device success is 94% on literature. I will
If
show
you
you.
have both, it is 100%.
So that was a
7 days antibiotic
That
to
is
be
not
given.
the logic.
Let's have the
Done.
opinion of the house, opinion of the chairperson.
We can move
Sir,
on to the next
no, no,
presentation.
opinion-
Samsad has to
Dilip,
catch. sir.
chairperson,
Any
chairperson.
comments here?
Sir, infective endocarditis and bacteremia are separate things, sir.
I have one question, sir. Like
when you are putting the leadless pacemaker first, in the same sitting you said sometimes you are extracting the infected pacemaker.
6 out of 7 times.
Huh?
6 out of 7 times we've done in the same sitting.
So if you are doing in the same sitting, then bacteremia will be there at that time.
Yeah, that is what we are saying, that this bacteremia does not lead to a infection in the leadless
That is our
pacemaker.
hypothesis.
Because
This is
it
not
is more or
hypothesis,
less
it is-
resistant to a biofilm formation because of the coating.
That is what I want to come to a point, like whenever there is a pocket infection, we are just not removing the device, we are also removing the leads. Because the leads, the infection can travel through the leads to the heart. So even if there is no bacteremia,
I
we are
have to
still
put it to
removing the
rest.
leads.
Sorry, I'm so sorry. We'll have a discussion on that. Shamsad and Poppy have to catch the flight. Sir has to go to somewhere. So I will ask Dr. Biswajit Undwar sir to come and give his talk, a quick talk, and then we took quick presentations and we'll finish and then we'll have a discussion on that. We'll definitely have discussion. Same set of chairpersons will ask you to come and we'll have discussion on that topic.
I think if those who have a pacemaker living with leads, if they develop septicemia after 6 months, 6 years, do you think the lead gets infected? No, not always. It doesn't mean that all the
If
septicemia
you
lead
save
will
the,
get
try to save the, want to save the patient, adopt my rule, it will happen.
If infection occurs, it has to come out total. Extraction should be done in total.
So therefore, if
Hema,
the
can you join on
infection
chair?
machine to be
Please
taken
come.
out and sent for installation, patient on temporary pacing is implanted on the opposite side after giving the antibiotic 75 days. We have got 425 cases published in Indian Heart Journal 30 years before. In 1995 it is already done. So infection rate does not differ whether new or re-implanted the opposite side after restoration. There has been important data already published a long time before.
But better to culture should be negative and then you put the leaflets and extract.
Dr. Hema,
Good
could you
afternoon,
join on this stage,
respected
please?
chairperson and distinguished audience. Now my talk is on important publication on CIDs in India. This is very difficult to pick up the important publication. There are so many publications in India. I have tried to pick up some on, list may be slightly lengthy. I will try to cover up only the salient features, not the detailed trial, to get an idea that how much work India is going on regarding this. Now introduction, growing to the CID use is India, what the many decades I will tell. Indian population differs, often they are young age, there is chance of infection and there is a background of rheumatic heart disease, though recently the trend of rheumatic heart disease has reduced so much. Evidence driven by national and regional registries. Now this is an important, rather I will not tell the trial, a consensus report on implantation and follow-up of cardiac implantation electronic device published in Indian Pacing Electrophysiology 2018 by IBHRE and Dr. Kapoor et al. And this consensus was 40,000 CIDs are implanted annually. This is data of 7 years back. And CID follow-up must be remain physician-led. Industry support is essential, technical only. This is a very important point. Because many times we rely very much on the company people. Definitely we have to rely, but also we should try to evaluate if there is any problem or anything. This is another publication, a survey of cardiac implantation, electronic device implantation in India by Indian Society of Electrocardiography, published in Indian Heart Journal 2016 by Dr. S. Bora, Jetli et al. At that time, this was Indian remains slightly lower, but now because of the scheme patient, now many patients are getting not only the pacemakers, also the CIDs, ICDs, and even the leadless pacemaker nowadays. So this is growing up. So ICD forms only 10%, yet are not appropriately selected, mostly primary prevention. In CAD with EF less than 35%. And significant gender gap persists with women underrepresented despite better CRT response in DCM. This is one publication from Dr. Suchit also, prevalence of atrial high rate episode and risk factors in Indian patient with cardiac implantable electronic device, real world data. Journal of Arrhythmia, 2019. And there are many points are there, I am not going in detail. Hypertension are the independent predictors of AHREs, that is important. And routine device integration for AHREs aids AF, stroke and thumb embolism risk stratification. This is another publication on Bachman bundle placing on diastolic function in heart patient with non-obstructive HCM. So we all know there is some role of Bachman pacing and many centers this is doing. I think Dr. Dilip Kumar has also done once, I think. Dilip, you have done one? So this is the publication of J. Singh, Subramanian M. and Dr. Narasimhan, published recently in Neurospace in 2024. And this shows that it significantly improved diastolic function, it shortens POF duration, and physiologic atrial pacing via BBP offers a promising strategy. This is another one publication, Dr. Dilip Kumar is also involved. Incidence of coronary artery disease after permanent pacemaker implantation, published in 2024. And the patient number was 699 pacemaker, 61.8% are non-obstructive CAD and 25% are normal coronaries. The low yield of obstructive CAD supports a selective rather than routine CAG strategy. In many centers, CAG done routinely in the elderly person, but many government sector we do not do routinely, unless there is some indication. So that may be the reason. This is one publication from FSCAI Hospital, Dr. Patra, Tusharkanti, Ashit Das, clinical profile of patient undergoing permanent pacemaker implantation in tertiary care center. And these are the data long, because SSKM is probably one of the highest, if not the highest center where pacemaker is done, highest number. Among 5341 patients receiving PPM, 67% were male. And degenerative CHB emerged as the predominant indication. So majority of the Indian data are mainly observational. There is no very good quality RCT. There lies one problem. This is the throughout problem in India. It is very difficult to do the RCT in India. So cardiac implantable electronic device infection design management prevention, a systematic review in 2024, published in Journal of Clinical Health Risk. This is related to infection. So CID infections are serious. And prevention include perioperative antibiotic, sterile technique, infection-resistant material, and risk stratification with PADIT score. This is another one, permanent pacemaker implantation, indication and complication. I am not going in detail, already you have told. This is some registry data, included 8,000 pacemaker implants across major Indian cities. And complication is not very high, relatively low. Pocket hematoma 1.2%, lead displacement in infection. This is important pacemaker outcome in elderly India. There is a many patient, in India we get many young patient and also many elderly patient also. And published in Indian Heart Journal 2012, rather older study I will say. But here 3 to 5 years survival compared to the younger patient. So elderly patient, even pacemaker is complication may be slightly higher, but survival is almost comparable. And age is not a mortality predictor. Comorbidity like CKD and severe LV dysfunction are present also. So age is not a very much predictor that mortality predictor. Definitely there is a higher chance, but associated comorbidity is very important. This is one study published from Dr. Gautam Datta regarding pocket infection. These are the data from the Eastern India, so I have kept it intentionally. And pacemaker infection rate, nothing new. Management is meticulous aseptic technique, perioperative antibiotic, pocket irrigation, and complete device removal. Majority cases, complete device removal is needed. But there are some condition when there is some erosion, but there is no infection, nothing. So there are some case report or some small data there. In that case, plastic surgeon can do something if it is truly it is a non-infected material. This is another one. I am not going in detail, from Goa. And this is one interesting data perspective in the management of recall of cardiac implantable electronic device in 2016, published in Indian Pacing Electrophysiology. ICD advisor recalls are increasing due to device complexity. Though actual malfunction affecting the patient is low, prophylactic generator or lead replacement carries a significant procedural risk. And consensus guideline recommended continuous RM is the standard of care for device surveillance. The CRT data, cardiac resynchronization therapy, published in Indian Heart Journal 2018 by Ajay Nayak et al. And this is a good data. LVA almost improved from 26 to 36% average. QRS was narrowed. 70% were CRT responders. So there is a very good data. This data showed that CRT is a very good option in the currently indicated patient. And this is another Dr. Samoga Sundaram data. Magnetic resonance imaging based dual lead cardiac resynchronization therapy, a prospective left bundle branch pacing study, Madurai LBB study, published in 2023. And in LBB associated non-ischemic dilated cardiomyopathy, LGE CMR effectively risk stratified CRT eligible patient, identifying a large low risk subgroups with minimal arrhythmic events, and CMR guided selection may help avoid unnecessary prophylactic ICD implantation in left bundle in non-ischemic dilated cardiomyopathy, improving cost effectiveness and patient tolerant therapy. This is another study regarding his bundle pacing. And this shows that clinical outcome were comparable at 6 months. Though now coming days, his bundle is slightly in the back foot, I think prospect of LBB pacing is much more than the his bundling pacing because of the media's lead-related complication. This is another publication. Dr. Rakesh Sarkar from our state is also involved. Also, this study is related to his bundle. So ICD for primary prevention in cardiomyopathy. This is a very good data in Indian Heart Journal published in 2024. And it shows 50 cardiomyopathy patients with primary prevention ICD. Appropriate ICD therapy was 32%, inappropriate shock was 14%, and device-related complication was 16%. Highlights clear benefit with significant inappropriate burden therapy. So that is a problem always in ICD, especially in single chamber ICD. And this is another study, experience from a northern state of India, the Srinagar extraction registry. This is a very good study regarding one question of how much extraction can be done. This study showed that 94% complete extraction achieved with low complication rate. So there is a good data on extraction and high reimplantation due to pacing dependence on our population. And this is long-term outcome of permanent epicardial pacemaker in neonate, because this is a one data I have kept intentionally because there is very few study on neonate. And this shown that overall outcome was favorable and mortality limited to the early post-implant period. This is another study from Punosami SS, feasibility and outcome of the left bundle pacing in octogenarian. And here we can see LBB is safe, effective, and provides resynchronization benefit in elderly patient also. Pacemaker lead perforation study. Bradycardia due to loss of capture was the most common presentation. Rare cases has abdominal organ perforation, and protocol-based conservative management resulted in low complication rates and minimal mortality. Not going detail, pacemaker follow-up study. So this is another CRT study. I am not going in detail. His bundle already I have mentioned. So bundle of his pacing. Conduction disturbance and pacemaker therapy in rheumatic heart disease. This is an older study, but we can get some patient with rheumatic heart disease conduction disturbance, and the data, rheumatic heart disease prone to conduction disease due to annular calcification, pacemaker improved functional class and quality, high rate of AF and long-term outcome good except in severe MS or pulmonary arterial hypertension. This is one wearable cardiovascular defibrillator, a live-based till the live boat arrives. This was published in 2014, and it showed that it offers temporary SCD protection during high risk period, post-MI patient and post-cardiac surgery patient. And this is one on coronary sinus anatomy variation, and it shows that coronary stenosis was present in 16%, emphasizing the need for anatomical awareness to optimize CRT outcome. This is one is leadless study. This was previous study. Transvenous pacemaker has 10% complication rate. A leadless pacemaker showed high success and low complication. So to summarize, India provides unique CIED data. Patients are younger, higher infection burden, distinct arrhythmic profile, strong evidence of CRT and ICD survival benefits, increasing adaptation of the leadless plus physiologic pacing. CID dramatically improve outcome in Indian heart failure and arrhythmia patient. Underuse persists due to cost and awareness. AI remote monitoring plus physiologic pacing and continued national registries are essential. Thank you.
Any comments from chairpersons? Otherwise,
Hello, sir. Excellent presentation of the summary of the data shown by different trials. I just want to one comment that most of the bradyarrhythmias requiring pacemakers we have seen it came from the eastern part of the India. So I generally practice in Bardhaman. So we come across a lot of complete heart blocks and other bradyarrhythmias coming from the rural part of Bengal, and many of them are very younger population, less than 30. And apart from doing simple echo and angiogram and thyroid profile, we cannot do any etiological diagnosis like for ruling out sarcoid because lack of facility. So and others also we cannot do the cardiogenetics. So more studies are required for the etiological spectrum of complete or heart block or other bradyarrhythmias who are coming from the rural part of Bengal requiring pacing.
Yes, that is very important because many young patients are developing bradyarrhythmia and we are just putting the pacemaker not able to evaluate because of the many factors. So apart from the genetics and everything, now infiltrative cardiomyopathy, sarcoid is a very important entity. We are seeing many patients because if you do not follow up, some patient after putting pacemaker developing LV dysfunction, we are assuming that it is pacemaker-induced cardiomyopathy. Actually may not be. Maybe only echo we get basal septal thinning. That is a classical finding. I have at least seen 5-6 cases. And recently I have a patient, 2 years back, patient was known to me, put on pacemaker, LV was okay. Now EF gradually deteriorates 25% and was not responding to therapy. We do cardiac PET and PET was echo. We see later on basal septal thinning. During pacemaker implantation, echo was absolutely normal. Now patient also developed VT. We have done PET and that come to a sarcoid. So sometimes dilemma comes whether patient has sarcoid and TB both. So whether to give steroid, ATD, everything. But we had put on steroid also, low dose, not given ATD, and we have upgraded to CRTD. And the QRs narrowed very much. Now we will do the follow-up how the patient is behaving. Sarcoid is an important entity, many times we missed. And sick sinus in young can be the manifestation of sarcoid. That's why AI pacemaker is not very popular because 20% may develop AV nodal disease and sarcoid presenting as sick sinus later on may not involve the AV node. That time AI pacing will not be helpful.
Absolutely. So yeah, one last comment from the chairperson. Yeah.
Sir.
He has a question. Sir. Vishuddha. Yeah, please carry on.
Sir, one question. And one question to the house also. Sir, we are doing a pacing in this eastern part of the India that more than 50% patient is coming below an age of 50 years.
Yes.
As 40 years to 50 years. So should we do a MRI prior to the pacing to rule out any storage disorder or some kinds of granulomatous disease disorder prior to the pacing in an affordable center or in the government center?
Actually, the problem lies time may not permit. You cannot wait for a complete heart block to wait for many days to do MRI, PET scan, then do pacing. So many times you have to do the pacemaker first. And now the advantage in majority, all the pacemakers are now MRI compatible. Later on you will evaluate. Because if index of suspicion of all patient, it is the guideline or majority recommend. If patient age is younger, relatively less than 60 or less than 50, any unexplained AV block, better to do some, at least exclude infiltrative cardiomyopathy. Because if you put the pacemaker and patient is doing well, if we pick up that patient is had already sarcoid, so we can give the disease modifying drug to prevent the LV dysfunction. After 2 years when patient EF will be 30%, already much more fibrosis, then the problem not only because of pacemaker, patient is also now becoming a candidate for ICD also.
So I think below 50 years, CHB requiring CHB, I think best do the genetic study.
Yes.
Thank you. I think we end the session here. May I request the chair, thank you chairpersons. Thank you, sir.
You exclude the genetics and infiltrative cardiology.
So may I request Dr. Samshad and Dr. Poppy to present their cases and then we'll move on with our agenda. I am extremely sorry for changing the schedule. Can we request Sir, Professor Kajal Ganguly to chair the session.
Good afternoon, everyone. So basically, my topic, basically it is a case presentation, but it is a day-to-day challenges which we face during pacemaker implantation. Actually, with coronaries, we are well prepared that what challenges we can face. But during pacemaker implantation, almost more than 95% of the cases for a conventional pacemaker, we can't presume that this can be a challenge which we can face. So I have 3-4 cases. I will show you and what I have done. So this is a first case. This case came to our hospital almost 10 to 12 days back. 70 years obese female who had pacemaker implanted earlier. PG replacement 4 months back. History of paroxysmal AF. She was changed to VVIR, single chamber pacemaker, in view of persistent AF. In emergency, she presented in gasping state, was resuscitated and was put on ventilator support. Urgently shifted to Cath lab in view of bradycardia. People in the emergency room, they felt that pacemaker is not working. Meanwhile, while shifting to Cath lab, her rhythm reverted to sinus rhythm. On ECG now, we were able to see the sinus rhythm. Fluoroscopy of lead and pacemaker was done, which was fine, and a temporary pacemaker was done because she presented in gasping state with bradycardia. So we needed a pacemaker support also. Now we carefully assess the ECG. This was the ECG at presentation. So what we can see? We can see that bradycardia obviously is there. Brady-induced VPCs, RONT phenomena are even occurring, and one clinching sign is there. Atrial pacing is there. A paced P spike we can see in the rhythm strip 2 in between. But we are unable to see that ventricular spike which will pace. This is the sinus rhythm which the patient achieved while being shifted after resuscitation. Now, when I carefully analyze, people from the company, they interrogated the patient while she was on monitor. So they said that everything is okay. When we increase the threshold, pacing is there. The problem was that, this is the pacemaker, no lead issue was there. Problem was there when she was interrogated. This was the rate they were able to achieve, 111. But on monitor, it is quite difficult to see whether it is a ventricular pace or atrial pace. So basically, it was a lead cross connection, what we concluded, that when the output was increased, rate was increased, it was AI pacing, and the patient had achieved the sinus rhythm. So AV conduction was going on well, and the patient was able to achieve that heart rate with a good threshold. So when I was interrogating, I just said that now I will interrogate it in AAI mode because temporary pacemaker is already there, so I have that safety. So this was the AAI mode. When I paced it at 110 in AI mode, it was a ventricular pacing. So this was confirmatory that it was a lead cross connection, and patient was most of the time in sinus rhythm. That's why she was not requiring pacemaker support. But the time when she required pacemaker support, bradycardia occurred and she went into cardiac arrest, and she was brought in gasping state. So, so what I simply did, I just opened the pocket, just corrected the cross connection, and this is the ventricular pacing. After that, which we achieved, this is the VDD pacing. This is more confirmatory that, good cross connection has been corrected. So VDD pacing we were able to achieve, and this is the atrial pacing. So what we can see that A pace V sense is occurring. So we have to be very much careful.
Can you go back to the previous slide. Yeah, the next one. This is the characteristic of crisscross of the leads.
Yes.
Crisscross. This is one. You are getting a atrial, pacing, and then there is a spike just after that. So it can't be. It is not in the range of ventricular safety pacing. So it's not a crosstalk. So what is this? This is a crisscross.
This is a cross connection. So we have to be very careful because at times during PG replacement, we think that it is a very much easy procedure. Even residents can do that. Just leave them to the residents. So whenever we disconnect the leads, so in my practice is that I disconnect the ventricular lead first. I place a forceps and it is a marker that this is a ventricular. Then I pace it, then I remove the atrial lead. Then after checking the parameters, when I reconnect the ventricular first. But to make double sure, I just ask my technician that pace ventricle. So on pacing ventricle.
How did this patient go home? Next day it was missed. No one saw that ECG. Many times it happens.
No, what I said that patient was maintaining sinus rhythm because.
No,
this is the ECG which I got. When I reanalyzed after all the ECGs, and this is the ECG when I reanalyzed after DDD. So next day we got the cross connection there, and the PG replacement was done almost 4 months back. So what I said, that patient was in atrial fibrillation, then she went into sinus rhythm, so she was not needing pacemaker support. But when she needed it, she arrested. Now let's move to the second case. So second case basically, it is a simple pacemaker, but the problem was in lead advancement. So this is the ventricular lead already advanced, so fluoroscopic things we could not take during that ventricular lead. We have a lot of problems in advancing the ventricular lead. We were unable to advance the ventricular lead at the SVC and left brachiocephalic junction. Every time we faced that difficulty. So what I did, I used the CS sheath. CS sheath, termowire, we went with the termowire, we used the CS sheath, the same process. The process I am following with the atrial lead. The same process I followed with the ventricular lead, but unfortunately we were unable to store that fluoro in that process because it was very difficult for us. So the problem with, people say that it will be very easy, but the length of the CS sheath is 45 centimeter, length of your atrial lead is 52 centimeter, length of the ventricular lead 58 centimeters. So for slitting, you need an adequate length of the lead to get it adequately slit. So what I did in this case is, usually for CS lead we start slitting and we pull it out. But in this case, our right hand is static with the slitter. But in this process, what I did, my right hand, I didn't kept it static. In left hand with the sheath, when I was pulling it back, I pushed my right hand forward because I had to cross this SVC-RA junction bend where the problem was there. So in between that, we were able to get through that junction, and the final result was this. Case 3, we had a 75-year-old male, 2 episodes of syncope. In last 1 month, 1 incidence of head injury. Neurological evaluation was already done because prior to us, the patient was under the care of neurologist. So we advised that he will need a pacemaker because he has a bifascicular block, no other obvious cause is there. But family wanted to make doubly sure whether his pacemaker will alleviate this problem or not. So we measured HV interval, it came up to be 88 milliseconds, so we went for it. But venogram revealed persistent LSVC with a absent right superior vena cava. Everything was draining in left-sided SVC. So we can face these problems. It was a very big roomy LSVC and it was straight away connected to the right subclavian vein. So we had a problem in advancing the wire, but anyways, we did it by making a bend in the sheath and then re-entering the wire. Now the second major problem was entering the RV because it was a big RA. Every time, at times we went to the IVC, at times we went again back to the CS because it was such a roomy CS. What we usually do, we usually try to use a atrial curve stellate to make the lead advance into the RV. But when I tried it again and again, it most of the time went back to the coronary sinus because with that loop, the coronary sinus was even bigger than that loop. So I just took a straight stellate of the ventricle, made a bigger loop with it, a bigger curve loop, and again I was able to enter that RV. So I was not able to negotiate up till the apex of the RV, but I was able to negotiate up till the mid-lower part of the interventricular septum, where I screwed. Good parameters I was achieved. R wave of almost 6.5 was there, so I was happy with it. Pacing parameters were good. Again, advancement with atrial lead was there, but with a curve stellate, we were able to advance it, and this was the final result which we achieved. So. And the one important thing with this case is that this case I took for a pacemaker at 8 in the night. I took a venogram of left, so it was LSVC. So I said that I will shift to, I will do it from the right side. Right side, it was absent. So I abandoned the case at 8 in the night because I said that it will take time and I don't want to do it in a hurry. So this case was done next day. not on the same day. And second thing, we do not make a pocket and take a venogram. We take a venogram, we do a puncture, after that we make a pocket. This is the usual protocol which we follow. And similar case, it is similar LSVC case with absent right SVC is there. In this case, it was slightly easier because we had a good experience earlier also, and this is the final result which we achieved. Thank you.
I have just comment. In persistent LSVC, the most difficult thing is to go into the RV. So what we do, we take a catheter like iambic catheter and throw the thermo, pass into the pulmonary artery, and then take Cook extensive wire, and over that we put CS delivery sheet, and from there I put the RV lead, and from PA we take out we put the seat backward and then allow it to fall on the septum, and then it's through there.
I think these options are when we are not able to do it.
So this
I
is
think
the way
we did last, a few days back, 15-20 minutes we could do the procedure, LSVC. So it depends how easily you are going into RV.
So
sometimes it's difficult, then you can
sure.
go with this.
This is 100% sure that you are on the RV and on the septum, you are falling on the septum. Because which I showed the...
Sir, any comments, sir?
Yes, that is difficult. Most difficult part is to go to the RV. So sometimes I have done, yes. Sometimes we do it make a loop in RA, and then it goes to RV.
That's what he did.
It was looks like alpha.
In the first case, we tried to make a loop, but
Yes.
RV was so roomy, CS was so much dilated that at most of the time it went back to CS again.
Yes.
Once it went to the IVC. But
So
anyways,
make a
we
loop in the
change the
RV,
curve
RA,
of the
make a
stellate.
loop in the RA and then it goes.
Yes.
Thank you, Dr. Samsad. Dr.
Thank you,
Poppy, a quick presentation from your side, and then we move on to Dr. Ashish Haldar's presentation.
Hello. Very good afternoon, our respected chairperson and audience. I'm Dr. Poppy Bala, electrophysiologist from the Jayaprabha Medanta Hospital. And thank you for inviting me here. And I'm going to share my first experience with the conduction system pacing. So initially, first 1 or 2 points. The first SBP was described in 1968, and the transvenous His stimulation in the human in 1970. And first permanent His bundle pacing was done in 2000, and the benefit of the LBB technique was first described in the 2017. And Dr. Sandhumoga Sundaram sir has the highest number of the CSP in India, more than 1200. So now comes with the CSP, my case presentation. It was in the year 2022. 2020, 75 years old hypertensive lady admitted to the hospital with the complaints of syncope with the ISD and long-standing AF. Patient has a heart failure syndrome for last 2 to 3 years, which increased for last several months. Especially patient has a hospitalization several times. During the admission, patient has a stable BP, but pulse was 34 beats per minute. Previous day Holter shows the long pause, 4.64 seconds. With this, and underlying rhythm was atrial fibrillation with a controlled heart rate. And that was the ECG, was in the hospital. It shows complete heart block with a atrial fibrillation. After giving the atropine, it becomes reverted to the atrial fibrillation, and AV block is resolved. Echo shows ejection fraction around less than 35% with a ICM underlying and also some endocardial scarring. So the diagnosis is syncope due to pant conduction system disease with the ICM with a severe LV dysfunction. So our treatment plan was device implantation because the troponin I was negative, followed by CAG plus minus revascularization. So there's no doubt about what are the device we should put. It was a CRTD in this case. But the huge problem is the financial issue. So now comes the choice between the heart failure symptom and the financial issue. Ultimately, the financial issue actually won in the end of the day. Also, some drawbacks of the CRT for this patient is persistent atrial fibrillation, lengthy complicated procedures, need dye, non-responder still high, synchronization via BIV still not a non-physiological means. So during that time, the new kid in the block was His bundle pacing or LBP pacing. So we choose the LBP pacing. We started the procedure. and we put the his bundle in the his area. And because the underlying rhythm was atrial fibrillation, still we can mark out the HB just before the RV signal, V signal. So we have cannulated the extrathoracic puncture. For this procedure, we have taken the select secure lead 3830 and fixed curve sheath C315. We have pushed the catheter with a lead. So as we know, we have to place the lead in the RAO position. The tip should be 2 inch away from the tip of the his catheter. And in the LO view, it should be perpendicular to the spine. And we can also ensure the septal position with some dye injection. Started the pacing, but there is no such good notching in the V1. We have removed the area and reposition the lead. There we can see a beautiful notch in the V1. We started to screw. And we have got the beautiful QR morphology in that case. Also, we measured the LVAT, and that was around 77 milliseconds. And the QRS is around 74 milliseconds. And we have put the RA lead. So we have done the angiography next day. And it shows a diffuse disease with the ectatic vessels in right coronary system as well as the left coronary system. So we have opted for the medical management. After stabilizing the patient, we have given the amiodarone, and it is converted to the sinus rhythm after that. So you can see the QRS is around 97 milliseconds. And after the pacing, the QRS become 98. It is almost normal looking pacing. And thank you.
There is no R or R prime there. So what do you feel from where this is coming from?
So it is most probably due to the more towards the septum, but also patient has a diffuse.
That's what in panel discussion I was discussing. This could be a right bundle capture also.
No,
it's a
sometimes, or it can be anodal pacing.
Can be, sir, also the.
Anodal pacing.
This is because of anodal pacing.
Anodal, that's what I'm saying. Two conditions, either anodal pacing or a right bundle capture. Or right bundle capture also you get the same thing. Very narrow QRS, but LVB morphology.
You pace in unipolar mode. And so that
I think it was unipolar mode.
Sir, in the unipolar mode, we can see, sir, QR pattern, sir. Yes, sir. Here. Yes. Yes, sir.
Reasons why you don't get a
so
RS.
it might be also due to the fusion bit. That's why it is a narrow QRS with both RBB and the LBB.
With
sir.
the anodal pacing both.
Yes,
both left bundle as well as anodal pacing, you will have a narrower.
And what can be done during that time, especially 2020, our next plan was to place the ICD lead in the RV and RA lead in the LVB. That would be the win-win situation during that time. But now in 2025, we have Omnia Secure defibrillator lead. It is better than that option also, but during that time, we don't have that type of option. Not in the Indies. So these are some examples of the CSP. And how can I actually locate the area? Especially LBB cases, the location of the really important. And ideally, in the HIS and the RV catheter is a good position. And most of the electrophysiologists done the LBB pacing via the HIS catheter. And also, where there is a EP section is not available, we can also put the RV catheter and hump is at the level of the actually HIS area. And nowadays, most of the operators done without any type of catheter help. And we have done one cases where there is no recording system. We have put only one V1 ECG lead, and we done the full procedure. So already I don't have any type of take-home message because already everything is discussed. So the food for thoughts, newer generation technology is the leadless pacemaker. Nowadays, Backman pacing, bilateral bundle branch pacing area, RBB pacing. Already SARS also mentioned the YCRT, LB leadless CSP, and Omnia Secure defibrillator lead. With that, thank you everybody, and thanks for your patience here.
Thank you so much. I think you should move because your flight is at 6:30. Any comments, sir?
No, that's all right. Only thing is that, why did you convert after the pacing? do I need to convert AFib before pacing? Yes.
During that time. So we didn't actually put any TPI because of that. Because patient is moving his hardly really much. So we don't want to put any extra effort.
Ideally, should be when you putting the atrial lead,
Yes.
because P wave will be very
exactly,
in the
exactly.
atrial fibrillation. So during putting the atrial lead, make the patient sedate and then cardiovert. And then
yes,
see
you
the
don't
P wave. Otherwise, your P wave vary from 0.5 to 3.5.
Yes, yes,
Yes,
that's what I
that
mean.
is true. That
So
is true,
atrial
sir.
sensing and ventricular pacing later on may be a problem. So it is better to have, once you put the atrial lead there, don't screw, find out variation, and then cardiovert and
Exactly,
see whether it
exactly.
is the P wave
That is what I mean.
is okay.
Thank you, thank you, sir.
Thank you,
Thank you, Dr. Poppy. Thank you, sir, for your comments and chairing the session. Now, may I request the chairpersons, thank you, Dr. Subir Ghosh and Dr. Surandan Sikdar to be there on dais, please. And may I request Dr. Syamasis Bandyopadhyay is our special guest because amongst the cardiologists we have a renowned general physician, internal physician specialist, and he is going to talk on importance of vaccination in heart failure patients. So we deal with heart failure patient day in and day out, but many times we miss. And what's the rationale, logic, and kind of evidence and guideline position at this moment about vaccination? And sir is kind enough to give us a whole idea, not only a Shingrix, but he will be giving us entire idea. Thank you so much. Subir, please.
Thank you, Dr. Dilip Kumar. It's been a privilege to stand in front of the cardiologist and hear all about devices. My humble talk is on when we have got all the heartbeat sorted, what do we do about prevention of hospital admissions from baseline conditions like pneumonia, etc. And herpes zoster is becoming an important medical threat, especially in cardiovascular conditions. So we know burden of cardiovascular disease in elderly population is pretty high, and it is between age 60 to 80, it stands quite staggering. We also know that it is one of the major global burden and cause of death, and the burden is growing gradually. And the Indians developed about 10 years earlier than the Western counterparts. So you guys, you know all of that, and I don't need to talk you through about this. But bottom line is that once you have sorted the heart, what else can you offer? Now, there are a lot of vaccine preventable condition in our arena, and especially so in the cardiovascular conditions. During COVID, we have learned that cardiovascular disease, the renal disease, pulmonary disease, diabetes, which is often the mother for all these problems, they carry increased mortality in every viral illnesses. So obviously, all the pneumonias, herpes, there are no exception to it. So the burden of vaccine preventable conditions in adult over 50 is quite impressive. And what happens that adults over 50 with a hospitalization for a vaccine preventable conditions like influenza, pneumonia, herpes, etc. are at increased risk of mortality, worsening health, and loss of independence. And this is the prevalence of infectious diseases in heart failure overall. And if you look at varicella zoster, influenza, and pneumococcal infection, you would see that that is quite impressive for any person. So we know that persons with heart failure has an increased incidence of infectious disease, morbidity, mortality associated with it. And the infections are linked with cardiovascular events under various umbrella and domain. So there is a lot of inflammatory cell in the arterial wall, then smooth muscle proliferation, then thrombosis, then disrupted media, also the cerebrovascular diseases, all the chemokines, especially interleukin 1, 3, 6, 16, 17, then TNF-alphas, they all have direct cardiovascular impact, as we know. You've been discussing about sarcoid and sarcoid causing sinoatrial diseases. So you are into this domain. Herpes zoster in particular has got strong association with stroke, myocardial infarction, heart failure, diabetes, hypertension, renal impairment, heart block. And we know that it causes meningoencephalitis, myelitis, pneumonia, endocarditis, post-herpetic neuralgia, and it can trigger giant cell arteritis and superinfection. So it is a strong trigger for inflammation, or autonomic nervous system dysfunction, and vasculopathy, thus causing all the standard illnesses we deal day in and day out. Now, herpes zoster ophthalmicus, one of the very dreaded consequences of herpes zoster infection that increases the risk of stroke and TIA from 1.3 to 4 times. It also, with patients with history of shingles, are associated with long-term risk of cardiovascular events, strokes, and coronary artery disease, and more so in the older people. So we accept and we know as the evidence stands that viral infections, especially like herpes, increases the risk of MI and stroke in long term. I will just skip these cases. I don't want to bore you with this. And this is the expert consensus statement on adult immunization. And you would see that influenza, which is an annual vaccination, pneumococcal, there are 2 types of vaccination concept. One is a PCV20, which can be given once. And the other one is a PCV13, followed by 2 months to 12 months of PCV23. And zoster are 2 doses of vaccine 2 months apart. This is the current ACC guideline on this. So also the European guideline on Cardiological Society on the same sort of vaccines, influenza, pneumococcus, and herpes. In India, there has been multiple Indian associations who have created an adult consensus on vaccination, and there is, it is recommended over 50 years of age for 2 doses. So vaccine recommendation, actually, if the MMR vaccines, chickenpox vaccines, and people hasn't had chickenpox, then yes, there is a role of chickenpox vaccine and inactivated influenza vaccine every yearly. So whom shall we vaccinate? We should vaccinate, obviously, with limited resources, especially when you have had all these hi-fi medical cardiological devices, is to catch up the people who are at the highest risk of hospitalization, death, and morbidity. So healthcare workers and individuals with chronic conditions. And chronic conditions are cardiac, pulmonary, renal, metabolic, which I said diabetes, hepatic or CLD, and with infections like HIV and autoimmune conditions on steroid. So We know that people with diabetes have more serious outcomes following an influenza infection and it about 3 to 6 times more risk of hospitalization, including 4 times risk of ICU and 4 times risk of death from the pneumonia. So this is quite significant if we look at a general population. The annual incidence of pneumococcal disease in the elderly are about 4 times than the young population, with higher hospital rates, and streptopneumonia still remains a major global threat, including India. So pneumococcal vaccination is indicated as per the Indian consensus recommendations on age over 50. Older adults, as I said already, you get a 13 and then followed by a 23. That should be at least 2 months apart, but you could give it after a year with the next vaccine. Shingrix is a recombinant vaccine on the same sort of platform as the COVID recombinant vaccine was, and it is 2 doses of vaccine, 2 months apart, and it is recommended for over 50 and for high-risk patients in particular. It is effective even in patients with cardiovascular conditions and hypertension, and post-hoc analysis says that it maintains efficacy in CHD and hypertension with a safety profile compared to the placebo. And it is, the immunogenicity has been tried in Indian patients and shown to be effective as well. The vaccine response rate is about 85%, which was the primary objective of the trials. So it is something to keep in mind for your patients who have got coronary artery disease or heart failure. And the post-herpetic neuralgia is a very bad condition to have, and whoever has had any patient would know what I'm talking about. So it can be given with other vaccinations. So any adult with these comorbidities, you can think of giving a pneumococcal jab, an influenza jab yearly, and a Shingrix jab, and that should be a sort of a vaccine preventable. You have taken care of the vaccine preventable condition. Thank you very much indeed.
How many of us were practicing this Shingrix? I really don't know. Sir, you were the earlier doctors.
My take is 100%. All patients who leaving my chamber, they get recommendations from my side, and above 50 years. And it has to be 2 doses because it's live attenuated vaccine. 60% antibody level you achieve with single dose, and 97% protections. 3 cases has been reported in those trial. So my question to Shamas is, if somebody is immunocompromised, the vaccinations, the antibody formation will be much more intense than people who are having non-immunocompromised state or more compromised?
No. Actually, the protection rate with immunocompromised state, be it for native infection of some kind like HIV or on steroid or on immunomodulators, in my practice of rheumatology, many of those patients are on biologics. So it varies between 85 to 87%. But
Right.
there has been multiple studies, even in severe heart failure, with 40% ejection fraction, it is about 85%.
So since it is T-cell immunity, I think.
Yes.
T-cell immunity.
It doesn't matter.
It doesn't matter.
No. You've got the memory with the NK cells left.
So sir, what is the gap between the first and second?
Sorry?
Gap between the first and second dose?
2 months. If you miss the 2 months, doesn't matter, you can give up to 6 months. There has been trials on the vaccine note that up to 6 months you can give it, no issues.
Dr. Lipika, what's your practice? Do you suggest your patients to get it? You are practicing, huh? About Shingrix? No.
Dr. Bandyopadhyay,
Mainak, তুমি কি বলছো? Influenza pneumonia mostly.
Dr. Bandyopadhyay, the shingles vaccine in your patients, what is the acceptance rate?
I'll be honest, once I think Amitabh Bachchan came in the telly and said that the vaccine should be taken. So some of the patients say, is that the Amitabh Bachchan vaccine you are talking about? So yes, it is little expensive, but for our patients, I mean for rheumatological patients, people do take vaccine because they are afraid of the immunosuppressed state. So they are on multiple biologics. My patients are on a lot of biologics. So they do accept it. For your patients also who are in heart failure, I think if they know about it, they would accept it. I think part of the problem is that we don't think as an adult practitioners that vaccination is something we need to talk about. It is a pediatric domain. That's how we have been taught. Our generation been taught that vaccination is done by the pediatricians, not us. So I think once we talk about it, people will accept it. That's my understanding.
So actually I had a patient of an interval MI and I did a primary PCI for him. And he had a heart failure because his ejection fraction was something around 35. So he landed up in this herpes zoster and he came to me yesterday still having pain with the herpes zoster. So post 1 year, herpes zoster pain still persists. So if
Absolutely.
you have that message is important here.
And you could vaccinate him now also.
Yeah. Okay.
Yeah, not having a infection doesn't protect you completely.
Thank you, sir.
Thank you.
Thank you for coming to us, to our conference and talking to us. Thank you so much. Thank you, Surendran and Dr. Subir. So we go to the next presentation. May I request Dr. Bipul Roy, Dr. Avik Karik and Dr. Subrosekhar Chakravarti to please come on the dais. And over to Ashish.
Good afternoon, everyone. I feel the audience is going through the attrition phase right now. So my topic is MRI and CIED update and recommendations. Every now and then, whenever we see patient, we recommend pacemaker implantation for the patient. After the pricing, obviously the first question they will ask, Dr. Bo, eta ami MRI korte parbo to bhovishote? So in the next 10 minutes, we'll be finding the answer. So the most common terminologies we come across in respect to CIED is whether the device is non-conditional or non-compatible or non-MRI compatible. So they are used interchangeably. So device is MRI compatible or MRI conditional only if the device components, that the pulse generator as well as the lead components, both are MRI conditional and both are from the same manufacturer. If you use the lead from Abbott and use the pulse generator which is from Boston or Medtronic, this combination is not MRI conditional. This is not compatible. And obviously that must be tested in a MRI field strength of 1.5 or 3 Tesla. That is quite product specific. So whenever the patient has to undergo this MRI investigation, we expect some kind of interference with the MRI and CIED. To have a best quality image, MRI actually relies on these 3 factors. One is static magnetic field, the gradient magnetic field, and the radio frequency field. Static magnetic field, it interferes with the ferromagnetic component of the pulse generator. It will have a torque effect. There is a chance of pulling. And gradient magnetic field, it actually induces the current through the lead. It actually invites the arrhythmia to occur. Radio frequency field, on the other hand, will have an antenna effect. It will cause lead tip heating, will cause myocardial damage, and there might be a change in the threshold and sensing and there might be requirement for generator replacement in the longer run. To avoid this potential problem, there are some part modifications which are made by the engineers. Obviously, the ferromagnetic components were reduced much. There are sensors which will be modified, and obviously the lead components were changed in respect to the lead winding pattern, and lead tip was covered with some material to prevent the lead tip hitting. And obviously we need to rely on the MRI settings to have the best quality image, as well as to make the procedure much more safer to the patient. So whenever the healthcare provider is ordering for the MRI, that needs to be communicated with the imaging team. He will assess the requirement for the imaging, as well as plan the imaging sequences. He will assess whether there is any contraindications to MRI or not, and that needs to be communicated with the heart rhythm device team so that the device related programming can be done beforehand. So whenever the device is MRI compatible, that is okay. But whenever that is not compatible, then there is a problem. We need to have a separate consent taken from the patient in respect. For example, if the patient is having any abandoned lead, you need to communicate in properly that you have got abandoned lead. So there is a chance of lead tip hitting. There might be some damage to the lead as well as myocardium, and also patient might have some discomfort. This should be specifically communicated to the patient and consent to be taken from the patient. There are some real-time questions. For example, mixed vendor. We sometimes mix up the lead as well as the device entity. Whether we can say the patient can safely undergo MRI in this situation or not. Yes, this is a low risk situation if both are MRI compatible, but mixed vendor situation, the patient can undergo MRI safely. This is also true for the other situation, that is MRI unlevel pin plugs. But we need to consider several situations. 3 situations are important. One is abandoned on fractured transvenous permanent pacemaker lead. The third is the epicardial pacing leads. So these are the conditions which are high risk situation. We need to be very cautious. There might be chance of complication in this scenario. Especially in situation of fractured lead and abandoned lead, where you can expect some sort of heating involving the myocardium, and obviously the patient will have some form of arrhythmia. You can expect that. So you need to be very cautious in such scenario. In some conditions are absolutely contraindicated. For example, those patients who are having TPI in situ and the floating leads are there, not fixed with the myocardium. In such scenario, the patient should not undergo any MRI investigations. So in short, what are the pre-scan parameter needs to be changed? If the patient is having intrinsic rate of more than 50, then we need to change the parameter in sensed mode, that is either ODO or OVO depending on the situation. If the patient's intrinsic rate is less than 50, the mode should be changed to the asynchronous pacing mode, either that is VOO or DOO mode. We need to change all the settings in bipolar pacing mode and inactivate the magnet response. And as soon as the MRI is done, the patient need to undergo repeat device checking in the coming 24 hours or 48 hours. For the ICD, you need to turn off all the therapies, tachycardia therapies, that is ATP or shock therapy, need to be stopped altogether. So this is an example from Abbott system, how you need to do the MRI setting. So these are the parameters. So now you have advice for MRI, what factors you need to measure or see during the procedure. The first thing is that immediate availability of the drugs and equipments necessary for the ACLS. Programmer should be available. Patient will have a monitoring system, ECG, blood pressure and oximetry, and obviously all patients need to report any kind of discomfort if he is facing. And the radiologist should be available there because he need to see the imaging also. Why? This is required to avoid the repeat scanning, which may be not required. After the scan is being completed, we need to interrogate again to see whether there is any change in the threshold lead parameters, and obviously we need to be very cautious, and reprogramming after 1 week is required if following things are present. To summarize from the programming part, if the system is MRI conditional, after 6 weeks the patient can safely undergo MRI. If it is less than 6 weeks, obviously that is class 2 a recommendation to undergo MRI. If the patient is having non-conditional system, in that situation, in absence of epicardial leads or fractured lead or lead adapter extender or abandoned lead, these 4 situations, if you do not have that, then obviously you can undergo MRI. If in presence of that scenario, you should strongly consider for another imaging modality instead of MRI. So there are MRI scan related issues. MRI field strength, if it is 1.5, obviously that is okay. One thing I must convey that if the device lead assembly is conditional to 3 Tesla, it does not mean that that will be conditional to 1.5 Tesla. This is very, very true. So if it is written that it is conditional up to 3 Tesla, then that is okay. So there are some settings that can be done manually in respect to MRI, so that the image quality can be retained as far as possible, and can make the MRI much more a safer investigation in presence of CID. Obviously, the MRI, if it is from GE or Siemens or Philips or Canon, they have got some specification pertaining to this to make the MRI much more safer procedure. In special situations like leadless pacemaker, yes, there are MRI compatible 1.5 and 3 Tesla. ILR, they are also MRI compatible up to 1.5 or 3 Tesla. But we must remember, always store the data before putting the patient to MRI, because it has been seen that these data can be erased, or sometimes there may be the ILR data might show there is ventricular arrhythmia or pause. That may not be true. That is because of interference with the MRI. Subcutaneous ICD, that is also MRI compatible or MRI conditional, but up to 1.5 Tesla. To summarize, before scan, always think about the alternating imaging modality, especially in such 4 situations that I just mentioned. On the day of the scan, actually take the consent properly from the patient, program the device according to the need, and BLS trained staff and ACLS trained staff must be there just outside the room to manage the complication if it happens. Obviously, it's a key that it's a collaboration between the referrer, cardiologist and radiologist, so that the procedure can be done safely, and as well as the imaging can be retained or properly taken. Thank you very much for your patient sharing.
Are there any questions? Fantastic presentation. So I have a query. I have few patients where nowadays we are doing lot CRT, lot CRT-D. Now lot CRT-D, you need to cap one of the lead. Whole device is MRI compatible, but one of the lead has to be capped. Now there is some confusion because I have around 3 such cases where lot CRT, left bundle optimized CRT-D was done. One of the lead is under cap. So can we go ahead with MRI, because the manufacturer suggests it is MRI compatible device, but if you cap some lead, then is it MRI, do you suggest to go ahead with MRI?
So the situation is, so that is actually a functional lead which is left untouched. So that is called abandoned lead. If it is capped, the chances of lead tip hitting will be more. So that is undoubtedly that is true. But whether the patient can undergo MRI or not, that depends upon the consent taking. As I mentioned, in such situation, you must be communicating the information to the patient that there is a chance of lead tip hitting, as well as the chance of increase in the threshold, as well as a sensing might be altered. But in real life scenario, the chances is less. there is a smaller data to prove that there is a higher chance of complication. So you can undergo the scan, but there is a chance. If the patient agrees for the same, then you can safely undergo MRI.
Absolutely, I do agree. There was a very large study which was undertaken, and they found that all those non-conditional MRI pacemakers and leads, when they underwent MRI, what happened to them? Nothing, not much of any significant difference happened. No such huge complications happened, and there was a recommendation, class 2A recommendation from HRS and EHRS that we can go ahead with the MRI with the risk consent. Usually it doesn't happen, but since it is MRI non-conditional, we can go ahead. Nothing happens as such, but consent has to be taken, and this case is very unique. This abandoned leads with a tip which is capped. It comes under technically abandoned leads, and abandoned leads, the situation is little difficult. But usually nothing happens. Nothing happens. This has been proven, and HRS was forced to change its recommendations from class 2B to 2A, even non-conditional MRI pacemakers and leads.
Thank you, sir. That was enlightening. So if there are no more questions, thank you, Dr. Ashish.
Thank you. Avi, can you comment? So now may I request Hajra sir, stay back there, Subro. Subro, stay back there.
The hall is half empty or half full? I think hall is
half full.
Half full. So the change of perspective, if you see anything on a different perspective, the outcome may be different. So I'm not looking on this side, I'm looking at this side. So this cat or dog, is it cat or dog? Dog. Some people prefer a
fox.
Or is a wolf? Yes, it could be a wolf. Yes. So blue-eyed wolf versus black-eyed wolf, whatever it may be, the talk will be on subcutaneous ICD versus transvenous ICD. And it is a long journey, and ultimately the first talk of leadless pacing merging with touching the heart, treating the heart without touching the heart, that is subcutaneous ICD. And there are a lot of studies in favor of doing subcutaneous ICDs. The biggest problem is inappropriate shocks and the longevity. Now, if you have heart failure, diabetes, renal disease, COPD, anticoagulant state, very obese patient with a transvenous pacemaker, or you have existing, that pump catheter, dialysis line, or SBC interventions, obviously the transvenous ICD will cause some problem, but expert like Dilip or Arindam can do any cases, can dilate the superior vena cava, can put a stent, can do the shock waves of the superior vena cava to open the shock waves can also be applied for obstructed calcified vena cava system. The biggest debate in 2025 onwards whether non-ischemic cardiomyopathy should get ICD as a primary prevention, and in post-MI patient, whether you should wait for 40 days or 3 months because the medical therapy like ACE inhibitor, ARNI, beta blocker, MRA, and SGLT2, also GLP-1 has done so much, especially this 40-50% ejection fraction group. But for the timing, the guideline varies from transatlantic domain like Europe versus America, whether it is TAVR or it is diabetes or the hypertension, there will be no alignment of the class 1 indication and class 2 indications. So class 1 indications for ESC, ICD therapy is recommended in patients with CAD, symptomatic heart failure, ejection fraction less than 35%, despite 3 months of OMT. And always we quote about our Ravinda or Sir when they talk about ICD, they quote SCAD-HEP trial or MADI trial. These are 25 years old trial. That time there was no ARNI, hardly any beta blocker. So perhaps the need for ICD has come down, but definitely some people do need this kind of ICD, especially a genetic variant of tachycardias, ventricular tachycardias. So Profit era trial and Contempo ICD trial will look into this controversial area of ischemic cardiomyopathy, non-ischemic cardiomyopathy. We have only one trial, Danish trial, done in only Denmark. Long time ago, there is still controversy whether 68 above should get, should not get. Now, yesterday there was a publications that in non-ischemic cardiomyopathy, if you have a circumferential fibrosis rather than whole fibrosis on MRI talk, perhaps the mid-circumference on your posteroseptal or your septal area of fibrosis is much more important than your inferior wall or anterior wall fibrosis. So those kind of new informations are coming. The Achilles heel of doing ICD is the infections, inappropriate shocks, and the no ATP. So having a pacemaker like wireless pacemaker which can give ATP like future generation, but without a backup of ICD, this ATP can degenerate in 8 to 12% cases into ventricular fibrillations. So ATP with SICD is possible now. And the size of the pacemaker infection, whether you have this leadless pacemaker, smallest size, then you have conventional single chamber, then you have double chamber, then you have a CRTP, then you have a CRTD. So the size is increasing. At the same time, the infection is also increasing because of the volume of foreign body is also increasing. So in the segment of subcutaneous ICD, we have two companies, Medtronic and Boston. The first experience, we had 4 cases of subcutaneous ICD, usually young patients, all are young patients who had monomorphic VTs, and this is for secondary prevention, not a single patient for primary prevention, but those who are primary SICD from Boston in the axillary area, or a substernal EV-ICD, which will be coming, as Medtronic has told us today, in the month of March. So this Medtronic one can give you a 40 rate of pacing, unlike your Boston one, anti-tachycardia pacing more than 200, even loop recorder, 12 years battery. You know, this Boston battery do not last so long. 40 joules shock and volume 33 cc. And you know, if you have subcutaneous space or touching heart or treating heart without going inside the heart, so treating heart without touching heart, less systemic infections and easy to remove the lead. Like if you have ICD lead which is infected, even after using lasers, it's very difficult. And sometimes, you know, you have this SBC syndrome or obstruction. And the pain from shocks, we still do not know why the ICD gives pain so much. Of people think it is energy, it's not the energy. So painless ICD is also the future. Now most of these subcutaneous ICDs are done under general anesthesia, but people have started using soda bicarb and 1 cc adrenaline, 12.5 cc of 8.4% of soda bicarb with 50 cc lignocaine infiltrate in the substernal area and axillary area. The subcutaneous ICD is usually put on those areas. So these are the tools from the Medtronic, and ATP is delivered like this. Initially, we put the patient on the table, then on the lateral and on the AP, we try to have superimposition of the device on the maximum volume of the heart. So on the lateral, if it is occupying almost 50 to 70% of the heart, that is the best position. Then you give a pencil marking, and then you go for. So this is basically EV-ICD borrowed from IBHRE. Now, you give anesthesia, you make a tunnel, so there is a tunnel there. Now, if you have a bypass patient who has got, this tunnel suture, it will be very difficult to go there. But if you do not, or a patient needs immediate bypass, like if you need something substernal to be done, then perhaps you should avoid this kind of technology. You should be going for routine transvenous. So this biplane or a moving plane will tell us that whether you're going absolutely on the substernal. So anything deviating from the sternal on the lateral border towards the other side, you should redirect, come back, or so those kind of movements or directions can also be done on fluoroscopy, did not need any cath lab. So once it is done, then your lead is placed there. But unlike your subcutaneous ICD from Boston, the tip is not tied. But there is always an apprehension of atrial oversensing and some displacement downward, not forward. So we can recorrect. Now once that is done, then the lead is inserted through either a, that routine pacemaker pillow sheath, or there is a dedicated sheath. So they will give two sheaths. If the two sheaths are broken or kinked, usually the pacemaker, this pillow sheath will work. So there are rings and coils which can be programmed, and the axis we can determine on the table. So like any CRT, these axis minimum energy requirement. But the only problem is all subcutaneous ICD, you must have DFT. The DFT you have forgotten from transvenous ICD, but it is mandatory, so far it's mandatory in this group of people. Now, leadless ICDs, like you have, not leadless ICD, like you have left bundle branch ICD has been talked, and this is 6.8 French, DF4 lead, 10 French CSP dedicated sheath, and this is the first case in the world. This is the second case in the world. So these kind of leads, they have a different single coil. The length has also been reduced, the coil length, so that it doesn't traverse into the right atrium to avoid inappropriate shocks. And ICD leads fracture is very less. Infection can happen. You can remove. Unlike your transvenous ICD, you can use the same pocket after it heals. So medical therapy has improved, so there are newer data that inappropriate shocks has been reduced tremendously by using artificial intelligence. Still it is high, and there are few trials, Atlas trials, untouched trials, and this is the basic difference in the size, efficacy, ATP versus sensing, EGM, inappropriate shocks, all can be corrected nowadays by modern generations of your system, and more and more we are going from, leaving nothing behind. That in drug-coated balloon you say leave nothing behind. But you leave something behind. It's not like leaving nothing behind. Leaving nothing behind means only simple POBA. You don't leave nothing behind. So you leave something behind, but you don't leave nothing behind. The lead has to be there, and it is basically outside the heart. So don't try to look into the venous system, try to think subcutaneous system, go epicardium, and go for ATP-based subcutaneous therapy, ICDs, those who really need, especially in young people. Thank you.
Thank you, sir. Any comments?
Thank you, sir. So any questions? That was quite enlightening.
Oh,
thank you.
This side.
I think adoption of subcutaneous ICD is very, very, less, and maybe cost is one issue, and absence of pacing backup is another issue, and only niche category of patients can be given with a primary VT and, genetic VF.
Right.
That could be the reason. So may we go to the next presentation, sir, and thanks, chairpersons, and may I request Dr. Srasti Kulshrestha, Dr. Mainak, please chair the session, and Dr. Anand Pandey. Arindam is going to present now.
Good evening, everybody. So let us talk on a very relevant topic, battery life. So why it is important? If you see the landmark trials of heart failure, as well as the device, as well as medical management, there has been tremendous improvement. So patients of heart failure, they are living longer. There is no denial of the fact. So worldwide data suggests heart failure with reduced ejection fraction, 5-year mortality is 50%. Trivandrum heart failure registry and our own registries, they suggest 3-year mortality is 50%, but as more and more devices, algorithm and newer therapies are being developed, I'll show you, data. So these are the landmark trials where you can see when a device was used, then you'll not find any 5-year mortality less than 70%. So everybody survived more than 5-year mortality is actually less than 30%. If we put a meticulous device, so people are living longer. So this is one piece of data where AICD was implanted in hypertrophic cardiomyopathy. So you can see there had been too many complications. You can see 5% pocket infection, pneumothorax 2%, 49% inappropriate shock. But many times we forget that this patient, they survived to have this complication. So what is the take home, that if you do a proper meticulous selection of device, they will actually survive long. And if they survive long, they need something which lasts long. So this is these are another pieces of evidence where you can see Brugada syndrome. 176 patients of Brugada syndrome, you can see after 20 years only 8 patients died after implantation of AICD. Similarly, you can see ARVC after 8 plus minus 7.3 years, only 5 patients died out of 312 patients. So 2% mortality, 8-year mortality 2%. So people are living longer. So we need to take care of something very, very relevant, the battery life, because you will be needing multiple replacement. More replacement, more the chances of replacement related complication, infection. You'll be surprised to know chances of pocket infection actually is higher if you replace, during replacement, chances of infection, pocket infection is actually higher. So if you get something which lasts longer, that solves many of the problem. So improving device longevity is vital to minimize the replacement, and that will reduce the device infection, lead malfunction, and also increase the ratio of revision. So what are the important factors which are important regarding the battery congestion? So as more newer algorithms, say for example AICD, we have very, very precise algorithm nowadays. So chances of inappropriate shock has come down. How it is done? The device stores the ECG of the patient, electrocardiogram of the patient, and there is huge storage of data. At the same time, there is something known as background current, and if your parameters are abnormal pacing parameter, impedances are abnormal, then it will consume more battery. So the first pacemaker which was implanted lasted for only 7 hours. Before that, we had, pacemaker with external battery. Now, gradually, that battery life improved. So, this is one person who was very, very vital in doing this landmark job. So, this is one of the, conference in Melbourne in 1971. You can see the 9th International Conference of Medical and Biological Engineers. And here, Dr. Wilson Greatback, he first time proposed the lithium iodine battery. So that was some landmark step forward. So now if you see what is an ideal battery. So ideal battery should be having two part. One part is the lithium iodine battery. Why? Because lithium iodine has low current function. It is very, very appropriate for pacing. So at the same time, if you need defibrillation, that requires higher current. So what option you have? You have lithium, selenium, vanadium oxide, or you have something known as lithium manganese dioxide. So these are the different, composition of the battery. You can see there are some low power, medium power, and high power. So in medium power, you'll find lithium manganese dioxide has been mentioned, whereas in high power, lithium silver vanadium oxide, that has been mentioned. But the problem with lithium silver vanadium oxide is that after 5-6 years, when the battery tries to reconfigure or we do capacitance charges, then it takes more time and the discharge of battery is actually higher. I'll show you data. These are different, manufacturer. You can see probably apart from Sorin nowadays is not available. Very soon it will be available again. Otherwise, probably we are all using all this company. These are all, different manufacturer, what they are actually using for their battery. And we all know the longevity of battery of all the devices are not same. So this is one of the published paper. You can see it was published in 2018 in Europace. The longevity of the battery, you can see on the top line, Boston Scientific, St. Jude, then Sorin, then Medtronic. Why it is so? And these are different factors in the same paper. They try to figure out what are the factors which is responsible for battery life of the patient. So percentage of patient, battery parameter, impedance, at the same time manufacturer. That means something to do with the manufacturing of the battery, what material they use. That was also very important. And you can see the battery longevity from cardiac resynchronization therapy, defibrillator, CRT-D. Here, another very important thing which came up from the same paper, that whatever battery life which is shown during interrogation of the device, that does not exactly replicate the same. You will see that the battery life now it is showing 8 years, then 7 years, suddenly it can change. Suddenly it can change to 3 years, 2 years. So that is very, something very, very controversial. In fact, I'll show you where people used to call it a scandal. At what point of time the battery should be replaced. So longevity of implantable cardiac defibrillator is extremely important because as of now, in none of the country, they come up with lifetime warranty. So none of the, defibrillator, be it either AICD or CRT-D, they come up with lifetime warranty. So it's extremely important to understand how long your, device is going to last. Fine? So device functionality over years, you can see on the right-hand panel, the size of device has started coming down from 70 to almost less than 27, but due to some development in the algorithm, storage of electrocardiogram, dual chamber nature of the defibrillator, rate adaptive response, this is one of the new thing in CRT algorithm. Almost all the company, they have some form of algorithm to use it. Then combining CRT with AICD, remote monitoring, that comes with a cost. It reduces the longevity of the, more use of ATP. That also utilize battery, ATP, RF telemetry, at the same time, type of battery, and, what make of the battery. Also the newer algorithm of CRT, say for example, multi-point pacing. Multi-point pacing almost reduces 2% extra battery. So you're not supposed to switch it on. So there are, multiple factors which are responsible for the longevity of the device. It is extremely important, more so if you're using something defibrillator function. So let us see why it is important, what are the factors. I already mentioned background current, I already mentioned the storage of electrocardiogram. At the same time, capacitor reformation. Nowadays, the modern AICD, they need to at least twice a year, it has to be done, reformation. It has to be done, whether you require defibrillation or not require defibrillation. At the same time, one reformation that utilizes around 20 to 24 days of battery, which is quite huge. So, multiple factors, telemonitoring. Now let us see what the international guidelines suggest. I already showed you data that all the batteries are not same. This is the NICE guideline. So NICE guidelines suggest they have evaluated, there are around 12 published paper on longevity of the battery. Based on that, out of 9 pointed out, probably if you use manganese dioxide battery, the ampere which you get is higher. It is more than 2, only one manufacturer will provide it. And based on that, this is very, very surprising. Whenever they are, in NICE guideline, they have suggested only one type of manufacturer to use while you are using AICD. So this is international guideline and very, very surprising. In fact, I didn't know about it. When I prepared this talk, I came to know this thing happened. And NICE guideline is a very well-known guideline. You can see, as per this guideline, based on 9 independent, research, they proposed only one type of battery, only one manufacturer of the battery. So why? Because of the economical data, replacement-related complication, and real-world device longevity. Based on this factor, they propose this algorithm, and as per NICE guideline, you are supposed to use one. There are more, device, more evidence. So pacemaker battery, I already mentioned, when you are supposed to replace, there is many confusion. So this is very relevant whenever you are choosing your battery, particularly for, defibrillator function. You should be very, very careful. I should stop here. Thank you very much.
Oh, thank you, Arindamda, for your excellent presentation as usual over here. Oh, I would like to know just one thing, that would you always recommend to go for the programming of this device implanted patient in a customized fashion? Because what most of the times is done, these programmings are done so much randomly without our supervision, because each device is just like a medicine to each patient. Each patient's lifestyle is different with respect to the age and his day-to-day life activities. So would you recommend to extend the battery life of the patient's device with respect to patient's age and physical activities and other disease comorbidities keeping in your mind, to go for a programming properly?
Yes, this is very relevant because we all, try to adapt tele-monitoring of the devices, but now it is well-known fact that if you do routine tele-monitoring, it will use up some of the battery life. So I, in fact, do not recommend for majority of my patient. In fact, in my hospital, none of us are actually doing that, the routine recommendation of telemonitoring. Similarly, what I follow in my practice, initial 5 years, I only do one programming. If everything is fine, only one programming per year. So that is more than sufficient. In fact, I have seen many people like Dilip Da, I have seen him doing one programming in 2 years. So if you do it in the initial part of the battery, that is fine, because somehow it is good for the patient. They don't need to come for the routine follow-up to the hospital. Other things can be taken care of. If there are no other factors, then you can do it, and that will also reduce the consumption of battery to some extent. Too many interrogation. I have seen people doing 3 monthly interrogation, 4 monthly interrogation. It may be relevant for some of your CRT patient who is not responding. But routinely, it should not be done.
Absolutely. So absolutely right. Because most of the times this battery decay is to some extent exponential nature at the later part of the life.
Yes.
Initially, it is more of a horizontal curve.
Any comments, Trustee Anand?
So basically, how telemetry is helping in prolonging the
telemetry is good for some of your patients who are very old. They cannot come for routine follow-up, and who are living farthest part of the city. So for them, I think it is appropriate. But otherwise, I don't see in a country like India, telemetry is going to be 100%.
So the home monitoring system, or what we call the remote care. Remote care has ample of evidence that it reduces mortality. There is a mortality benefit. So there is always a debate where you protect the battery or to go for a mortality benefit. This is a class 4 indication for last 20 years. So let's not get into that, but even then we have to customize. That's very important what Medica and Arindam told.
Just one line. Don't you think the use of beta blocker is also important to improve the battery life? In CRT, if you use beta blocker or ivabradine like molecule, which will control the heart rate, would it translate into prolonged battery life?
Yes, theoretically it sounds very good.
Theoretical and practically is possible.
I also agree with you, but I am not aware of any clinical trial or evidence whether using beta blocker, not using the beta blocker has increased the longevity of the life. So, Ashish, can you throw some light? I am not aware of any study or trial.
As far as the direct relation is being concerned, we avoid atrial pacing in such situation in CRT. If we use beta blocker in higher doses so that the sinus rate will come down and the patient might have atrial pacing, in that situation battery might deplete. So that is my perspective. I don't know any trial or something, some other evidence.
Thank you.
I would like to add just one sentence. That a few years back there was one publication in European Heart Journal, particularly in AICD implanted patients. If propranolol was used in one group, it was found that the number of shocks delivered was relatively less. So if we can decrease the number of shock delivered, then probably will be increase the chance of battery longevity in ICDs. That was
Absolutely,
one I can remember 3 or 4 years back, I think.
If we give a patient ICD, obviously the patient will get a beta blocker.
Yeah.
Yes, so that is a question.
Specifically propranolol they have found with respect to other beta blockers.
Okay.
How to?
Ampere hours. They look for the ampere hours and they do. Yeah.
that is true for silver vanadium oxide battery. They have, a typical feature that after 5 to 6 years, suddenly the battery life shows very less.
Surandan, hotel guys will come after us now. It's 6 o'clock. So let's go ahead with the Gopal. Please
Thank
come for presentation. You have to have quiz also. You have the quiz master. Yeah, unfortunately I did.
Good evening, everyone. So, thank you, Dilip da, for organizing the device update and inviting us. So, I'll show you one unique case of left bundle area pacing. And in my center, there is no EP catheter or EP system. So, I have to do in fluoroscopy guidance only. So, a 72-year-old lady, she presented in the emergency with a history of chest pain and generalized weakness, and unable to move from one place to another, even not able to go to bathroom also because of the weakness. And her, on taking a history, her husband died few months back, and son died recently in an accident. So her blood pressure was 70/40 in the emergency room, although maintaining the saturation well. This was the ECG. Not good picture, but it's clearly there is a AV dissociation, and ventricular rate is very lower, so it's a complete AV dissociation. And immediately started on isoprenaline infusion, and with the isoprenaline infusion, we were able to do an echocardiography. So this is the A3C view. This is a two-chamber view. So showing the basal septum probably moving, the apical septum is not moving, and there is some ballooning in the apical part. So biochemical parameters showing creatinine was higher, urea was 79, so, and patient was started on injection noradrenaline, and we put a temporary pacemaker. So here our decision was whether to go for a CRT or a CSP. As the patient, correct sir, with complete heart block. So creatinine was...
How you diagnosed it as Takotsubo? How do you diagnose it as Takotsubo?
No, so here the creatinine
till now you have
was
not
high,
diagnosed.
patient
Till now you
was
have the DCM.
clinical, yeah,
Till now
only
it was
clinical.
DCM. Yeah.
So at this point, whether my point was to go for CRT or CSP. CRT because patient was restless, or temporary pacemaker, or noradrenaline, and so here I choose conduction system pacing would be easier for me. So under fluoroscopic guidance, so we put a lead. So this is the initial screwing point. So typically W pattern wave seen in the V1. So at this point we further move, screwed further, and this is the final result, unipolar connection at 5 volt, showing a typical RS R' pattern in V1, and there is discordant AVL AVR, and a relatively positive lead 2 and relatively negative lead 3. So probably posterior fascicular capture. And this is the final picture of the position of the leads. This is the RAO view. This is the LAO view. So that lady came for follow-up at 3 months. This is the ECG at 3 months. And surprisingly, this is the echo. I do not have the image, only the images are available. So LV function become absolutely normal, and we can see the lead position here. So this is a classical case of Takotsubo cardiomyopathy with conduction system disease, AV dissociation. This is a very rare condition, and although literature showing the prevalence is almost 0.7 to 2%, the conduction system disease in Takotsubo cardiomyopathy can happen. So in this position, decision on permanent pacemaker implantation are made case-to-case basis, and if properly selected, LV pacing could be an option here. Thank you.
I have one question. When the patient came for follow-up, did you do the interrogation? pacemaker interrogation?
No, sir, interrogation, no. I have
How
not
much
done.
dependent patient was? Was it, she
She
was
is
being
in
paced
follow-up.
or it was, she was like, what was the V pace percentage at follow-up?
Just show the ECG, that was at follow-up ECG.
Why are you saying that, Akaso? Why isn't like you have done the left bundle pacing and patient improved DCM? It 3 months, yes, I have seen 3 months, 6 months time, patient improving like anything. Emotional stress and everything was there, I can understand, but you should not underplay your magic of a treatment also. It could be equally contributory, isn't it? You don't have any evidence?
I think it's the most interesting case in device update program today. It's thoroughly enjoyable. I really loved your case. A beautiful case. You must report it. Now, why it is Takotsubo? One is sudden presentations. Second is hypotension. Usually, complete heart block patient will have hypertension. You know, they never go into hypotension. Complete heart block hypotension means inferior MI. Complete heart block hypotension means large anterior MI. So MI with hypertension, complete heart block with hypertension, complete heart block without hypertension, two different meanings. The rapidity of your this LV improvement goes in favor of Takotsubo. Second, it has a typical, this shape of basals is moving absolutely normal. But it would have been much more interesting if you have done one angiogram. In spite of having small dye would have made the thing, because that will be criticism. If you have demonstrated absolutely normal coronary angiogram, then people will say, okay, it is Takotsubo or dilated cardiomyopathy. So, the history, but if you have some genetic markers now, I'm sure genetic markers will be negative. If the genetic markers are positive for dilated cardiomyopathy or hereditary cardiomyopathy, perhaps it goes in favor of dilated cardiomyopathy. But again, it is a controversial. My bet will be on Takotsubo cardiomyopathy.
Thank you, sir.
Thank you, Gopal. So we can move to the next presentation, Dr. Sudipto Mandal, then we have Dr. Mainak, then Dr. Srasti.
Hello. Good evening, everyone. Thank you, Dilip sir, for inviting me in this cardio device update to 2025, Kolkata. So I'll present a case in the next 10 minutes. So my case, I titled it as Wrong Side Rhythm Reaper, Epic Triumph over VSD's Lingering Curse. So I'm working in the Mission Hospital as the lone electrophysiologist there. So this is my case, that 14-month-old boy with acyanotic congenital heart disease, situs inversus dextrocardia, perimembranous VSD with more than 2:1 left to right shunt. There is no significant PH or heart failure. Patient was in sinus rhythm with normal AV conduction. And the body weight was 10 kilogram. And this was the pre-VSD device closure ECG. As you can see, there was evidence of situs inversus, as well as there is conduction, AV conduction was normal, and infrahisian conduction, probably it was normal. So the pediatric team of our hospital went ahead with device closure. As you can see, that there is perimembranous VSD, which was closed with ADO2 device. Immediately after VSD device closure and 2-month follow-up ECG was absolutely normal. As you can see, there is no AV conduction delay, or the previous interval was same as compared to the pre-device closure ECG. But surprisingly, in 6-month follow-up post-VSD device closure, the patient developed infrahisian conduction system disease. That there is, we can see, there is complete AV dissociation, and ventricular rate came down to almost 50 beats per minute. And the QRS complexes are of left bundle branch morphology, LBU morphology, and there is complete AV dissociation. So most likely the patient developed infrahisian conduction system disease. We do not know the etiology, but considering there is the previous ECG showing normal QRS duration, narrow QRS complex, and most of the congenital AV nodal disease will have nodal disease, so the escape rhythm will be narrower. So we assumed that this case was probably related to VSD device closure impinging on the conduction system, causing erosion, or device related fibrosis causing the infrahisian conduction system disease presenting as CHV with low heart rate. So we discussed the option with the parents, but parents were requesting that as we already have underwent one microsurgery, can we do another microsurgery and avoid one sternal scar? So I read the literature, and I found that it's possible, and we discussed with the parents, and we went ahead with the endocardial pacemaker in a 18 months, 22 months old boy. So although patient was right-handed, we opted for right-sided approach because we thought it will simulate the process of normal left-sided pacemaker. So we went ahead with micropuncture needle, we crossed it. Initially it was going to the hepatic vein, we were thinking whether it was going into aorta or not, then it went into the left-sided IVC. And we confirmed it previously during the VSD device closure. As we can see from the LV angiogram, that arch was right-sided. So this was confirmed that the wire is in the left-sided IVC. And the wire, once it went into the RV, anterior RV, we confirmed it in the lateral view as well. So then I thought about the anatomy, and I used reversed Mond curve. This Mond's curve we usually give, like left bundle curve, left bundle sheath we will have a natural curve. So we used it in the reverse direction and placed it in the septal region. Although I discussed with the parents about the left bundle pacing in this child, but the economy did not support us. So this was the LAO-RAO, corresponding LAO-RAO view or AP view. As you can see that I have kept significant amount of loop in the left-sided right atrium, and the procedure was done successfully, and on 1 month follow-up the wound has been healed, and the threshold was 0.5. Both the atrial and ventricular thresholds were 0.5. So this was the post-PPI ECG. As you can see, there was single chamber pacing, and pacing was absolutely fine. And relatively narrow QRS, as you can see, compared to the wide QRS in infrazian disease, complete heart block. So before the procedure, the questions which were in my mind, I have written in here. The why late CHB, I discussed this congenital, I ruled out, thinking that probably this is device related. Will he require pacing? Because many patients with congenital CHB will have nodal escape, will have narrow QRS complex, and patient will be absolutely asymptomatic. Patient might not require pacing immediately. So we can follow up and screen them for high risk features in complete heart block. And which modality, whether we should go for epicardial, endocardial, I have kept one slide for this. And whether we should use any special technique, whether we should go for right-sided approach or left-sided approach, Mond's curve, whether left bundle pacing should be used, all these things I have kept in mind. So why I thought this was probably related to VSD device close, the device-related complication, because as I discussed that this is probably infrazian disease and impinging on the conduction system, his bundle. And also it has been reported in many cases that late device-related complication may occur, like 1 year, 2 years, 3 years down the lane after the device closure. The tissue which has been held with the device might get fibrose and contract, and this might cause, for example, in ASD device closure cases, it can drag the aortic rim and can cause aortic regurgitation. In VSD device, it can cause complete heart block. So this is the guideline why I thought this patient will require pacemaker, because the patient 2-year-old child, less than 2-year-old child with heart rate of 45 to 50 heart rate and wide escape rhythm. This is the principal reason why I chose for pacing, because this was wide escape, unstable escape, and the rate was significantly low. And this was the consensus guideline from 2021 PACES guidelines. So it mentions that if the patient has less than 50 heart rate with infrazian escape, wide QRS escape, then we should go for pacemaker even if the patient is child. Though why endocardial, why not epicardial? This debate is still running. But I read about the literature. Then epicardial versus endocardial pacing meta-analysis has been published. That it tells that epicardial pacemaker may be associated with increased pacemaker lead failure compared to endocardial, but the threshold rise, infection, battery depletion, almost there were similar results. So endocardial pacing was relatively better option compared to the epicardial, although most of the centers will prefer epicardial pacing due to difficulty in the difficulty in the endocardial pacing procedure and the future risks involved in endocardial pacing. That I will discuss in one slide probably. So whether in situs inversus dextrocardia patients, whether pacemaker has been done previously or not, yes, it has been done, but in adult patients, like 2 or 3 case reports are there in more than 55 years of age. It has been done from the right-sided approach. That's why I chose right-sided approach and clinically feasible. And it has been done in adult patients. But no cases have been reported till now in pediatric patients in situs inversus dextrocardia. And as I have discussed, I thought about the anatomy. The septum will be in the reverse direction. So we have to, if we use right-sided approach, the opposite approach, we should give the posterior bend rather than the anterior bend in the curve. And recently, most of these 3 studies, most of the studies, case reports have been published in recent years, 2024, 2025, that endocardial left bundle pacing in pediatric patient, even 3-month-old, 6 months old, 2 years old, it is possible, feasible, and clinically safe. So, although I discussed the left bundle pacing, but this was not feasible due to financial issues. So, this left half of the screen is from my previous institute. One patient underwent pacemaker at 6 years of age. After 10 years, the lead got stretched, and that caused lead malfunction and intermittent pacing inhibition and lead noise. So this is to highlight that we should give additional loop to prevent, to allow the growth of the child, so that the loop will be straightened up in future and will be adequately adjusted to prevent lead-related complications. And one article is there from Jack, whether we should keep, what is the adequate loop for children. So they have calculated almost 28 to 52 to 54 patients probably, I forgot exact number. So and they put additional loop and calculated how much additional length will be required when the child gains 18 years of age. So that they have calculated, put on a plot, and they have calculated one formula, so that the radius of the loop can be interpreted, and we can keep at least that much amount of loop. So take home point from my case is, the VSD device closure, whenever we put device in perimembranous region, the aveneural region or conduction system region, we should always follow up with the patient with adequate ECGs, ask for the symptoms, and if the patient is having any anatomical issues like situs inversus dextrocardia, we should have technical modifications. Thank you for kind hearing.
Epicardial way of pacing is very inefficient, I tell you. Many times it loses capture.
Yes,
and,
sir.
And lead breakage is very, very common.
Yes, I have seen my
very thin, hook they deploy there, and then.
I have seen many children having threshold of 3.5, yes, and battery will be drained in 3-4 years. So recurrent.
Endocardial is always better.
Although that meta-analysis did not show, but I thought about it also, sir.
I think which device you used? ADA2.
ADA2, sir.
I think now people have abandoned all the ADA device in VSD. Now yes, people are going for Conord device.
Conord.
Yes. Conord is much softer. The chance of complete heart block. It is Indian device,
Yes, sir. The inventor is from my our alumnus.
Okay.
Suchitra.
So we know what the Conord device is. It can be hooked from both sides.
Yes.
And the chances of complete heart block much lower. Second, have you used steroids? If you develop complete heart block, you use steroids?
On follow-up, sir, we did not.
I know. Most probably, steroids
6 months later, we did not use.
No,
sir.
If you read the angiogram,
yes,
is the coronary, venous angiogram. What do you see? How do you describe this venous abnormality? Where is the right-sided SVC?
That is not there, sir. So it's a dextrocardia, sir.
Dextrocardia, the SVC will change. You said it.
No, sir.
He said left-sided SVC.
Sir, CS will be right-sided.
No. Right-sided SVC must be absent here.
No, sir. If you take from exactly opposite.
Whole SVC will be on the left side.
Yes, sir. Mirror image. For example, for normal patient, LSVC will not be there. So for this patient,
so
RSVC
why did you say the left-sided SVC?
Because it's left side of the patient.
Left-sided ASV is a completely different entity. You cannot say.
No, sir.
It's normal.
Yes, sir. That's why I told left-sided
You
SVC.
said normal SVC. Why you say left-sided SVC?
Because it's left-sided, sir.
Thank you,
Yes.
Sudipto. Wonderful
Thank you, sir.
case,
Thank you,
Wonderful
thank you.
case. Good to have you here. Sudipto is doing good work in Durgapur, na? Durgapur, yes.
So, good evening. Thank you, Dilip sir, for giving me this opportunity to address this august audience. I'm going to present some interesting case. May I have my slides, please? No. This was for the previous, the other one.
I've been telling Mainak to come and join our hospital for so many years.
Please give me, show my slides. I'm not getting over here. Moinak Mukhopadhyay. Case presentation 2. Case presentation 2.
Case presentation 2.
Okay, got it. Okay, so this interesting case, the follow-up thing entirely happened around 5 years back. I was posted in Midnapur Medical College right at then after my DM passed out. And at that point, we had got only an ECG and X-ray and just a stethoscope only for the diagnosis of the patient and nothing else. So this patient present, he is a middle-aged male without any comorbidities, and he was admitted at the local hospital in ER with hemodynamical instability in March 2020, where he was DC cardioverted for some ECG abnormalities and subsequently underwent a coronary angiography which was found to be normal, but in spite of that, patient was advised from anti-ischemic medications. So this was the event ECG, and after the cardioversion ECG, you can see over here, this is a wide complex tachycardia with varying T morphology, more on in favor of AV dissociation with an LBBB pattern of the wide complex tachycardia that goes more again in favor of the below of presentation of the depolarization. So overall, probably we are dealing with an RV apical origin VT, and in the sinus reversal ECG, it's showing the T wave inversion in the 2-3 AVF, and that was the coronary angiography. It was normal, so no need viewing that. So again, there was a further episode of the ER visit at the peripheral medical college in hemodynamical instability. That is when I came across to this patient, and after the initial cardioversion, we went for the evaluation of the patient, and there was no apparent risk factor, no definite family history over there, no substance abuse, and the baseline blood workups and electrolytes were everything normal. So I had got access to a local echo machine, which is a very good echo machine, and I'm very fond of advanced cardiac imaging, and where I did all the 4Ds echocardiography, including the volume rendering echocardiography of the right ventricle, and found that the patient is having right ventricular dysfunction along with ejection fraction lower for the right ventricle. This was again the subsequent month ECG. You can see over here some VPCs. Again, the origin is the RV apical kind with a T inversion in the V1 to V3. So altogether, probably we are dealing with a case of ARVC, which is a bit uncommon, but not day-to-day practice. Sometimes we do come across. So I went ahead with a cardiac MRI to complete the diagnosis and found that the patient is definitely having the ARVD with fibrofatty infiltration in the right ventricle. So we have got 3 major criteria with respect to the presentation of the tachycardia and the cardiac MRI proof criteria and the echo criteria. So altogether, more than 2 major criteria. So it's ARVC. So it's a definite ARVC with the arrhythmia with RV imaging abnormality variant. So the patient was advised to undergo AICD because it is a cardiac arrest survival kind of patient, and avoiding the strenuous activities, patient was prescribed bramiphyl and beta blocker. After 1 year of the first presentation, or rather the AICD implantation was done in the July 2020. It was a COVID era. So 1 year down the line, in August 2021, patient received the first shock. And at that time, although after a single shock, I always tell my patient to go for the programming and the check of the machine, but unfortunately because of the COVID issues and the patient was living in the extremely nook corner of the Midnapur, so it was not possible for him. So around down the line, 5 months afterwards, patient went for the programming, and when I did the programming, I found that everything was fine and it was a properly delivered shock for a VT episode, which was terminated well. So this was the device interrogation done in the January 2022. You can see over here that the impedance and the R wave sensing and everything was fine. But interestingly, again, down the line in September 2022, patient got another shock, and this time some abnormal sound was coming out from the patient's chest. So this is, if the audio was playing, I could have shown you that it's basically, it sounds like an ambulance. It's mostly because of the lead alert sound generated by the ICD. And here, when I did the programming, I found that there was, although that the impedance was fine with the RV defibrillation also, but there was some shocks which was not appropriately given, rather some failed shock also. And interestingly, if you can see over here, there was a very less amount of joule. There was a suboptimal amount of the current generated. And then you can see that just after that lead warning, there was a drop in the impedance of the coil also, or the lead rather. And then it was a Miro MRI device. Then the Medtronic team was contacted and they did all the analysis along with myself, and the entire thing was sent to the core lab because of this abnormal presentation. And it was basically a triggering of ICD short circuit protection, because here the entire impedance and all other things were absolutely fine, but all on a sudden patients got a shock which was of suboptimal electrical amount. This is a very rare troubleshooting or complications of the ICD. It was the incidence of something around 0.003%, and at that time, almost around 8,16,000 implanted device, only 28 case reports were there. So, as per the norm, that the ICD pulse generator as well as the lead both were changed in October 2022, just after 1 month of the proper diagnosis, and subsequently there is this uneventful follow-up. The main reason is because of, in some models they had got this glass feed through, which was mostly related to some abnormalities in the insulators over there. That was generating some extra amount of current, which is why there is sudden activation of this short circuit programming thing, and the patient was not receiving the shock sometimes, or receiving the shock in the lesser amount of current, which may not be effective enough to prevent the VT episodes. And it can happen intermittently also. So the take-home message is that ARVs is an uncommon disease that can cause sudden cardiac death. Cardiac MRI is diagnostic. ICD prevents sudden cardiac death in this group of patients. But the triggering of this ICD, the short circuit protection is an extremely rare phenomenon, and cardiologists must take care of the device interrogation themselves along with the industry people, and continuous and the sincere follow-up of a patient ensures better long-term clinical outcomes and consolidated learning. And this is an extremely high impact case against all the infrastructure related odds at that time that I encountered. Thank you.
Wonderful. It is a occasional one of its kind problem which happens, and I must admit I was not aware about this phenomenon. So very good. Thanks for enlightening us and showing us this case.
Thank you.
Any
sir.
comments? So we can move to the trustee's presentation. So we are at the fag end of our day and the conference. After that, I will be quickly present slides on HCM, and then we'll go for quiz. So what we'll do in quiz, this will be a table A, B, C, and D. Individual can vote. The count, huh? Okay. So yeah, trustee, go ahead.
Sorry, actually, some of the slides are not properly visible. I'll just speak up. This is a case of micra retrieval, which we did in our hospital under the guidance and as a team effort by Dr. Dilip Kumar only. This is a 70-year-old male who had a pacemaker for complete heart block done in 2011. He came to us in 2025, few months back, with a history of couple of months of fever and a couple of weeks of fever with a protruding bulge on his chest and even some granules. So it was probably a pacemaker infection.
This is not the same patient. This is just a, you carry on in next slide.
Yeah. This was the patient's history. He was a 70-year-old male, diabetic, hypertensive. He had a PG change which was done 6 months back, and for the last 2 months he had that symptoms. So when he came to us, he had no history of fever. He was given multiple antibiotics in the peripheral centers. The blood cultures were negative. He was dependent on the pacemaker. And there was a good LV function. So we basically planned to do a leadless pacemaker followed by a lead and PG extraction. So we went ahead with the procedure, and our plan was to first implant the micra, as the patient was pacemaker dependent. He had a CHB, underlying CHB. So we took a right femoral venous axis and implanted the micra. And after that, we checked all the parameters. We checked the fluoroscopic position. The threshold, the final threshold was around 1 millivolt, and the programming was done, and the tether was removed. Just when we were about to proceed with the PG and the lead extraction, we again rechecked the device, the micra device. So at that time, the threshold rose, and it was somewhere around, hovering around 2 to 2.5 volts at the, so we abandoned that procedure of lead extraction and PG extraction, and we decided to monitor the patient overnight. And at that time, the threshold was not really stable, and it was hovering around 2.5 at 1 millisecond of pulse width. So the next day, we had to take a decision that we have to retrieve this micra, and we have to place a new leadless pacemaker before extracting the infected device. So again, we went through a right femoral venous axis, and we took the delivery sheath, the large bore delivery sheath of the micra itself, which is around 27 French, and we took a steerable edgeless catheter, as we can see, and through it there was a large snare which was used to capture the leadless device. After taking certain attempts, the device was captured, and we tried to bring it back into the sheath along with the steerable catheter. But it was not exactly manipulated and became coaxial. So because we wanted to avoid any kind of injury to the intracardiac structures, we brought it down. We brought it down with certain rotatory maneuvers, and we reached the aortic bifurcation, where we gave a rotatory torque, and it became coaxial, as we can see now. It became coaxial and went into the delivery sheath, with which we took it out of the left groin. So this is the final removal. Along with the whole sheath, the whole assembly was moved out of the left groin. Then again, a new micra was implanted in the same way before we proceeded with the final PG extraction and the lead extraction as we had planned. The second micra, it was successful, and we completed the successful procedure of lead extraction too. So this was our case, and the motto with which we presented is, because we are doing a lot of leadless pacemakers, and it is an approved method now. We have the evidence in the micra registry itself that leadless pacemaker in the cases of CIED infection is a very good and approved method, and that's a higher success rate. So we should also be aware what kind of complications we can deal with when we are implanting these kind of devices and doing the subsequent PG extractions. So this was an enlightening case for us.
It was, I think, first case of micra being explanted. In my knowledge, I don't know, it's arguable that whether it was first in India or not, through a snare device. So there are systems by which we can extract your micra through the same delivery system of the micra delivery catheter. You can, at the place of tether, you push the coronary wire, make a loop at the distal end, and then try to capture the cup with the handle of the micra being given torque. So you place there, and then try to capture it, and then finally take the sheath over the micra so that you can capture the micra just like a normal delivery catheter capturing. This was one case where we extracted with a snare. It was riskier because the tines were open, and it was catching something, so it could cause some trauma also. Tricuspid valve also, it caught something. Lead is also catching. So it was all along catching something. Finally, we took the micra out from the left groin, and right groin we proceeded with the same time. Figure of 8, we gave here figure of 8. We proceeded with the next micra, and then we extracted the entire infected part. Patient is doing well and coming in follow-up. Thank you so much. Through Agilis sheath. Inside the micro delivery catheter, Agilis sheath, then there is snare. Just a quick presentation on something which is available now with us, which is not very costly, which we used to feel that was very costly.
Winner may get a dinner with you, that is one good thing. Arre baap. So most people would have stayed back if you had said it fast. So it's a great thing, and I think you can have a dinner with him, Dilip, and learn the tricks of the trade. Yeah, we can download the app or whatever.
So you can just scan the QR code. It'll just come up on the screen. It's just going to flash on the screen.
So there will be 21 questions. Each question has 4 answers. There is no negative marking. You can make a wild guess and you just go on answering and take the enjoyment of the quiz. So I think everybody can join. There is no harm in, maybe somebody will get 10,000 rupees. So who can know that whose luck will be today's?
So I request everybody to please scan the QR code and start joining the game.
So only thing, Dilip, if he wins, what will be the protocol?
I see 9 participants have already joined. I will encourage everyone to
No, everybody should join. I think, I don't know who will get this prize. So that will be a great memento. Okay. Should we go in? Okay. So we go to the first question. There are players to join. Huh? All people have joined?
Okay, I see a lot of names popping up on the screen now. We have some mysterious names as well. We have an SH, we have a T in the room. So I think looking into the history of previous device updates, these mysterious alphabets have a tendency of, catching up on the leaderboard.
15 players are there actually. 16 now.
So should I start?
Yeah.
All right. Okay, so I'll go ahead and start. The first question will be on the screen. And each question has a timer attached to it.
Enlarge and see the complexes. What does the complex 3 represent? Very basic question. Just look at the complex and what are the choices? Choices will come up. 3 choices: intrinsic bit, fusion, pseudo-fusion, PSP. So let us see the correct answer. And that is correct. Pseudo-fusion, which takes place if the stimulus comes in the absolute refractory period. Next slide, next question. Yeah. So where does the resistance to current flow occur in a pacing circuit? Is it the header, the lead tissue interface, or CAN? This is also a basic question. So yeah, majority answered correct. That is the lead tissue interface, and that is because of the big cations that move to the cathode. We have the third question. A 60-year-old lady with VVIR with dyspnea and syncope. So
what is we are seeing here? Undersensing, lack of output, lack of capture, A plus D or B plus C. So, no, basically, its correct answer is there is undersensing plus lack of capture. This one will be the correct. Both. E will be the correct one. E1, E is the correct one.
Got it.
Now it actually duto slides. So yeah, this is the lack of capture and there is undersensing.
I get it.
So this one. So this is a patient who has a double chamber pacemaker and he gets a ischemic CV after this. So what are the possibilities? Intermittent AF, lead malposition, perforation, epicardial pacing. The most perfect answer will be the one that we want. Oh yeah, so it is correct. Lead malposition, that is the answer. I think 3 people have given that. So one of the important thing is, yeah, but ultimately it is the malposition which is, but basically perforating the LV and going to the LV side is more difficult. It is a broader term, and if the lead goes to the ASD and go to the left ventricle, that will be a malposition only. So all quizzes will have something which is close together. Yeah. The next slide. So this is the ASD. This is the lead to the ASD. So you can see that the leader goes to the ASD to the LV. And in the lateral view can confirm. Next slide. And this is one of the differences. Oh, no required. Go ahead. The time is also fast. Yeah. Next slide.
So this is a quick look at the leaderboard.
So
I will head back.
So here is a patient who has a CRT with increasing dyspnea. What may be the cause? AF, LV non-capture, long AV delay, RV non-capture. So look at the complexes. So LV non-capture intermittently, you can see the complexes becoming white, and as we know, the loss of Q wave in lead 1 and AVL and widening of the QRS, that is one of the important signs of lack of LV capture. Next slide. So you can also magnify this image. Recurrent AICD shocks. What can be the reason? Yeah. So go back to the choices. I think you can see the choices in the mobile. Is it? So you have the choices. 4 choices are there. Yeah. So is it a lead fracture, a VF, EMI, or myopotential? Yeah. So if you have very high frequency, high voltage artifacts coming on the lead, then that is one of the very important signs of this lead fracture. High amplitude, high frequency. Next slide. So asymptomatic patient, dual chamber AICD, what is happening? So is it a pectoral myopotential, or is it VF? Is it EMI? Is it diaphragmatic myopotential? Yeah. So we have the correct answer as electromagnetic interference because it is very short, very high frequency but small amplitude. If it was a lead fracture, it would be bigger amplitude. Next slide. Asymptomatic patient, again, with AICD. What is happening? So we have pectoral myopotentials, we can have EMIs, we can have, go to the choices, VF and diaphragmatic myopotential. Which one is correct? So the correct is diaphragmatic myopotential because only the ventricular channel picks up them. In pectoral, both of them will be involved. Next slide. So you have these three different artifacts: electromagnetic interference, lead fracture, and myopotential. If it is in the only the diaphragmatic, that is more to involves the ventricular channel. If it is pectoral, both. And if it is in EMI, it is very high frequency but short duration, usually. And prayer maneuver can take out this. Next slide. So all are to be ensured during the implantation of the pacemaker. That is shown in the ECG. This is a specific type. We are not discussing that. We have discussed from the morning. So what are the different options we have? Next. Yeah. R wave peak time less than 85, R in lead 3 more than lead 2, except QRSD 130 and AVR negative, AVL positive. Oh yes, so everybody has gone through today's device update very successfully. So next slide.
So this is how the leaderboard looks like. We see Dr. Oshesh climbing up the ladder, followed by Dr. SK and the mysterious T in the room.
There is one mysterious. So next, yeah. So what is the location of the lead? RV, mid-septum, LV, left bundle area, and LV endocardium. We have the choices. Yeah, so majority have answered correctly. Next slide. So you can see obviously that R is too much high and we have isoelectric interval between the spike, and so it is a left bundle pressing. Next slide. So what is this device? And this is actually case done from our institute. You can see a sheath coming down. Is it a laser extractor, a tight rail, lead locker, and extraction gun? So all were more or less correct. Yeah, next slide. So this is the actually a tight rail device, and it is different from the laser sheath because you can see the shape is different. Next slide. So what is the impedance of a pacing conductor approximately? Is it 25 to 50, 100 to 200, 200 to 400, 400 to 1500? Yeah. So the question is actually not the pacemaker lead impedance. It is the conductor impedance. So the conductor impedance is very low because it is not the lead interface, that is the lead endocardium interface that has the highest resistivity. So the conduction is very low, it is 25 to 50 ohms. 400 to 1500 ohms is actually the entire lead, including the lead tissue interface resistance. Next slide. unipolar versus bipolar pacing. Which is the correct choice? Impedance is less in unipolar, initial threshold is lower in bipolar, both are equal, threshold falls over time in unipolar. So read these choices correctly. Yeah. So impedance is around 20% less in unipolar compared to bipolar. Next slide.
So let's have a quick look at the leaderboard. It seems Dr. Ashish is again leading, followed by the mysterious T.
So what is happening? And for your clue, the timing of the ECG and EGM is same. They are going same in the time. You can magnify this. Ventricular lead dislodged, atrial lead dislodged, swap, loose set screw. Yeah. So if you look closely at it, whenever there is a pace, actually the V is being paced, so the lead is swapped. So this is lead swap is the correct answer. Next slide. So what is happening? And this is a real case. Look at the electrograms and the positions of the atrial and the ventricular electrograms. Next slide.
Yes.
And here is another clue. So what is happening? We are pacing VVI. We are pacing VVI and look at the ECG. Yeah, ventricular lead has dislodged and come to the atrium. Therefore, you can see the ventricular and atrial signals in electrogram almost simultaneous. And when we are pacing the ventricle, it is pacing the atrium. So VVI is showing an atrial pacing. So ventricular lead dislodgement is the correct answer. Next. Okay.
So we just have 4 more questions to go.
During a programming episode, the patient has severe palpitation. So what it can be? AVNRT, PMT, VT, AT with aberrancy. Near a basic question. So you can magnify this one and see, yes. The ECG is very familiar. So during programming, PMT can occur, and this is one of these ECGs. So this is one of the classic ECG of PMT, and mostly we can change the p-varp for reducing these episodes. Next slide. p-varp. So that is a very vital thing in all these sort of timings cycles. So if the upper rate is 120 per minute, AVI is 200, what is the p-varp? So today we had a talk on the timing cycles also in the morning. Yeah. Yeah, most people correctly answered. Next slide, yeah. So how do you calculate? total atrial refractory period is 60,000 divided by upper rate, that is 120, 500. P-VARP is TARP minus AVI, 500 minus 200, 300. Next slide. Multiple shocks during exercise in a patient of ARVC. You look at and enlarge this figure. Is it an EMI or a lead fracture? T-wave oversensing, response to VT, appropriate response to VT. So there is a small clue, and it has a specific name. This pattern has a specific name. Yeah, very good. So this pattern is specifically called railroad track pattern, and it occurs because of T-wave oversensing. R to T-wave has a specific interval, and T to R has a specific interval. So there are always a long short sequence going on. If you can see in the lower, this is called railroad track pattern. Long short sequence. Railroad track pattern. R to T one type of interval, T to R another type of interval. Long short sequence. Double counting these two beats. So it occurs particularly because in case of ARVC, the R wave comes down, T wave remains the same, and therefore there is a tendency of double counting. It can also occur in other diseases which I have mentioned, Brugada and long QT. Next slide.
Good to see Dr. Abhijit coming up on the leaderboard now, followed by Dr. Sudipto, and Dr. Ashish is taking the lead.
Yeah.
Okay, so this is the second last question.
So we have been talking much of leadless, and this has also been discussed inside. Our talk, many people talked at this one, which is the rate response sensor, acceleratometer, minute ventilation, blood velocity, temperature. Which one? So
Quite a mixed reaction from the room.
yeah, it was very well discussed in the talks. It is actually temperature. We go back to history, and the last slide ends with a historical snip.
Okay, so the last question on the screen.
Who is this man? Inventor of ICD, inventor of pacemaker, inventor of temporary pacemaker, inventor of biventricular pacemaker. Yeah, so majority have answered correctly. So next slide actually. So pacemaker actually Wilson great back, and takes temporary wire is John Hobbs. So let us go to the last scoreboard.
And the final scoreboard for everyone. So Dr. Ashish obviously has taken the lead with 4,990 points, and followed by we have Dr. Abhijit. Can we have a huge round of applause, please? And obviously Dr. Sudipto as well. So Dr. Dilip, I request you to please.
They are asking for a blank check from you.
So the room suggests we have a blank check. I'm sorry? Dr. Abhijit, can we please?
You
Dr.
can
Ashish,
come.
please.
Please come to the dais.
Dr. Sudipto, please. Can we have a huge round of applause for our 3 top scorers in the room? Please join the frame. and the moment finally arrives. Third prize goes to Dr. Shrudipto. Can we have a round of applause for Dr. Shrudipto again? The second place goes to Dr. Abhijit. Can we have a huge round of applause for him? Congratulations, Dr. Abhijit. And the top scorer, Dr. Ashish. Please make it a point to catch hold of Dr. Ashish once he's out of the room. I think we all can get a treat. Congratulations and thank you so much.
Thank you, everyone. Thank you so much. It's, I think, 7:30. We are here. And it's a testimony that how much we like our device update. We could have, we must have done some mistakes. Please forgive us for that. And a word from our senior Prakash Da, just two sentences. We have to keep our steam up and we have to take it to next level. I think device update is a platform where from 10:30 to 4 o'clock it was jam-packed. And 4:35 we had some, people started going out. That is expected. It's a Sunday. But nevertheless, the spirit was on till the last time. Thank you so much, so much.
I think for those who are here, those who are not here, those who have heard us, those who have not heard us, those who have seen us, not seen us, for all of them, the message should go that the device update, which is organized by none other than Dr. Dilip Kumar, has taken Eastern India to a national level, and perhaps our legend is in making. To be very honest with you, our legend is in, he's already a legend, but a super legend is in making. And it is all possible because of your participations from the different device companies, from the pharmaceutical companies, good friends like Amit Malviya. When he's in trouble, he calls Dilip or me. When I'm in trouble, I call Amit, this is the case. Something like that should grow. The friendship, brotherhood, fellowship should grow. We are not here to teach you, already know a lot of things. You're just fine-tuning your skill and knowledge and intuitive, innovative minds. So we are culturing your minds. So through this device update, next year, perhaps we'll see many more newer technology, and hoping for a better crowd next time. So inform your friends that we are progressing in a very fast pace, and definitely it will be to the higher and higher level next time. Thank you, Dilip, and everybody present here.
Everyone who all can be accommodated here, please come. Ashish, please come. Santanu, Srishti, Mitali, chalo aasho. Abhijit, industry friends, please come. We'll have a group picture. Saptarshi, Sovik, kothay? Kothay chalega? Chalo. We will take the picture. Raja, Sanjay. Okay, everyone, please come. Are Amit, please come. Somitro, kichu bolbe? You came for device for first time. Please.
আমি এই প্রথমবার এলাম. I have come for the first time, and I hope it will progress day by day, year by year. And thank you, sir. Thank you for your organization.
Dr. Somitro is doing exceptional work in Vardhaman. I went to his center, and it was a fabulous job he's doing. Amit, any word from you?
I mean, it's amazing experience, and I think it will grow from here further and further. We can make it a really international conference. Maybe we can try together and make it even bigger platform from next time.
We think we can.
Yeah. No, we can do so. It's just we have to think about it. So.
Anyone? Ashish, bolbe?
So what else I can say? Dilip sir, আমাদের সবসময় প্রয়োজনের নট অনলি প্রয়োজন, সবসময় সাথী প্রয়োজনের তো বটেই। তো অবভিয়াসলি lighthouse for all of us. And thank you, sir, for guiding us. And wish you all the best for this program. It will be a much more bigger platform in the next year. We will be hoping so.
And I am so blessed to have so many good friends. Prakash Da is so supportive. Every time we call him, from morning to evening, and I said, Dada, quiz ke paas jana. So, and I think we have elder brother with me. Yeah, I will thank her. Yes, he is already here. On Sunday, she is already here. Thank you, everyone. Thanks to Abbott, Medtronic, Sun, Novartis, BMS, Boston, and all the company which helped me. Thank you so much. Thank you.
There you go.